or to reduce the testing time. So they have used some shortcut. That shortcut is SITA, Swedish Interactive Thresholding Algorithm. Why that word interactive means the test changes as per your responses. It is not same for all. Okay. For example, in a full threshold, there is a 5-second pause. One test, one stimulus comes, after 5 seconds, the second comes. Okay. Let us say you're too quick on your button, like 1 second you press. So when you are doing the responses very quickly, waiting for 5 seconds is a waste of time. So what does the test do? They say, okay, this pan is responding quickly. I'll reduce the stimulus time, the latency. It will reduce it to 3 seconds. It will save 2 seconds per stimulus. That means it will change the speed at which it is presented. Looking at your response, if somebody is going very slow, it will keep 5 seconds only. That is the interactive aspect of this. Okay. Number 2 is, it does not check 422 in SITA. It just checks 42. It doesn't come back with the refinement. So it is slightly a compromise. Okay, but it's okay. So instead of 422, it checks 42. Like it changes decibels by 4 decibels, again checks by 2 decibels, and that's it. It thresholding is done quickly with 4-2 strategies. And the third in full threshold is, it also checks what is called short-term variation. Short-term fluctuation, short-term fluctuation, SF we call it. What is this SF? SF is nothing but intra-test variability of your response. For example, there's a point X. You have checked it. The threshold is 24 decibels. Okay, whether you have done it correctly or not, I don't know. What I'll do is, after some time, I'll again check the point X. Now you will get it as 22. That means the short-term fluctuation is 2 decibels. Right? So it will keep some select points, some 10 to 15 points. It will go and double check just to see whether your responses are correct or not. If your responses are incorrect and you are not a good cooperative patient, number 1, or if you are actually having a glaucoma, the points are sick. This point X is sick. It behaves erratically. Sometimes the threshold is 24, sometimes it is 22. So short-term fluctuations can also indicate that you have glaucoma. Because the point is sick, it is behaving abnormally. Okay, the threshold is not fixed. It is kind of sick. So presence of short-term, so it just checks and says this is the short-term fluctuation, maybe in decibels, 1.2 decibel, 2 decibels. So if the short-term fluctuations are high, the reliability of the test is low, or it also indicates glaucoma. And we have told the pattern standard deviation as the hallmark of glaucoma, because mean deviation is a overall performance of all points. Like if I give you a test, if I take all your marks and take an average, that is mean deviation. Okay. But I told you these questions, 50% of questions are actually out of your syllabus. So everybody would have got less marks. So what I'll do is I'll take that out and again recheck. Then whatever result I get is an actual thing. So what we do is we correct for the, okay, we correct for the generalized depression. So get a localized depression. If the pupil is small, there's a media opacity like a cataract, there's a corneal opacity, you're not corrected for near correction, your overall performance will be very low. Very little light goes into the eye and all the points, the threshold will be less. So it corrects for the common factor and the localized defects will come up. So the PST is a sign of or a parameter for localized defect, which is classical of glaucoma. But this PST is marred by the short-term fluctuation, is it not? If the patient is behaving erratically and varying the response, the short-term fluctuation is a confounding factor. So what we do is we correct for short-term fluctuation, so that the whatever parameter that comes out after correcting short-term fluctuation is called corrected pattern standard deviation, called CPST. This is the ultimate and the most important parameter. If you have done a full threshold only, you get a CPST and SF. In a SITA, it does not check for short-term fluctuation. So no CPST, no SF in the global indices. You understand? So SITA is a compromise. You are not going to do SITA in that man which Okay, she described. Okay, we are not going to do in an early patient. If your patient is already an expert, he has done perimetry multiple times, then probably CETA would help. Or a young patient, energetic, who can understand. But otherwise, always it's better to start with a full threshold. Again, you should have said about SWAP. What is SWAP? You remember it as boy, blue on yellow perimetry. So you have an yellow background on which you put a blue light. The stimulus is blue. What does it do? So you have three types of cones. So it's all about foveal cones. Blue cones, green cones, red cones, right? To simply simplify it. The blue cones are the one which die early in glaucoma. But when you're putting a white light, all of them will get stimulated. So that early death of blue cones is missed because the yellow and red are also firing. So what we do is we want to eliminate those and we want to selectively stimulate and see whether the blue cones are working. If you put an yellow background, this yellow and red cones will get saturated. The green and red cones will get saturated with a yellow background. Then you put only blue light and try to stimulate the blue cones. Okay, 448 nanometers. So then what happens? The blue cones, they respond and that is recorded. In a SWAP, there are certain things that you should know. So SWAP is a test which is done to detect early glaucoma when your standard automated perimetry is normal. Okay. SWAP uses a yellow background and a blue stimulus. Number 3, the stimulus size is size number 5, not like size number 3 as in the standard automated perimetry. Standard automated perimetry, to apply your statistical analysis, it always has to use a stimulus number 3, the size of the stimulus. Whereas here it uses stimulus number 5, a big one. Okay, it flashes stimulus number 5. Then if you see, the overall grayscale shows a lower threshold compared to a normal standard automated perimetry. If you do both, the thresholds values are much better. Performance is much better in a SAP compared to a SWAP. And it is said that this SWAP will show changes around 3 to 5 years prior to changes in SAP. That is the advantage. Okay, but you can't do this test in few cases. Can you guess in which cases you can't do SWAP? Huh? Color blindness, good. So patient is color blind, so obviously this thing doesn't exist. Number 2, cataract. You know, cataract absorbs what light, what color? Blue. So if you got an advanced cataract or significant cataract, your boy perimetry or SWAP is not going to be right. Okay. So this is very important. So if you have color blindness, if you have a cataract, you cannot do these tests. Okay. At the same time, so it would be a good idea to do a SWAP rather than anything else. But having said that, the discussion to start treatment in a glaucoma. Now you all check your this one. Everybody's ready? Okay. So you will, so I'll just give you a small idea. Maybe you have some time in the later part of the day. Okay, I have a neuro-ophthalmology to cover, what is important for the exam, because that is a very favorite of examiners. And from all your nerve palsies, discussion can slip into Horner's, myasthenia, INO, gaze palsies to whatever. Okay, we will discuss all that later. And also about the cases, the short cases, you get entropion, ectropion. Okay, leg of Thalmus, Bell's palsy. These are the cases which they find in the OPD and bring it. It may have a very, obvious entropion, maybe mild also. Okay, it will be just a discussion. So because most examiners know entropion, ectropion well, and this is one area where you have a lot of confusion. There are too many names, too many different schools of thought. Many might have not seen it. Many would have seen different things. So how to, come to some terms with these confusion? What you should know for the exam? And what is the basic oculoplasty? what things you are going to tell in the exam. So let us clear that confusion also later, okay, in the later part. And of course, refraction. So I'll, before the next person starts, so it's about let us say, in that patient, if it's 22, we have to qualify the IOP. So we have to do IOP measurements and multiple times of the day, different days, maybe a DVT, to find out what is the baseline. You do a swap or a SAP or whatever to find out whether the perimetry is also normal. This should be evaluated more carefully. Okay. And you should reason why the IOP is high. So if you rule out all the other causes, probably he's a POAG suspect. So what we call, if there's a consistently IOP is high, 30 plus on multiple occasions, CCT corrected and no obvious secondary cause, there may be a small PXF, we'll never know. Patient may be using steroid cream somewhere every day for last 5 years, you'll never know. So you wrote all that. Then we call him as an ocular hypertension. So ocular hypertension is a situation, it's actually a forerunner of POAG, where the pressures are always outside the statistical normal range with a normal optic nerve head and normal fields. Okay. So if you have an ocular hypertension, see, the discussion should be like that. If such a case is given, so you brand him as OH, then you take a decision to treat or not to treat. We can take a leaf from the ocular hypertension treatment study and to decide whether we should treat this patient or not. I think we'll discuss the details of such things, all the different aspects. This is not important only for the exam, it's also for the real life. Like in different aspects of glaucoma, how do you make a thing? So now we have the bouquet of topics important for the theory as well as for practicals. So we have Dr. Abhishek Baudekar, who is in the department of cornea, refractive, as well as a uvea. He's a combination of a double degree holder, a double fellowship holder. He has got a fellowship in uvea as well as in cornea phaco-refractive. So he will be talking about uveitic cataract. See, there is a patient of uveitis will be a normal case in the exam. And with the digital, maybe the platform coming as maybe a OSCE or something, if you don't have actual case, they will definitely keep a uveitis. Okay, so uveitis discussions can really be very varied. So in that, one of them would be how to manage a cataract associated with uveitis. Okay, so we have Dr. Abhishek, who will be giving you your 10 commandments of managing a uveitic cataract. You want this?
Good morning, everybody. Yeah, good morning. After Dr. KP sir's exciting talk, I hope I don't bore you enough with uveitic cataract. Now, compared to the normal cataract, all of us know that uveitic cataract is not a normal cataract. So I'll be taking you through 10 simple commandments of how you would approach a uveitic cataract and what all are the important practical points. So the first thing is you should determine the cause of the cataract. In case of a uveitis, the cataract could be due to the intraocular inflammation, or maybe the chronic corticosteroid therapy, or maybe a combination of both. Now, the incidence in case of uveitis, the cataract varies from as high as 57% to in pars planitis to almost 78% in fuchs. Especially cases where there is a long-standing or chronic or recurrent uveitis, you would end up having cataract also because of chronic systemic therapy. The second thing, uveitic cataract, how it's different. Now, because in most of the normal age-related or the senile cataract, you have very clear-cut guidelines where how the vision improves. But in uveitic cataract, the improvement of the vision, the visual outcome depends on the underlying diagnosis and presence of vision-limiting pathology and how you have managed the perioperative disease. So, number 3, when do you go for cataract surgery in case of uveitis? Number 1, which is an absolute indication, is a phacoantigenic uveitis. Generally, when a patient has a traumatic anterior capsular rupture, there is some amounts of lens protein into the aqueous and it elicits an inflammation. In this case, it is an absolute indication. Other indications include a visually significant cataract in an eye with an expected good potential. Number 3, cataract that is impairing your fundus view in a case with suspected posterior segment pathology. And number 4 is if a patient is undergoing any concomitant vitreoretinal surgery, and it is important for the retina surgeon to have a good fundus view, then you need to get rid of the cataract. Now, number 4, you have to evaluate why there could be a poor visual prognosis. Now, there are 3 things which are important here: the macula and the optic nerve, and the degree of preoperative vision limiting pathology. Now, most commonly, if there is any macular or optic nerve involvement in the form of cystoid macular edema or maybe an glaucoma, concomitant glaucoma, the post-operative visual recovery may be suboptimal. Most important poor prognostic factors for a good recovery would be a long-standing chronic macular edema, in present also macular ischemia, macular atrophy, or a macular hole or a scar. Optic atrophy and glaucomatous optic cupping is the second, and retinal as a whole, panretinal ischemia, if there is any detachments or presence of epiretinal membranes, these also can hamper the recovery. It is not just this, there are other factors also which can affect the visual outcome. They could be a corneal scar, the presence of band-shaped keratopathy, presence of posterior synechiae, severe iris atrophy, hypotony, vitreous opacities, which also interfere with the quality of post-operative vision. Number 5, what about the timing of the surgery? Now, the best time to operate a uveitic cataract would be when the inflammatory stage of the uveitis has burned out. But most often it is not possible. So the next thing is, when you know that there has been an period of inactivity for several months without any therapy, that would be the next step. But at least in an emergency case, you should have an eye at least quiet for a month. For the sake of examination, you should know that uveitic cataract could be considered early when you are having a mature cataract, or you should have a posterior segment pathology. Now, for a successful uveitic cataract surgery, now this is more important for the practical tip. When the examiner asks, when do you want to operate? You should, theoretically, it is that the eye needs to be quiet for at least 3 months prior to the surgery. The disease should be well controlled pre, intra, and post-operative period. And you should also make sure that the patient doesn't develop any cystoid macular edema because of the post-operative inflammation. Now, what are the risks for post-operative hypotony? Now, most often than not, people tend to make a mistake and intervene in a case of active uveitis. The surgery may be successful, you may have removed the cataract, but then you would be facing a much more important problem, that is post-operative hypotony. Now, you need to know that if the patient is having, these are the few important factors which you should know. Suppose a patient is having a persistently low IOP of 6 millimeter or less, even on minimal therapy, when there is a presence of a seclusio pupillae with a normal IOP, when there is apparent phacodonosis without evident zonular lysis, and if you do a B scan, if you have a diffuse retinochoroidal thickening. These are the 4 important parameters which probably you need to treat prior to the surgery to avoid post-op hypotony. Now, what about the surgical technique? Now, the choice of the surgical technique is best left to the surgeon. Whoever is comfortable with a phacoemulsification should go ahead with that, or else at least a minimally disturbing small incision cataract surgery. The best surgery is ideally phacoemulsification, and the goal of the surgery would be that to maintain the anatomical landmarks and the segment, and you try to restore it to as normal as possible during the surgical period. This is the most important part, which probably would come as a short note for most of y'all. The problems regarding pupil management in uveitic cataract. Most often you know that in uveitic cataract, the iris would be atrophic and it would be floppy. It would be constricted also. So you have an increased chance of intraoperative inflammation and iris trauma. Now, how do you manage? Preoperatively, you can go ahead with topical mydriatics like homatropine or atropine. Intracameral, at the start of the surgery, adrenaline 1:1000 is very good. Use of proper viscoelastic substance. Sometimes you could also do, in a case of small pupil, you could do a mechanical stretching with Kueglen's hooks. Pupil dilatation devices include the presence of self-retaining iris hooks, There may be the Asia pupil expanders. These are the different pupil expanders. The Malyugin ring, and in case of Atmanirbhar Bharat, you have the beta hex. Others, for the sake of completion, with the eye ring pupil and OSS expander. And in case you don't have any of this, the last thing which you could probably consider is doing multiple sphincterotomies. Now, what about the intraocular lens which you would like to use? Now, there had been a 2014 Cochrane review in which they have tested almost all of the intraocular lenses, and more or less in case of descending order, they have found that hydrophobic or hydrophilic acrylic is the best material. Sometimes if you don't have access to this and it's a very poor patient, you could get away with using a PMMA lens. But there is no definite study which tells that any one lens is superior in case of the visual outcome. Most often, if at all you develop any intraop complication like having a posterior capsular rupture, you would think 2 times before putting an IOL in the sulcus or into the anterior chamber. In these cases, it is better to leave the patient aphakic and plan for a scleral fixated lens later on. Now, the last point I have to talk about is the perioperative management. Now, the main treatment or intra and post-operative treatment of uveitic cataract in the management would be steroids, steroids, and steroids. You need to give topical steroids. You can augment with subconjunctival steroids. You can quieten the posterior segment inflammation by using intravitreal steroids. You can start the patients on oral steroids and pulse steroids. Immunosuppression, generally, you would avoid a day or 2 or a week prior to the surgery. If the patient is on long-term immunosuppression, like maybe methotrexate, you would defer the treatment, that dose which is there on the previous Sunday. Now, why steroids are important is we need to know that the most important enemy of the outcome is inflammation. Now, this inflammation can give rise to macular edema, it can give rise to hypotony, it can cause pupillary block, and also it can cause glaucoma. So with this, I would probably end my talk, and I thank you all for your patient hearing.
Thank you, Abhishek. That will be probably very useful for all the postgraduates. I think we'll have a question for a book. So be ready. Will you be inspired by somebody else's answer, or you write, I mean, all at the same time? I don't know. But I think, what is the answer? See, we don't call Webino as paralytic pontine exotropia. We call 1.5 syndrome as paralytic pontine exotropia. I think that is Divya is the first, I think, answer. Correct? Yeah, you are Divya 1 and 2, right? You are okay. You are 1 or 2. Abhishek, I think let's clap for Divya. Okay, okay. Okay, with that, we come to the next talk. See, you always have a fundus case as a venous occlusion, either BRVO or CRVO. Depending upon what the examiner knows, the discussion can vary, greatly. Sometimes it can be only at the superficial level, or sometimes it can go very deep into studies and anti-VEGFs and things like that. So we have our retina consultant, Dr. Giriraj Vibhute, who will be discussing the with the exam point of view, what you should know about venous occlusions, both BRVO as well as CRVO, and what is the points, carry home points for the sake of Viva VOC, as well as if you get a theory question in the exam. So over to Giriraj.
Thank you, sir. Thank you. So we used to discuss before our exams that this is most important topic and second most common cause in India for diminution of vision. So it is very important. One of you will, many of you will definitely get this question in your exams. So when I was in PG, we used to discuss that when we go to conferences, many of the things we don't remember, and we just remember the take home points. So let me start with the take home point itself so that I can grab some of your attention. So people with glaucoma, they are predisposed to venous occlusions. Why is that? In this image, we can see people, glaucomatous cupping. Just a second. Okay. So people with glaucomatous cupping, you can see there is kinking of blood vessels, which makes them more prone for development of occlusion because of compression. So let's start the topic discussion fast because we don't have much of time. So we'll be discussing only about classification, little bit of epidemiology, some cases, and some landmark studies. So classification, as all of you know, this is just a revision: central retinal vein occlusion, hemiretinal vein occlusion, BRVO, and tributary vein occlusion. So central retinal vein occlusion and hemicentral vein occlusion, they behave in a similar manner and they are treated in the similar manner. So they form a group: central retinal vein occlusion and hemicentral vein occlusion. BRVO and TRVO, they behave in the similar way and we treat them in the similar way. So they form one another group. So we'll be seeing all these images again and again. Please play. So this is a very good video to understand. All of you, I'm sure, know the pathogenesis, but just for revision matter, because visual memory is good. So let us just see, because of atherosclerosis, aging, cholesterol deposition and all, the arterial wall starts to enlarge, it compresses the venous wall, and because of which we can see venous stasis and accumulation of blood cells leading to clot formation. Okay, next. Okay. So fast with the epidemiology, both the occlusions are common in people of age more than 65 years. CRVO is more common in males, but BRVO doesn't follow that trend. It is more of feministic. Males are equal to females. Okay. Then case 60. This patient presented to us, 60-year-old male, sudden painless diminution of vision in the right eye, hypertensive, diabetic, has all the comorbidities. Then there is RAPD. Again, one of the most important Viva questions: what is RAPD and what are its gradings? I'm sure you know, weaker than grade 2 initial stall and redilatation, immediate pupillary dilatation forward. So just you can see how the RAPD is checked with neutral density filters. What are neutral density filters? Are basically, they are held in front of good eye to reduce the entry of the light in the good eye, so that we make the good eye equal to the other eye, at which point this stops. That is RAPD. That is grading of the RAPD. So some people would like to ask in Viva, what is the grade of neutral density RAPD that you can judge clinically? So the cutoff is 0.6. So 0.6, if neutral density filter grading is there, if it is beyond that, that is the clinical, then only you can assess it clinically. So this was the fundus picture of that patient, which we just heard about. Then coming to its differential diagnosis. So hypertensive, the patient was hypertensive, diabetic, comorbidities were there, hypertensive retinopathy. How to differentiate it? There were a lot of, there would be a lot of flame-shaped hemorrhages, cotton wool spots. There will be arteriolar attenuation. Venous congestion and tortuosity will not be there. So that is the clutch. Then papillophlebitis, prominent disc edema, less of hemorrhages, more common in young females. Neuroretinitis, history of fever, can be bilateral presentations. Cotton wool spots will be there. Then other DDs are combined venous and arterial occlusion. You can see areas of hypoperfusion in the central part. Then diabetic retinopathy, I'm sure you all know hard exudates more in the posterior pole. And retinopathy with blood dyscrasias, you will know this is not typical hemorrhages once you see many patients, and distribution will not be as a classic CRVO. Then what will you do? You have seen a case of vein occlusion. Patient has presented to you with diminution of vision. Most probably, most likely he will be having macular edema. So you have to get an OCT done to confirm and quantify the macular edema. Then assessment of ischemia and serial monitoring is again more important. So grades of ischemia and an OCT. In grade 1, you can see all the retinal layers. You can differentiate the retinal layers. Grade 2, there is not so much of differentiation. And in grade 3, you will not be able to differentiate anything at all. So this is PMLM sign, a recent development that is prominent middle limiting membrane sign. It is indicative of ischemia. Some people may like to ask about this. It is indicative of ischemia and it is a poor prognostic factor. So if a patient on OCT has PMLM, it is he might be having a little poorer prognosis compared to other patients. So ABC of the investigations, HbA1c, most of the people might be hypertensive, diabetics, then BP and CVS examination, cholesterol, lipid profile. Yesterday I had gone to Bijapur to see some patients. One patient, 65-year-old Ajja, he was a farmer. For the first time he had come to me. He had diminution of vision. No, and he had visited few of the local doctors. Nobody had told him to get his BP checked. Yesterday I checked his BP. It was 200 by 110. Okay, so many of the people here also we see this is the first thing which brings them to doctors, and then they realize that they are having all these problems. So we are the first point of contact for them. So let's not lose any patients because of our poor ability to identify systemic things or just poor neglect. Just whenever you see a patient, just check his BP. Takes 2 minutes, but it will be very good for the patients. So role of FFA no longer used, just historical importance. It is, if it needs to be done, it is done after 3 months or 3 to 6 months when the hemorrhage is resolved. B scan in cases of vitreous hemorrhage. So ischemic versus non-ischemic. So you can see in the first image, the occlusion, the red arrow occlusion site is before the collateral, or let's say another tributary. So there is another way for little bit of blood to go. Okay, the blood flow direction I have shown in the blue arrow. So in such cases, the venous occlusion will be non-ischemic, so that because there is some other pathway which is helping the blood to go. But in the second case scenario, we can see the occlusion is further behind in the optic nerve. So there is no way for the blood to go. So definitely there will be ischemic changes. So all these things most of you must be knowing already. Ischemic is less common. Past middle age, vision will be very less. RAPD is a prominent feature. Fundus picture is classic blood and thunder description. Then site of insult, as I just told you, FFA, this was done in high-res era. So FFA criteria is more than 10 disc area of perfusion. ERG shows decreased B wave amplitude, and ischemia means poor prognosis. Okay, so virtuous triad, and we saw pathogenesis in the video itself. So everybody knows virtuous triad. I'll not waste your time there. So one thing which I wanted to tell you, in cases of young patients, you have to be more careful. Bilateral presentation indicates usually hypercoagulable disease and hyperviscosity diseases. Look for them, keep an eye out for them. Look for infectious diseases, vasculitis in young patients, syphilis, sarcoidosis, Behçet's, eels, etc. Then OC pills use in women. Again, it is a risk factor. Chronic renal failure patients, you know these things. Some things which are protective for venous occlusions. physical activity. So including all of us, we should start more and more physical activity so that we'll be healthier later. Then moderate alcohol consumption. Oh, I can see some of my friends smiling there. Okay, this is just moderate. Okay, but we never drink more than moderate, I think, isn't it? Chalo, next, post-menopausal estrogen, they have a protective role. Yes, sir. So another take-home point which I started with. So again, it is asked in Viva difference between collaterals and neovascularization. Many times it is asked collaterals, they are intraretinal. Then neovascularization, it is extraretinal. On FFA, neovascularization leaks, collaterals don't leak. These are the clutch points. Next, never forget physician reference, strict follow-up. So I'll come to follow-up schedule in the next slides. So treatments mainly include laser, anti-VEGFs, and steroids and surgical treatments. Surgeries will come to that. So what are the things which you need to look for? Whether the edema is recurrent, whether the ischemia is severe, then what is the lens status, what is the IOP? So so that just for your historical importance, some of the surgeries have been tried but no longer used. Intravenous recombinant TPA injection had been tried, not so useful, and risk versus benefit was not good. Again, in here we can see sheathotomy and optic neurotomy was tried to relieve the venous compression, but not very much helpful. The risk was too high and benefit was not so. So next, the greatest risk of developing anterior segment neovascularization. So this is something we need to be looking for. Greatest risk is within the first 7 months. So for the first 7 months, you have to observe the patient every month for this. About 1/3. So there is still hope also. 1/3 of the patients with iris neovascularization and 1/4 of the patients with both angle and iris neovascularization do not develop neovascular glaucoma. So if there is little bit of neovascularization, it's not like everything is lost. Still there is hope. Okay, CRVO, because the entire retina is ischemic, it mainly causes anterior segment neovascularization. BRVO, mainly posterior segment neovascularization. So first 7 months monthly checkup, then high risk cases you can check again monthly. Total observation period should be for at least for 3 to 4 years. Complications can be neovascular glaucoma, TRD, CRD, and optic atrophy can be there later. So this is for you to ponder over. This is anterior segment neovascularization. Nobody should miss this. Again, 55-year-old lady, just to show you these are our own cases. This patient was treated earlier with anti-VEGF, then later with steroids. She improved with steroids. Case of BRVO, again, gross macular edema. For 1 month post anti-VEGF injection, she improved, but she developed recurrent edema. So at that time, we had to switch to steroids. When do you switch over to steroids? When the edema is chronic, when there is ischemia, when you are seeing the disorganization of layers, and when you see hyperreflective foci, which indicate chronic disease. So vessel involvement, superior ST arcade is most commonly involved in BRVO because of maximum AV crossing changes. Then again, as we discussed the classification earlier, FFA mainly to look for neovascularization and CNP areas so that you can target your laser. So let's discuss some scenarios. You have one patient with in front of you. Scenario 1, the patient has no edema, no neovascularization. What will you do? Observe. Okay. The patient has CME, but no neovascularization. What will you do? Anti-VEGF. Again, if there is edema, treat is one school of thought. If there is vision is good or more than 6/9, then you need not treat. You can observe for a month is another school of thought. But many of the studies show early treatment is best treatment. Scenario 3, there is neovascularization but no edema. Then you have to do sectoral laser for branch retinal vein occlusions. Then there is edema plus neovascularization both. First, you bring down the edema with anti-VEGF, then do the laser. So another case, okay, will not go here. This was just to show you the importance of BP checkup again. So some examiners would like to ask this question: what is hemicentral retinal vein occlusion? Just one point you need to remember: if there is dual trunked central retinal vein, then only this terminology comes into effect, otherwise nothing. So if somebody asks hemicentral retinal vein occlusion, dual trunked central retinal vein. Okay. uh, when you call it as hemiretinal vein occlusion, look, either quadrants are involved, either temporal and nasal are involved, then it is hemiretinal. So RVO studies, we used to find it difficult to remember, but it is a necessary devil. We have to remember them. So just you have to by heart, and these are most important in the exam. They will be asked. Branch retinal vein occlusion study, old study. The conclusions from this study: scatter photocoagulation prevents development of neovascularization and vitreous hemorrhage, but it should be applied only after neovascularization development. Overall, in this study, it is noted that if you give laser treatment earlier also, it is not of much help in terms of vision. It may save, it may reduce the edema, but visual improvement will not be there. So consensus is, if there is neovascularization, then only apply laser, otherwise it is of no use. So mainstay of treatment still remain anti-VEGFs. Again, what is in CVOS, frequent follow-up for the first 6 months, score study. Many times it is asked. This study is the one which established role of steroids in treatment. 1 mg, 4 mg, sham group. What is sham group is the question. What is the standard care is the most commonly asked question. At that time, the standard care was observation, do nothing. Okay. Then Bravo study. This is the study for Bravo and Cruise study. They together say that you have to give monthly injections of anti-VEGF and at least for 3 to 6 months, and then later you can go for as and when required. So Cruise, Bravo, Geneva is the study which brought the dexamethasone implant into play. It has established the role of Ozurdex. So just for some people to remember, if there are any Game of Thrones fans here, this is the city of Bravos. If anybody knows Game of Thrones fans, at least for the first 7 seasons, it was useless. Then you can see one cruise there, one ship or cruise you can see there. Okay. Inside that young lady Arya is going. So this is the city of Bravos. You can see Cruise and Bravos are the initial studies. This is going towards Horizon. Horizon is the study which followed Cruise and Bravos into the up to 2 years. Okay. To enter Bravos city, Arya had to hold that coin, golden coin. She had to retain to that coin. Retain is the study which followed Cruise and Bravos for 4 years. Okay. So Cruise, Bravo, then Horizon, and then if you can retain this, retain. Okay. Next. So basically everything tells monthly injections for 3 to 6 months. Then as and when required, further injections, rescue therapy by laser in cases of neovascularization. These are the most important take home points for you. These studies you can remember: Vibrant study, Marvel study is done by our Indian LVPI group. Nobody had done a significant study for Avastin, that is bevacizumab. This Marvel study, because our many patients are poor patients, to help them, bevacizumab is not at all inferior to either aflibercept or ranibizumab. That's what they have proven in Marvel study. So patients who can't afford Lucentis or Eylea, they can go ahead with bevacizumab, but the risk of safety is the only issue with bevacizumab, nothing else. Then just to round up, look whether it is ischemic, look for risk factors, refer to a physician, then don't hesitate to diagnose vein occlusions, then systemic workups, treat. Now I have told 3 times, everybody knows what is the treatment. Then follow up till at least 3 years. It is your duty to counsel the patient to come back for a follow-up, to look for neovascularization and treat. Again, thank you. Fine, I'll end with this. Okay.
So thank you, Dr. Giriraj. How many of you here have not seen Game of Thrones? Hey, there are plenty of them. I think you are still biatting like me: Horizon, Retain, Bravo, Cruise. So, okay, I was thinking I'm the only one in this whole hall who didn't understand what he spoke about, but there are a lot of them with me. Okay, so now with this, so our next speaker, by the time our next speaker gets ready, a next question pops up in the group. Our next speaker, we have with us our own oculoplasty specialist from our own home faculty, Dr. Vinay Sultanpur. He's quite a other than maybe an oculoplasty specialist, the most composed doctor whom I've ever seen. Never seen him getting angry at any circumstance in our OT or OPD. I think that is one of the most important thing which we are supposed to have as a doctor, in addition to the knowledge of ophthalmology. The ophthalmology knowledge already resides him as up to the brim, so over to him. But before that, the question has popped up in your WhatsApp group. So I need the specific answer for this. There are multiple things which are coming up. I need the specific answer, complete answer, not a part of it. So if you have typed something, you can retype it back. If your answer is fully correct, you will be getting it back. Okay, so the answer which I wanted was, who is Dr. Archana? Yeah. So before that, no one has mentioned about that. So let me just explain in a short. This was very important. We need wide-eyed as well as the trapdoor. These were the two important things. See, whenever there is an orbital fracture, you all know that the fracture gets displaced. There is that teardrop sign, the muscle getting incarcerated, all those things. But in case of children, what happens is, because of the elasticity of the orbital walls, so the fracture which is like this, which actually opens up, immediately recoils back. So it actually closes away. So because of that closure, there is not much extensive symptoms that will be more or less like a white-eyed. If you see him, actually you will not see any other symptom. But while closing, it holds back a small amount of inferior rectus along with it. So there is an incarceration. It is like a trap door, white-eyed, with the muscle entrapment. So this small amount of muscle entrapment will actually cause a vagal stimulation, resulting in a bradycardia and hypotension. So the child, actually this had happened to us. So the child had an injury with a ball. The eyes were completely wide, nothing much symptoms were seen, but he was again and again going in for a bradycardia and hypotension. He was referred to an emergency department. He was referred to neurologist. Everything else was done to him, other than people thinking that there could be a trap door white-eyed blowout fracture. So whenever you see a child with recurrent hypotension and bradycardia post injury to the eye, always keep this in mind. It could be a trapdoor white-eyed blowout fracture that is basically due to the elasticity of the orbital walls, which it actually, the fracture just closes, incarcerating a small amount of IR, causing the vagal stimulation. So here's to Dr. Archana. Before that, doctor, so this one, Abhishek. लड़की उठ क्या रही वो उठ गई बस Dr. Archana, yes, this is for you. Thank you. So over to Dr. Vinay Sultanpur here.
Hello. Good morning, everyone. So today I'll be discussing with one of the most favorite topics in oculoplasty as an exam point of view is the contracted socket management. recently I came to know that this question was asked in a previous batch. So it's very unfortunate that probably it won't be repeated for you, but you never know because the most of the questions are repeating. So one should know in detail about the contracted socket, because not in practical, at least for in practical exams, yes, definitely there will be a case of contracted socket, because in for DNB practical exams, most of it will be walking patients. So at least you should know about the contracted socket, its classification and everything, and its management. So I'll be discussing in different headings, because nowadays the questions are asked in parts. Like for example, definition 2 marks, classification 3 marks, management 3 marks. So I'll be discussing with all these headings. So definition, it's a shrinkage and shortening of all or part of the orbital tissue, causing a decrease in depth of the fornicis and orbital volume, ultimately leading to inability to retain the prosthesis. So remember the words for definition, these wordings has to be there, like shrinkage and shortening of the orbital tissue, causing decrease in the depth of the fornicis and orbital volume, ultimately leading to inability to retain a prosthesis. So this is the definition. So what are the factors leading to contracted socket? Like etiology related, like alkali burns, radiation therapy, surgery related, fibrosis from the initial injury, poor surgical technique during previous surgeries like enucleation, evisceration with extensive dissection of the orbital tissues, excessive sacrifice of the conjunctiva and Tennant's capsule, traumatic dissection with within the socket, which leads to scar formation, multiple socket operations, site related like poor vascular supply, severe ischemic ocular disease in the past, cicatrizing conjunctival disease, chronic inflammation and infection. Some implant and prosthesis related like implant migration, implant exposure, not wearing a conformer or prosthesis post evisceration or enucleations, and ill-fitting prosthesis. So the main important is the classifications. So the famous classification and most commonly used is the Gopal Krishna classification. This you all have to by heart all those things. So the grade 1 is there is a shallow lower fornix, shelving of the inferior fornix. The lower fornix is converted into a downward slope that pushes the lower lid down and out, preventing the retention of the artificial eye. So grade 1 is the, just remember, shallowing of the inferior fornix. Grade 2, loss of both upper and lower fornices. Grade 3, both loss of upper, lower, medial, and lateral. All four fornices are lost. Grade 4, loss of all fornices and reduction of the palpebral aperture in horizontal and vertical dimensions. So that is grade 4. Grade 5, there is a recurrence of contraction of the socket after repeated trials of reconstruct. So it's easy to remember. Grade 1 is lower, grade 2 is upper, grade 3 is all the four, grade 4 is all the four with volume reduction and horizontal and vertical palpebral aperture size reduction. Grade 5 is the recurrent case. That is the Gopal Krishna classification. So can you tell which class it is? Hmm? That is a grade 1, because you see there is a lower lid, there is a shallowing. This is grade 4, because you see all the fornices are lost. There is a horizontal and vertical aperture is also less. So this is grade 4 like that. So this is a recurrent case. Next is the Byron-Smith classification. So this is classified as the mild, moderate, and severe. So all are the same, just different authors has given the different names. So this is a Byron-Smith classification. Shallowing of the fornices, usually the inferior fornix. Moderate decrease in the area with or without shallow fornices. Severe is the loss of area and volume. Malignant contracted socket, loss of area, volume, and associated bony contraction. So this is Byron-Smith, mild, moderate, severe, and malignant. Mild is shallowing of the fornices. Moderate is decrease in area. Severe is area with volume. Malignant is with bony contraction. Next one is a Guber morphological classification. So they are classified as anophthalmic contracted socket, ophthalmic contracted socket. That's most commonly chemical and irradiational injuries. Then morphological microphthalmic contracted socket in association with the microphthalmos and microcornea. Then hypoplastic contracted socket, congenital underdevelopment of the bony socket. So just remember the author classification name: Gopal Krishna classification, Myron Smith classification, and Guber classification, right? So main important is examination of the socket. So the pre-op assessment is examination of the orbital area and eyelid is very, very important. Then the tone of the orbicularis and sulcus. Prosthesis fit the size and its appearance with respect to the fellow eye. Area of the socket, assessment of the fornicis, volume of the socket, presence of any chronic inflammation or infection, any cicatricial bands are there, whether the socket is dry or wet, as a dry fibrous conjunctiva may indicate poor vascularity. Movements of the muscles are looked for, associated bony contracture. So this is all for preoperative assessment. So what should you, area, eyelids, tone, volume, then whether it's dry or wet, the movements we should be looked for. Then coming to the management, what is the primary aim of management is to create a socket so as to maintain a prosthesis with good cosmetic appearance. Before commencing any definitive therapy, it is necessary to identify, classify, and eliminate any precipitating factors that lead to contractures. So always the treatment is, its prevention is better than cure. So proper dissection at the time of the initial procedures, like in evisceration and enucleations, preserving as much as of conjunctiva and Tennant's capsule as possible during the enucleations or any procedures. Secured closure of all layers over the implant without tension or superior displacement of the inferior fornix. Avoidance of ill-fitting or roughened prosthesis, elimination of any source of chronic infection, identification of the conjunctival cicatricial disease like pemphigoid or Steven-Johnson syndrome, avoidance of oversized prosthesis to prevent the migration of the implant that causes the obliteration of the inferior fornices. The conformer must be left in place till the all the inflammation is healed. It's usually left for 3 to 6 weeks. If the socket has undergone prior irradiation or chemical or thermal injury, it has to be retained for a much longer time, over a period of 6 months. Major reconstructive surgery should be performed only if there has been no cicatricial activity for at least 9 months. So the treatment: inciting cause, treat initially. If only the inferior fornix is short, the prosthesis is modified. If a more severe contracture, gradually increase the size of the conformer or prosthesis. Once the ocularists achieve the best possible expansion of prosthesis, socket is evaluated for additional surgical procedures. So the cases need oral mucosal grafting, should have mouthwash started at least 2 weeks prior to the surgery. Socket should be always free of the infections. So management: mild socket contracture. So you have to remember this algorithm. This is important. Grade 1 contracted socket, when there is only a inferior fornix is shallowing. So if there is adequate fornix, then transverse blepharotomy with marginal rotation, or we can do skin lamina strengthening. Don't go in detail with the surgical procedure at this stage. Just remember the procedures. If there is adequate fornix, only the transfer blepharotomy with marginal rotation and skin muscle lamina strengthening. If the shallowing of the fornix only, then we have a closed method of fornix repair, shallowing with prolapse fat, open method of fornix repair. Just to remember, closed method is just we are taking the fornix formation sutures over the conjunctiva directly. If there is a fat prolapse, then we have to open it. Why opening? Because we have to remove a little bit of fat. Opening will causes further fibrosis and it will cause a good inferior fornix. So you remember the words: shallowing of the fornix only, closed method. If there is a fat prolapse, then we have to do open method. Then moderate and severe contracted socket, assessment of the socket. If there is a moist socket, then we have to go for mucous membrane graft. If there is a dry socket, then we have to go for split thickness skin graft. Why? As the name indicates, moist and dry, right? I'll be telling it. So partial thickness mucous membrane graft, they are more susceptible to shrinkage and contracture. So full thickness mucous membrane graft, they contract less and obtained with a minimal post-operative complications at the donor sites. The full thickness mucous membrane graft usually taken from the oral mucus of the cheek and lips. It's most common site. We can take it from hard palate, superficial skin, and skin of the labia. The treatment of dry sockets, the sockets is lined with a split thickness graft. It is usually taken from the inner aspect of the thigh and forearm. Then the dermis fat graft is used to correct for the conjunctival and volume deficit in the contracted socket. Currently, it is the only autologous transplant used as the orbital implant in ophthalmic plastic and reconstructive surgery. Then the temporal muscle graft. It's a autogenous dermis fat orbital implantation. There is 30% chance of atrophy of at least half of the graft volume when it is implanted in an avascular graft. That's why we introduce a pedicle flap in the orbit as a vascular bed for the autogenous dermis fat graft. It increases the graft survival as well as the supply additional volume to fill the socket. Transposing a pedicle flap of temporalis muscle into the orbit reduces the chances of atrophy. So you remember the words dermis fat graft, temporalis muscle graft. If there is a horizontal palpebral fissure with the deficiency, then what we call as a switch flap technique, classically described by the mustard A. Here the rotation of the full thickness flap from the lower eyelid to the upper eyelid, and lower eyelid is reconstructed by rotating cheek flap and lining with the composite nasal septal graft. So the management of recalcitrant socket is described by the Dorsbeck and Kalhan. We have to know no other options. We have to completely exenterate the socket, and later on we have to do for a customized artificial prosthesis. Okay, thank you. Any doubts we can discuss? So remember, the main thing is the most of these procedures are rarely done. Means in examination practical point of view, they'll be asking about the etiology, how you prevent it, then the classification, and just the management, right? If you remember the charts, because most of the will be discussing about the mild cases only, no one will discuss about the malignant contraction sockets. So at least remember the definition you have to by heart, classification you remember, and some words like split thickness skin graft, dermis fat graft, temporalis muscle graft. I think you will be overcome through this. Okay, thank you.
So with this, we go to our last two talks, which would be in glaucoma. Again, the topics are very much selected. We are not covering all the topics, only very few topics which have been asked in the exams have been stressed upon. We could have covered everything, maybe ptosis, proptosis, but then they have been covered for you in various other places during your Viva VOC case presentations. Only those which were actually not discussed anywhere have been selected. Now moving to the next one, this is again very commonly asked, and you don't get all of them together in one places, the non-penetrating glaucoma surgeries. To discuss the same, we have Dr. Vijayalakshmi with us. She was a topper for RGHS for her DO, Diploma in Ophthalmology. And post that, she has done her DNB, her fellowship in ophthalmology, fellowship in glaucoma, and now she's working as a glaucoma consultant with us. Maybe we both share a very long bond, and I have seen her right from post DO stages, from the time she's finished her DNB, a very hardworking consultant. Despite having a child of just 1 or 2 years, she never said no for extra hours, even if there are patients who have walked in at around 6:30, 7 o'clock. So again, what I would like to stress here is it is not just the ophthalmology that you people take back from here. These are some small snippets. Why am I stressing them? That's because that is what you people have to take back. Ophthalmology to sab sikha dete hai. These are something extra which you take back. So if you have to extend for the sake of patient, maybe 1 minute, well, maybe half an hour, never say no to that. That's what maybe Dr. Vijayalakshmi will teach you. And the next other thing is the non-penetrating glaucoma surgery. Over to Dr. Vijayalakshmi.
Thank you, ma'am, for the kind words.
So today I'll be talking on non-penetrating glaucoma surgery, which is also called as NPGS, more from the examination point of view. So I'll be telling you only what to write and how to write in an exam. So this could be a 10 marks question. So these are the recent advances. So in a DNB now, I think fourth paper will be on recent advances and all these studies. So more stress to be given on such topics which are untouched and which are less commonly practiced. So NPGS, these are also known as SHEMS canal surgeries, which is the emerging topic now. So these refers to the drainage procedures that restore the aqueous filtration through a natural membrane called as trabeculodesmatic membrane. I'll tell you all what it is. As you all know, the aqueous formation happens at the non-pigmented ciliary epithelium, and from there, through a process called as ultrafiltration, diffusion, and active transport, it is secreted into the posterior chamber of our eye. So the outflow pathway consists of mainly two parts. That is, one is the trabecular outflow, which is the conventional outflow where majority of the outflow takes place, that is up to 75 to 90%. And the one more flow is the UV scleral outflow, that is unconventional, and only 10 to 25% of the total outflow occurs through this method. The maximum resistance to the outflow is at the juxtacanicular tissue and the SHEMS canals. So in these NPGS procedures, we are going to target this site where maximum resistance is occurring. So you can see the juxtacanicular part. That is the part where maximum resistance to outflow occurs and leads to increase in our intraocular pressure. So the techniques involved are the ab-externo-trabeculectomy, the viscocanalostomy, canaloplasty, deep sclerectomy, and laser trabecular ablation methods. We will be discussing each one. So the principle remains the same for all. These are intended to facilitate the passage of aqueous humor through the trabeculum and SHEMS canal, bypassing the juxtacanicular meshwork, which is the site of highest resistance. And in all these procedures, we are not entering the anterior chamber at all. The principal concept is that the flow occurs through a naturally occurring membrane, and which causes the outflow resistance. The whole procedure is performed without penetration to the anterior chamber. Like in conventional trabeculectomy, we actually enter into AC. But here we will not enter the AC at all. So this becomes an extraocular procedure. And this membrane, that is the trabecular-desmatic membrane, it consists of anterior trabecular meshwork and the peripheral desmates membrane. And it targets the presumed site of pathology, as I told, namely the SHEMS canals and the juxtacanicular meshwork. So you all can see here. So this trabeculodesmatic membrane mainly consists of the posterior part of the desmates membrane and the anterior trabecular meshwork. So mechanism, that this trabeculodesmatic membrane, it offers resistance to aqueous outflow. It occurs a balanced resistance. That is, post-op, you don't see the most common complications of trabeculectomy like hypotony or choroidal detachment or overfiltration, or there will be no high IOP also. It will balance both the things here. And the aqueous humor resorption, as in conventional trabeculectomy, you see a post-operative bleb. But here in these procedures, you can see 4 points. That is, first will be a conjunctival bleb, as normal conventional trabeculectomy you all can see. And second will be the intrascleral bleb. Third will be into the subchoroidal passage, and fourth will be episcleral drainage via the SHEMS canal ostium. So the drainage occurs through these 4 pathways. The indications remain open angle glaucoma, glaucoma patients with high myopia. As you all know, trabeculectomy causes in patients with high myopia more chances of choroidal detachment, post-operative hypotony. So those can be avoided in this procedure. Then other indications remain pigmentary glaucoma, PXF glaucoma, aphakic glaucomas, congenital glaucomas, and glaucoma associated with Sturge-Weber syndromes, and glaucoma secondary to uveitis. These remain the indications. Whereas the contraindications relative are narrow angle glaucomas, status post laser trabeculoplasty, where already the trabeculum is being manipulated, and post-traumatic angle recession glaucomas. And absolute contraindication will be neovascular glaucomas. So the ab externo, these are the 4 techniques which I'll be discussing. The first one is the ab externo trabeculectomy. All procedures have a common techniques. That is, first a conjunctival flap is made, which could be a fornix based or a limbal based. Then a deep scleral flap is dissected such that the roof of the Schemm's canal is reached, and then it is unroofed. That is, Schemm's canal's roof is removed first. Then in the floor of the So in the floor of this scleral flap, aqueous leak will be seen once the Schemm's canal is unroofed. Then mitomycin is applied to the scleral flap. And a diamond microdrill is then used to remove the floor of the Schemm's canal. Mainly the endothelium is unroofed. Okay, this is the first technique. Second technique is a deep sclerectomy. That is, a fornix or a limbal based conjunctival flap is made. Superficial scleral flap of 5 by 5 mm is created, which involves 1/3 of the scleral thickness. And in order to be able to dissect down to Descemet's membrane later, the scleral flap is detected 1 to 1.5 mm into the clear cornea. You can see the diagram later below there. Then after first flap is done, a second flap, that is a deep scleral flap, is then created up to 95% of the remaining thickness of the sclera. So you'll be having 2 flaps, a superficial scleral flap and then a deep scleral flap. Then you identify the Schemm's canal. How do you identify? It is located anterior to the scleral spur where there are parallel fibers. The scleral fibers are arranged parallel to the limbus. That's how you identify the Schemm's canal, and it is unroofed. When the anterior dissection is complete, the deep scleral flap which you have made is cut anteriorly, like seen in the picture. Then to avoid a secondary collapse, the superficial flap over this trabeculodescemetic membrane and the remaining very thin scleral bed, an implant is placed. Implant could be a porcelain, collagen, or a reticulated hyaluronic acid. Most commonly used is a collagen implant. Then 2 interrupted sutures are used to suture the scleral flap, like how we do in our conventional trabeculectomy. And conjunctiva is closed here with wet-filled cauteries. And next procedure is a viscocanalostomy. Same, a fornix-based flap is made, then a superficial scleral flap and a deep scleral flap is made. And finally, a finely polished cannula with an outer diameter of 150 micron is introduced into the Schemm's canal. You can see in that diagram. And a high viscosity Helon GV is injected. That is 4 to 6 mm on each side. Higher viscosity viscoelastic substance has to be introduced so that it dilates our Schemm's canals. Apart from dilating, this viscoelastic will also be having anti-inflammatory, antimicrobial properties. So it also reduces the post-operative inflammation and also reduces the post-operative fibrosis. So you can see in our ASOCT, dilatation of the Schemm's canal visualized with US imaging. See the pre-operative and the post-operative images. Similarly, the advanced method of viscocanaloplasty is just a modification of viscocanaloplasty is the canaloplasty. That is, after 360-degree viscodilatation of Schemm's canal, then a microcatheter, a beam-tipped microcatheter is introduced into the Schemm's canal. The diameter of the microcatheter should be about 200 microns. A 10-0 Prolin suture is passed through the entire Schemm's canal and tightened towards the AC, and that further produces a downfall of IOP of up to 2 to 3 mm of Hg. So you can see there is the first image shows grade 0, that is no distension, grade 1 good distension, and grade 2, that is maximum desired distension is obtained with canaloplasty. The last one is laser trabecular ablation. Here we use excimer laser. A circle, you can see that marker, a circle straddling the limbus marked with the help of 4.25 mm optic zone marker is used. Then a corneoscleral incision with a diamond knife is made. Flap is dissected and bent forward to expose the area that should be treated. And a specially designed mask with a 2 by 4 mm window is placed to protect the surrounding tissue from the excimer rays. And finally, laser is applied to the tissue, that is basically the Schemm's canal, and it is unroofed. So these are the 4 techniques, that is the ab externo trabeculectomy, the deep sclerectomy, viscocanalostomy, canaloplasty, and laser trabecular ablations. So what are the complications here? The intraoperative complication would be a perforation of trabecular descemetic membrane, and when there is perforation, you can convert this case to a conventional trabeculectomy and go ahead. Early post-operative complications could be inflammation, which is tackled using antibiotic steroid eye drops and anti-inflammatory agents. There could be hyphema, hypotony, and post-operative increase in IOP. That is when there is no well dissection of trabecular descemetic membrane, you can see a IOP spike post-operative, and that is tackled while doing a ND-AG goniopuncture, something called as we do ND-AG for that trabecular descemetic membrane using a gonio assisted. Late post-operative complications, that is late rupture of TDM, the descemet's membrane detachment, peripheral anterior synechiae, scleral ectasia, cataract progression, and bleb fibrosis and encapsulated bleb. Okay, when compared to our conventional trabeculectomy, the bleb observed in these NPGs is more of a diffuse and a very shallow bleb. Whereas when you see in a post-operative trabeculectomy, the bleb will be more elevated. And cataract progression also is more in conventional trabeculectomy as compared to these, because here we don't enter the anterior chamber only. So the advantages when compared to our conventional trabeculectomies include low rate of post-operative complications, shorter ambulatory care, rapid visual acuity recovery, low post-op inflammation, less cataract formation, and more diffuse and shallow filtering blebs. Limited risk of end-off as we do not enter the eye here. Safe for the end-stage glaucoma surgeries because there are chances of snuff-out phenomenon, and easy post-op follow-up, and it's a closed globe surgery. And disadvantages, it is more difficult, technically challenging, more meticulous dissection is necessary, prolonged surgery time, may need ND-AG goniopuncture, and increased cost and contraindicated in cases of angle closure glaucoma. Until today, our conventional trabeculectomy only remains the gold standard procedure. Thank you. So now we have our last talk in glaucoma, and that would be how to read OCT and GDX charts. Those are very commonly kept in your exams. I think not commonly, 100% they are kept in your exams. So reading OCT with respect to your retina has already been covered yesterday, both in your CPV stations as well as in the chart buster session. So the same OCT charts, reading them for the glaucoma as well as the HRT charts, GDX. So all these charts which are kept. So with respect to glaucoma, reading them, we have with us our consultant, Dr. Priyanka. So over to her for the imaging modalities in glaucoma.
Thank you, ma'am. A very good morning to all of you. So most of you must be like finished with your theory exams and practicals might be remaining. So practicals are very important. Okay, it's not that it's only the cases, but tables are also important. And the examiner usually sees the overall performance. Okay, maybe the cases might be different for you, but table vivas are very important. They are usual charts, everything which you see in the day-to-day OPD, and it is expected that you must know about these. Okay. So what I will be discussing today is the imaging modalities in glaucoma. The first one is OCT, and then the GDX and the VCC. Okay. So coming on to the OCT. So first of all, you must know what is the principle of each and everything. What is the principle of OCT? It is interference. Okay, what do you mean by interference? There are two light rays which are getting superimposed. Okay, so usually there is a reflecting mirror. Okay, the light ray is reflected onto the mirror. It reflects back from the mirror, and one ray is reflected from the surface of the tissues. These two rays are superimposed to produce a pattern which is called as the interference pattern, right? So that is the principle of this OCT. Coming on to the OCT printout. Okay, so this is a OCT printout which you see in the first part. What do you get is the general information regarding the patient, the date and time of the scan. The another thing which is important is the signal strength. Can you see it there? इसमें pointer है क्या? Pointer. Pointer. नहीं दे रहा है क्या? Okay, the pointer is not seen. Can you people see the signal strength there? Just below the exam time, the serial number and the signal strength, the down one, 10 out of 10. So usually the signal strength is from 1 to 10. Okay, if the signal strength is less than 6, then we discard the scan. Okay, we will not take it as a good scan, we will not interpret it, and we will not treat the patient according to the scan. Okay, if it is more than 6 to 10 is considered as a good scan. Okay, what may be the causes of a low signal strength? Okay, so usually it is because of the optical media, which is unclear. Okay, it may be because of the cataract, it may be because of the lens of the instrument. Okay, it may be a dry eye. Okay, so all these causes cause an interference in the optical pathway, and that causes a reduction in the signal strength. Okay, so this is the most important thing which you will see in the first thing. Okay, then the second thing, what is the second parameters? It is a comparison of the right and the left various disc parameters. It may be the RNFL, the cup rim, the cup disc ratio, vertical, horizontal, the rim area, which is compared in both the eyes. Now, in this OCT RNFL, there are 3 false color schemes which are used. Okay, the first false color scheme is the A scheme. Okay, that is the RNFL thickness map. Okay, the third one. So at the 3 number, you can see from 0 to 350. 0 is blue, green color. So that indicates thinning. Okay, that is the thin area. The bold colors, that is the yellow, red areas are the thick areas. Okay, so that is plotted. That is the RNFL deviation map, which is thickness map, which is plotted in the number 2. Okay, usually this is a R glass pattern. Okay, like this. Okay, because the red and the yellow areas will be there in the superior and the inferior areas. Why? Because those are the thickest areas of the RNFL. Okay, so this is the pattern, which is the R glass pattern, which is seen in both the eyes, in the right and the left eye. Okay, in the right eye, in the second chart, you can see there is a borderline. Now, this is the first color scheme. Okay, the false color scheme A, which we said is for the RNFL thickness map. The second color scheme, which is the color scheme B, which is for the chart 2, chart 4, chart 6, and the 7. What is that? Green, red, yellow. This all of you know. Okay, what is yellow? It is borderline. Green is within normal limits, and red is abnormal. Okay, beyond that, there is a white and a gray also. White means it is more than 95 percentile. Okay, what is this? This is the p value. Like whatever is the thickness, whether it is significantly thin or not, this data is compared with the normal data. Okay, so if it is more than 95 percentile, then it is considered as white. Gray is like totally outside normal limits. Okay, so that is the color scheme B, which is used in the OCT. The third is the color scheme C, which is seen in these OCT RNFL graphs, which are the vertical and the horizontal in the 8 and the 9. That is the yellow, red, green, which you see normally in the OCT. Now, coming on to the fourth one. The fourth chart is showing a neuroretinal rim thickness. Okay, it is plotted as red, yellow, and green. Dotted line indicates the left eye. Thick line indicates the right eye. So it is giving you a plotting of the neuroretinal rim thickness in both the eyes as compared to the normals. Fifth one is a RNFL deviation map. Now in these charts, every chart has some importance. If you look at the RNFL thickness map, the third one, what do you need to look for in it? You need to look for any artifacts. Okay, artifacts meaning there will be black spots, means that area has not been scanned. If there are lines which are there, that means that artifact is either the patient has blinked, the patient has moved, and that is why you are getting those lines. So what is the importance? If you get those lines, if you get those artifacts, that means the scan is not good. You cannot interpret the scan even if the signal is good. Okay, so that you will see in the RNFL thickness map. The next is the RNFL deviation map. The RNFL deviation map, you can see a purple circle. So you have to see whether the circle is well centered on the disc or not. Okay, so that will tell you whether the report is reliable or not, whether it needs to be interpreted or not. The sixth one is the most important part. Okay, what is it? Sixth one. What is it called? Have you heard about the term TISNet? Okay, it is a TISNet graph. TISNet meaning TS, T, temporal, superior, nasal, inferior, and temporal. TISNet. Understood? Na? The RNFL, temporal, superior, nasal, inferior, and temporal, is plotted along a graph. It is called as the TISNet graph. As you know that the inferior and superior will be thickest, so you will see two hump like signs, okay, double wave sign, which will be there on superior and inferior side. Okay, so that is the double hump sign or the TISNet graph which is seen. Okay, if it is not there, then that means what? There is a thinning which is there either superiorly or inferiorly. That is why, and it is plotted on the same false B, the color scheme B, red, yellow, and green. Then you have the seventh, that is the quadrant RNFL and the sectoral RNFL. Quadrant RNFL, it is divided into 4 quadrants compared to the normal. What is all these red, green, and yellow are comparisons to the normal population. As compared to the normal population, if the thinning which is seen in the patient is significant or not. If it is significant, how much is it significant? Whether the p-value is 5%, then it will be red. If there is much more thinning. If it is borderline, then it will be yellow. Okay, the 8 and the 9 are actually OCT scans, which are vertical and horizontal OCT scans. Why are these important? Should we see these scans? So this is for any anatomical abnormality. Okay, if there is any disc abnormality or disc coloboma, then all these scans will not be interpreted. If there is a high myopia, if there is a peripapillary atrophy, if there is a vitreous traction, it will cause a false high thickness and it will give you a green scan. That is called as a green disease. Okay, there is something called as a green disease and red disease. You need not know about it. Green disease means the patient has glaucoma, there is thinning, but because of the vitreous traction or a PVD or a V's ring, it is causing a false green value. Okay. So this was one, see, OCT, there are 2 types. One is a Cirrus OCT, which is by Zeiss. This is the most common printout which is available in all institutes. The second one is a Spectralis OCT. Okay, the Spectralis is by the Heidelberg. So this is a Cirrus OCT which is there. Okay. So this Cirrus OCT has one, this chart, and the other is the ganglion cell layer chart. Now, you know in glaucoma, the earliest changes start in the ganglion cell layer, which has been proved now. This ganglion, why? Because ganglion cell layers are the ones which are lost. Okay, and those are the reflections are the RNFL. Okay, so the earliest changes are detected in the ganglion cell layer. So this is the ganglion cell analysis. So again, this will have a first column which has the normal details of the patient, and it will have the signal strength which has to be more than 6. Variation is between 1 to 10. More than 6 is a good value and you can take this. So here also you have a signal strength of 10 out of 10. I know the chart is not that clear. So this is both eyes, right eye as well as left eye. There is a thickness map and there is a sectoral map in the 4th one. And this will indicate, now this is compared again to the normal value in the normal population, whether this value is thick or thin. Okay. This is the sectoral values which are seen in the 4th one. Again, the false color scheme is used. And then you have the average thickness. Average thickness is the average of all the sectoral quadrants. Again, you have the OCT map in order to see whether there are any anatomical abnormalities or not. So these are the 2 scans which can be given in cases of a Cirrus OCT. The 3rd one is the PanTop. PanTop meaning pan. Okay, so a combination of these 2, whichever we have seen, the optic nerve head as well as the macula of a single eye is given in this printout. So it is nothing different. It is the previous 2 scans, only it is of the right eye and it is a combination of the 2. Okay. So first one is the false color scheme A, okay, which has to show the hourglass pattern, which is not showing and there is a bit of thinning. And the next one, you will have there is an inferior thinning. There is a yellow-red inferior thinning, which is seen. Then you have the TISNet graph, okay, and then you have the GCC. Now this scan is a Spectralis scan, okay. Spectralis, how will you, can you see the signal strength here? So how will you interpret whether it is a reliable one or it's an unreliable one? Have you seen? All of you must have seen this, no? So you have seen the Cirrus one. So Cirrus is more common, but we have Spectralis in our institute. I'll just go through the each and every this thing. So first one is the same, but there is nothing, no comment on the signal strength in this. Okay, it's just regarding the patient data, name, age, and whatever is the date of the scan. The the second one is actually a, what is the principle here, which is the red light used? It is the infrared. Okay, the infrared reflectance image is the first one. You can see the blue line in the second one, second image. What is that blue line? It is called as the 4D. 4D is fovea disc alignment. Okay, there has to be a particular alignment of the fovea and the disc. The fovea has to be a little inferior to the disc so that whatever is temporal is depicted as temporal. If the disc is tilted, temporal will go superior and so on and so forth, and you will have a wrong scan interpretation. Okay. So that is 4D. On the this thing, actually it's not visible, it's more clear here. If you see the first image, above that it is written IR 30 degrees HS. What is that? IR is for the infrared reflectance, 30 degrees is the view, HS is high strength or high resolution. Okay. वापस. Okay, the next graph, the second graph of the OCT is showing OCT ART 8 Q24HS. ART is automatic real-time imaging system. So there are certain softwares to acquire the images so that the images are much more clear, the images are much more reliable. So one of the software, whenever the patient blinks, it will not take an image and so on and so forth. So that is the automatic real-time imaging, which is taken care of. That is the ART. 8 is the number of frames, number of clicks that they are taking. It may be 8, it may be 30, it may be 40. Q is the most important here. Q is the quality of scan here. Okay, so it ranges from 1 to 40. Above 20 is a good quality scan. Below 20 is a bad quality scan. Okay, HS is high strength or high resolution. So coming on to this, so third one is giving you just an OCT picture to see whether the anatomically everything is fine or not. First, the infrared reflectance image. The second one, you have to see for any artifacts, if there are any black areas, dot areas, if there are any lines. Lines meaning there is a blink or there is some problem in the image acquisition. Black things means that area has not been scanned, either because of the blinking action of the patient or because of the optical media not being clear, corneal opacity, lenticular opacity, anything. Okay, now coming on to the fourth one, it is similar to the testnet graph. Okay, similar kind of coding, yellow, green, red. And then you have the eighth one is superimposition of both the eyes, right as well as left, so that you can compare whether there is significant thinning in one eye as compared to the other eye. Fifth one is the sectoral and the quadrant maps of the RNFL. Okay. So this is a similar image. Another thing that it gives is the asymmetry. That is the sixth point, asymmetry of both the eyes. Okay, so it compares the quadrants in both the eyes and sees whether how much is the asymmetry it gives you in the sixth chart. So here you can see there is some amount of the superotemporal thinning in the left eye. One more thing is there, if you interpret this OCT chart, what do you people think? Right eye is showing outside normal limits. So is it fine, or is it there's something which is defective? So you have to see and you have to think. Okay, you don't have to think directly in the exam. So if you can see this chart in the right eye, if you see the black line, okay, that is going to the 0 level in the testnet graph. Can you see? It has gone to the 0 level between 270 and 315. Are you people able to see? Can it go to 0? Can the RNFL go to 0? So this is called as the floor effect. Okay, what do you mean by floor effect? Ki even if, so that is why OCT is not a investigation of choice in cases of advanced glaucoma. Okay, why? Because there is something called as floor effect. The thinning of the nerve fiber cannot go below a level of 50 microns or 30 microns. Why? Because there is some connective tissue, there is some glial tissue which is remnant. Okay, so it can never reach a zero level. Okay, so this is something is wrong in this and you cannot interpret it correctly. The RNFL graph should never touch zero. Okay, so this is another, so as we said in this thing, there are two types of scans which we had seen. One was the optic nerve head and the RNFL scan. One was the GCC scan. Now here you have a glaucoma, GMPE. Okay, this is a software which is used in cases of spectralis OCT. It may or may not be kept for the exam. Okay, so this is a GMPE. What do you mean by GMPE? Glaucoma Modulation Premium Edition. Okay, it's just a software. Okay, it actually measures the minimum rim width. Okay, you can see the red line around the disc, that is the BMO, that is the Bruch's membrane opening, and there is an internal limiting membrane. So it takes the distance between the Bruch's membrane opening and the internal limiting membrane, which gives it the rim width. It compares the rim width in all these, how many quadrants are there? 3 into 4, 12 quadrants. Okay, it compares 3 on each side. So in all these 12 quadrants, it will compare the minimum rim width of both the eyes and compare it with the normal and say whether it is borderline normal or it is. So we have discussed about the floor effect. So it will be minimum 40 or 50 will be the neural glial tissue which will be remaining, and below that it will not go. So now we have seen so much about OCT. So how reliable is this OCT? Can you rely on it? Can you start a treatment as per the OCT? If no, why not? So much GMPE module, so much of resolution is there. We can actually see the thinning. We can see whether the signal strength is there, whether there is a good scan, there is no artifact, nothing, no anatomical abnormality. So why can't we start a treatment? The main thing is the normative data. The normal data with which there is a comparison which is done is very small. Okay, it's just like 250 to 500 patients. Okay. So it was this normative database is only of 280 to 300. Now it has become 500 patients. It compares the normative data, that too between the age of 18 to 84. Okay, means below 18 years, again, it is not reliable. Okay, ethnicity, only 1% of Indians were considered for this OCT. Okay. Refractive error from -12 to +8. So beyond this refractive error, there are no normative data which are available. So because of this small normative data, there are many areas which might be normal, which may be flagged as thin. There might be thin areas which may be flagged as normal. So it is not that reliable. So we can just understand that the OCT might be baseline only for self. Only the self, you do a scan for a patient, that is the first scan, and you repetitively do the scan and see whether there is a thinning or not, or the thinning has increased in the same specific area or not. So each patient can be his or her normative database to diagnose glaucoma in difficult situations like high myopias and all. Okay. Actually, there is a progressive thinning of the RNFL with age also. Okay, so this is the progressive thinning. So if the rate is more than this, then it will be considered as significant. So it is minus 0.52 micrometer per year. That is for the average, 1.35 for the superior, 1.25 for the inferior. Okay, so can anybody, so when you want to read a OCT scan, how will you do it? So it is a Sirhis OCT scan of the optic nerve head and the RNFL of both the eyes. The RNFL thickness map shows a loss of the R-glass pattern on the left side that you can comment. Average disc parameters on the left side shows a significant decrease in the average RNFL thickness, disc area, rim area, borderline decrease in the average and the average CD ratio and the vertical CD ratio. Neuroretinal rim thickness is definitely less in the left eye superotemporally, okay, which you can see the red yellow areas. Anything abnormal you can see in the OCT scans? In the right eye? Right eye, optic disc cup contour is normal, or is there any alteration? Anyone wants to give it a try? Is it normal or abnormal? It's normal. So it's not a contour. No? The disc is filled with something you feel. So it is actually a variation. It's a Burgmeister's papilla. Okay, a remnant of the hyaloid artery on the disc, which is giving a false green value in the right eye. Okay, so you need to interpret each and every OCT. Okay, and left eye, it is showing thinning. So glaucoma is usually age related, so usually bilateral and bilaterally progressive. But green disease, this is called as a green disease, means right eye mein there might be a thinning, but it is not getting detected because of the Burgmeister's papilla. What about this? Anybody wants to try? So the signal strength, suppose it's getting covered by this, signal strength is good. So there is a inferior defect which is seen in the right eye. So whether you will take it as a inferior thinning or, so you have to go every map wise. Okay, so first map, RNFL thickness map. Do you think it's normal? Can you see some lines there? Can you see horizontal lines there? Okay, so there are horizontal lines in the RNFL thickness map. Okay, so these are called as artifacts. Okay, whenever you comment on a scan, you need to say there are no artifacts, there are no anatomical abnormalities. Okay, so here you have artifacts. Okay, in the previous scan, you had anatomical abnormality. Okay, so whenever you comment on the scan in the first go itself, you say there is no artifact, no anatomical abnormality, and good signal strength, and then you go ahead. So here you have those two lines. Okay, so maybe the patient has blinked, patient has moved, that is why you get those lines. Okay, and that is why you cannot interpret it, you need to repeat even if the signal strength is good. Okay, if the signal strength is less, then definitely we need to repeat constantly. If it is less, we need to see for the causes. If it is cataract, we need to perform a cataract surgery. After that, repeat the scan. If it is the mirrors of the instrument, we need to clean it and then again repeat it. What about this? Now, this is a bit very small, but if you see the RNFL thickness map, okay, in the lower right-hand corner, can you see a black spot? Okay, here it is not prominent, here it is very prominent, this black area. Okay, this is the area, so this is an artifact. So what the machine does, it scans multiple areas and then it joins the data to create this image. But there are certain areas which are not scanned, which appears black like this in the RNFL thickness map. Okay, so here it is quite significant. Here there is a black dot. So you need to see for the RNFL very cautiously. So that is why this inferior defect might have been there. So we cannot take this graph also. Okay. So this is a significant abnormality. Okay, there is a significant artifact in the right eye which may lead to a superior thinning in the right eye, and that is why again we cannot interpret this graph. Okay, so all of you are clear some concept about OCT. Okay, then another thing is which I have not included is the vitreous traction. Okay, a PVD. Okay, or a vitreomacular traction, which actually will be seen on the OCT graph and which will lead to a green disease. Other eye will be having a red glaucoma, but यहाँ पे green हो जाएगा because it is misinterpreted as a thickness of the RNFL. Okay, coming on to the HRT. Okay, these modalities are very rarely seen, but in case they give it for you in exam, you must know what is the overall view. So this is the HRT2. So there is a HRT1, there is a HRT2, and there is a HRT3. Okay, so this is a confocal scanning laser ophthalmoscopy. A 670 diode laser is used. 15 into 15 degree area. वहाँ पे 30 degrees था OCT में. So there are multiple optical sections which are taken, nearly 32 sections, okay, of the optic disc. And these sections are taken 5 times, okay, sections. It's like sectioning. Sections are taken 5 times, whichever are the most 3 reliable, these are taken to produce this scan result. Okay, so these are the multiple 32 sections which are taken from maybe 6 or 5 millimeters behind the optic nerve coming on anteriorly. Okay. What is the limitation in HRT? You people have, most of you must have read, because of the corona time, you people must have read more, right? You are the batch who must have got the maximum time to read. So examiners will also expect you to know everything. So what is the major limitation of HRT, you think? HRT1 and HRT2, which has been overcome in HRT3. Any idea? So HRT, anybody has read? Or because it's not practiced, nobody will ask. So the main thing is this delineation of the optic disc has to be done by the operator himself. Okay, depending on these images, seeing these images, he has to mark that area. Optic disc ka margin has to be marked by the operator. So it is very much operator dependent, the 1 and the 2. Okay, 1 and 2 mein kya difference hai? 1 is the resolution. First, HRT1 has a resolution of 256 into 256. It is 380 into 380. The resolution is more in HRT2 and it is less operator dependent. Matlab, there are multiple other mechanisms to help the operator delineate the optic disc. Okay, HRT3 is totally operator independent. The machine itself will mark the optic disc area. Okay, so the 32 sections are taken consecutively. There are multiple data points which are analyzed. So this is the OCT the tomography photograph which is seen. Okay, this is HRT1. Okay, tomography photograph is the red one. Red is the optic cup. Okay, blue green is the the disc rim. Okay, red is the optic cup, and this is actually the tomographic image. Left mein jo hai, it is the reflectance image. The amount of light reflected is again given a false color coding, which is this blue brownish thing, and it will give you this image. This is HRT2. Okay, what do you see in HRT2? Again, you have this tomographic image. Red is the cup, blue green is the rim area. Now this is plotted. The first one is the global. Now in this, what attempt they have done is whatever is the mistake by the operator to plot that graph, that can be मतलब थोड़ा बहुत कम हो सकता है. So what they do is they divide this area into 6 areas. Okay, left side you can see 7 ticks. Okay, in all 6 quadrants and 1 in the central. All 6 are the quadrants which are there, and central one is the global one. Okay, why there is a green tick? Green tick meaning within normal limits. Yellow exclamation mark means borderline. Red cross means definite thinning. Okay. So here you have another bar graph. So what is this bar graph? Green area is the rim area, whatever in that particular quadrant. First one is the global one. I think it's not that visible. First one is the global one. Second is the temporal. Third is the superior, inferior, inferotemporal, like that, 6 quadrants. Okay. Green is the rim area. Red is the disc area. Each quadrant mein kya hai? Each quadrant is then compared to a normative database to see whether it is within normal limits, borderline, or outside normal limits. Okay, within normal limits will be green tick, borderline will be a yellow exclamation mark, and red cross will be outside normal limits, matlab definite thinning. Okay, so this is the HRT2. This is the HRT3. Okay, in this you have the right eye. In this, what happens? This is like more of an OCT scan. There are multiple parameters which are studied. If you see that graph in the center, it is showing neuroretinal rim thickness, the cup disc ratio, vagera, all these 6 parameters. Okay, and these are then converted into bar graphs, and you can see that 3 horizontal lines. जो green में लिखा है, that is within normal limits. Yellow is borderline, and top one is outside normal limits. Okay, so more taller will be the bar graph. It will be outside normal limits, and it will be considered as abnormal. Okay, so this is the OCT3. I mean the HRT3. Okay, this is not a purple. It is a yellow exclamation mark, which is borderline. Okay. Coming on to VCC. Okay. So what is VCC? What is the full form of VCC? VCC. So there is something called as a FCC, something called as a VCC. What do you mean by FCC? What is the principle of this GDX? Time हो गया क्या? नहीं. हाँ. हाँ, वो नहीं होंगे तो भी चलेगा. हाँ, हाँ. Okay, so VCC is variable corneal compliance. Okay, FCC is fixed corneal compliance. What is the principle of this? It is birefringence. Birefringence meaning when a polarized light is passing through a material, it will get split into two. There will be a retardation of the light ray. Okay, and this retardation will be proportionate to the thickness. More thick the area, more will be the retardation. Okay, that is called as the birefringence. So this is based on that. Since cornea is also a lamellar structure, it will have its own birefringence, and that will interfere with whatever is the image acquisition. So we need to minus the birefringence by the cornea. In case of FCC, it was a fixed. All patients fixed birefringence was minused. But every cornea is different, every person is different. In VCC, there is a variable corneal compliance, and it will be deducted. Everything different for different patients is the variable. Okay, so it has a good sensitivity. It is reproducible. 780 polarized laser light is used. Okay, this is the splitting which is there. So there is a retardation. Whenever it passes, retinal nerve fiber has that birefringence property. Whenever a polarized light will pass, it will cause retardation of that light. Whatever is the retardation will be proportional to the thickness. So this is a graph of the GDX, okay, a VCC. So in the first graph, you can see it is the pattern of the retinal photograph. You just have to see whether there is a well centration or not. Okay, in the center, there is a graph which compares the Tisnet, the superior average, inferior average. If it is written in green, then it is within normal limits. Yellow, it is borderline. Red is outside normal limits. Okay, this is again interpreted by the inferior graphs. Okay, that is the deviation map, which is the yellow. This is the hourglass pattern which is seen. Below that is the probability. Okay, if you can see, the gray graph, below that you have blue, light blue, yellow, red. So what is the probability that whatever is the thinning, it is significant or not? Okay, so here you are not seeing anything, any squares are not seen, means it is a normal OCT. There is no thinning which is there. Lower graphs, it is compared to the normal. Whatever is the thickness of the green area which is seen on the left side is the normative database. If the graph is following in that area, that means it is normal. Left side, right side, the purple area is the normative database. If it is falling in that area, means it's normal. If it is falling above or below, that means it's abnormal. Okay, so this is the reflection image of the retina. This is the retardation image. How much is the light getting retarded? If it is retarded more, means there will be more thickness, thicker areas represented by bright colors like red or yellow. So you will get an hourglass pattern. So this is the FCC and the VCC technology. So this is if there is a significant thinning, you will see that these red areas, red is P less than 0.5. Okay, you can see downwards, red, blue, light blue, okay, and yellow. So these will be plotted. If it is not plotted, means everything is normal. So this is a normal area. You can see the perimetric graph also on that side, hourglass pattern, and no red, blue spots in the retardation image. Here, there is a minimal inferotemporal defect, okay, and there is a retardation which is seen. Similar here, superotemporal defect, which is a combination of red, significant defect is seen. Bitemporal, superior as well as inferior thinning, significant red. Okay, and this is a normal graph that you can interpret. Right side, inferior thinning, left side, both superior and inferior thinning. You can see the graphs also, which are getting displaced similarly here. So we can do a serial analysis also and see whether there is a significant decrease or not. The last word is, The AO practice guideline on glaucoma concluded that the clinical utility of quantitative approaches to the documenting optic nerve head appearance, the nerve fiber layer polarimetry, confocal scanning tomography, and optical coherence tomography has yet to be established. None of the techniques has yet been shown to be superior to a disc photography for documenting optic disc morphology or for monitoring progression. Thank you.
So your first CPV session actually starts by 11 o'clock. So before that, we have another 5 minutes time. And this is something which I have requested Dr. Purnachandra sir to just discuss with you and give you one small talk on how to read ERG, EOG charts and VEP charts, because now the newest one, our own PGs, when they gave their examination recently, the last batch which passed out, they had an ERG chart which was kept in front of them. It was a simple retinitis pigmentosa, yet our PGs staggered when they read those charts. So now with the curriculum being set quite high, and with all the institutions now having electrophysiology, so I think ERG, EOG, VP, even if they don't have, they are projecting those on your as a soft version, so soft copy. So I think you need to know this ERG, EOG, just how to read what you're supposed to see. At least if you don't tell the diagnosis, but at least read out the chart, whatever it is. If you can just tell 1 or 2 points about it, I think they will go to the next topic. So that should be worthwhile. And we have with us Dr. Purnachandra. Okay. So he has done his MS from AFMC and fellowship from Narayan Nethralaya. Now he's been practicing consultant Vitreoretina department in Narayan Nethralaya, Bangalore. He has multiple researches as well as awards in his kitty. I think one of the very competent and yet a down to earth and humble retina specialist as of now, one of the leading retina specialists in Karnataka. Over to Dr. Purnachandra sir. So after this topic, you will be having a short tea break, and then all of you know which stations you are going to. Your examiners are already ready now. So after the tea break, you can aram se move out to your stations, and please take your bags with you. Don't leave behind any bags here. Patients will be roaming here when you are in your CPV session. So God forbid something happens to your valuables. So for that sake, just take all the bags with you when you're going for the tea session after this talk. Over to Purnachandra sir.
Namaskar. Okay, thank you so much, Deepthi ma'am, for the kind introduction. So, as she rightly mentioned, so electrophysiology, I know like electrophysiology, the moment someone says ERG and all of you feel like running away. It's something alien, it doesn't belong to me. You need not read about that. But that's not true. So before you do anything, not only ERG, anything in life, you need to ask yourself, why I need to do that? So similarly, so why do I need to study and understand electrophysiology? So two obvious reasons for exams. Of course, you want to write, you may get a theory question, or you may be asked few questions in practicals, you need to answer that. And for diagnosis and patient management. So beyond these two reasons, sometimes I know like most of you will be appearing for the fellowship interviews and all, and some of you will be writing FRCS exams. So there you may have some station, you may be asked questions regarding electrophysiology. So answering any questions related to electrophysiology will always give an extra edge. For example, if you have goofed up something about the basics and if you end up answering ERG and all, then examiners understand, okay, this guy or girl knows, maybe she or he was tense in the morning, something like that. So it's very important. So just concentrate forget everything. I mean, not the ophthal part, other personal things, and just concentrate for next 20 minutes. If you know this much, you need not read anything. You will be able to write both for theory exams and you'll be able to answer some of the basic questions which they ask in exams. Okay, fine. So anything which starts with the definition, okay, it's simple. So try to understand the logic and then write the definition. So it's ERG is nothing but it's a mass response for a luminance stimulus, such as light. So what happens when you throw a light on the retina? There will be obviously some biochemical and ionic changes, because you know, like photoreceptor and RP are very highly active metabolically. So it generates electric potential, which is recorded as electroretinogram. That's it. You stimulate the retina, it causes some potential changes which generates action potential, which is generated as electroretinogram. Okay. So then coming to the most commonest questions asked in the examination, origin of waves in a ERG. So ERG basically has got A wave, which is a first negative deflection, B wave, and oscillatory potential. So A wave is from photoreceptors, B wave is from bipolar and Muller cells. Oscillatory potentials usually in present, these are usually present along the ascending limb of the B wave. So we use something called band pass filters to extract them. That's a different thing, will not go there. And most of your Viva will end there. So the reason being, some of the examiners may not know what was beyond this. So if you answer this much, your ERG Viva is over. That's for practical. Suppose if you say like, if you get a question in theory and if you answer well in ERG, they want to give you some extra marks or they want to compensate for whatever you answered wrong in the morning, because usually table wave happens in the afternoon, no, in most of the time. So then what next? So there is something called implicit time and amplitude when it comes to interpreting any electrophysiological test. So the definitions of these are same what we learned in 11th and 12th in physics. It's the same thing. So implicit time is nothing but from the onset of stimulus to the peak or trough of wave of interest. For example, so A wave implicit time is calculated from the, here if you give the stimulus to the trough of A wave. Similarly, for the B wave from here to the peak of B wave.
In the Zoom link, if you don't hold up mic close, it will not be
Okay, fine. So that is about implicit time and the amplitude. Okay, amplitude is measured from the trough of previous wave to the peak of wave of interest. I think. Fine. So next, you learned the definition of ERG. You know how the waves come from A wave, B wave. Now to do an ERG, how do you place the electrodes? We use basically 3 electrodes. So one is the recording electrode, which is placed on the cornea. Okay. And the second is reference electrode. It is placed near the lateral canthus, approximately at the level of retina. So that is reference. Reference near the level of retina. Remember like that, RR. Recording on the cornea. And we place one more electrode called neutral electrode. It is just in the middle, just above the nasio, and you can place it. Understood? Recording on the cornea, reference near the lateral canthus, neutral, just above the nasio in the middle. Okay, fine, clear. And next is you need to write what are the different types of electrodes which are available. This sometimes you can get as MCQs also in your FRCS exams. So there are different electrodes called Baryon-Allen, skill electrode, jet electrodes, and gold foil electrodes. So if you look at the Baryon-Allen, it has got a speculum kind of a thing. So it is preferable to use these electrodes in pediatric patients so that it won't let the child to close the eyes when you give the light stimulus. The second one is skin electrodes, which are used in infants, because infants you can't place the electrodes, no, they won't be cooperative. So it's not ideal to use the skin electrodes because the amplitude and the both implicit time will be affected. So just imagine something recording on the cornea and skin, there will be difference, right? So, but of course, in some clinical scenarios where you don't have anything to, you don't have any other clinical clue from imaging or anything, you can do an ERG by using a skin electrodes in infants. And jet electrode is just like a contact lens electrode, the way we use, which is the most commonly used. And the recent one is the gold foil one, which we use in our institute and in most of the institute. When I was in Moorfield, there also they use the gold foil electrodes. So basically, you place these electrodes in the fornix, and part of it will be touching the cornea. So you just write these 4 electrodes and just write 1 or 2 lines about that. So that should be more than enough. There are some other electrodes like LVP electrode, DTL, and all that. I don't think they will ask you these things. Fine. So clear definition, how ERG originates, implicit time, amplitude, and different electrodes. Fine. So then how do you stimulate the retina? You need some source, right? So what is it called? That white thing? Yes, correct. It's a Gans field stimulator. So which can generate light of desired intensity, and also it can change background color also. Okay. So you can see the electrodes, how they are placed. One on the cornea, one near the lateral canthus, approximately at the level of retina, one in the middle. Okay. Fine. Clear so far? All of you are with me? Fine. So now coming to the a full field electrogram, how to record it. So there are two types of responses what we record when it comes to ERG. One is dark adapted. It is after 20 minutes of dark adaptation. And there are light adapted responses, which is recorded after 10 minutes of light adaptation. So again, there are some subdivisions. I'll go into it in detail. So I mentioned here something called ISCV. These are all ISCV standard response. So there is something called International Society for Clinical Electrophysiology of Vision. They lay down some standards. So wherever you do ERG across the globe, you need to follow those standards. The kind of electrodes you use, the impedance, the resistance in the electrode, the kind of stimulus you use, it all should be standardized so that ERGs done at different places can be compared. So otherwise, before this society was formed, people used to do their own intensity of stimulus, and obviously amplitude and implicit time will vary, right? So these are all ISCV standard electroretinogram responses. So now, if you understood all the basics and the background, so we'll go like how does a normal electroretinogram, full-field electroretinogram looks like. So it starts with a dark adapted 0.01 ERG. 0.01 is the intensity of that is the candela per centimeter square. After 20 minutes of dark adaptation, you have taken the patient inside, and the first stimulus which is given is the 0.01, this thing. And you get a big positive deflection over here. So which represent rod system activity. Okay. So each and every word is important. It represent rod system activity. Rod is a photoreceptor, right? Photoreceptor is supposed to produce which wave? B wave. Sorry, A wave. Here what you are getting is a B wave. So why? If someone can answer. So because at such a low stimulation, the depolarization which happens in the rod photoreceptors is so less to be recorded as a deflection as A wave. So this B wave indirectly represents rod activity. Okay, understood? So it indicates the rod system is intact. From the photoreceptors to bipolar cells, everything should be intact to produce this B wave. And this is an isolated rod-driven response. There is no cone contribution in this one. Clear? So what happens when you increase the stimulus of the light to 3, till in a dark adapted stage? See that now the A wave starts forming. You see this A wave. Okay, now cones also will start to contribute in a minimal way, though it's predominantly a rod-driven response. Again, increase the stimulus of intensity to even more. So the A wave deepens. So this is the combined response. So now here we have contribution from both cones and rods. Okay, started with an only rod-driven response. Now we have contribution from both cones and the rods. Clear? So then comes the oscillatory potential. Oscillatory potentials are from? Whatever, I can't hear. I think I assume you are all telling correct answer. Okay, fine. So oscillatory potential, you don't have much clinical utility. So earlier in the for diabetic retinopathy research, they used to study this oscillatory potentials a lot because their hypothesis was in the diabetic retinopathy, even before the microaneurysm form, the middle retinal circulation gets affected faster, which can affect oscillatory potential. But we have some other emerging modalities like OCT, FFA. So we don't use this oscillatory potential that much. Okay. But it is still a part of ISCV standard prescription. So these are all dark adapted. Now coming to the light adapted responses. So this is done after 10 minutes of light adaptation. So, okay, this is a predominantly cone driven response. So the one which you are seeing here, this is a predominantly cone driven. I'm telling the predominantly cone driven. Then the last one is the 30 hertz flicker. So we give a high frequency light at a flicker rate of 30 hertz. So with such an high frequency, the rods fails to respond. Only cones can respond to just high frequency of bright light. So this is purely a cone-driven response. Understood? So we started with an isolated rod-driven response and ended with isolated cone-driven response with a spectrum in between. So what you need to do is ERG is simple. Just see whether the rod system is affected, whether the cone system is affected, or both are affected. So clear? So of course, you need to measure this amplitude, implicit time, and all those things which I described. So there are some ISCV standard ERGs also, like red flash ERG, on off ERG. You know, no, there's on bipolar cells, off bipolar cells in particular disorders. If you want to differentiate between them, you can use orange stimulus with a green background to get off ERG. And there are some short wavelength cones. If you want to get an only short wavelength cone activity in some of the disorders like enhanced Descon syndrome, you need to use a blue stimulus in an orange background. Don't worry about these things much. So, but there are some non-ISCV standard ERGs also which we use sometime. So fine. So whatever I described so far was a full field ERG. So what does full field ERG means? It's the response of the entire retina. Okay. So the whatever the waveforms which I described, dark adapted 0.0130, it represents activity of the entire retina. Okay. That's why it's called full field ERG. So now coming to a different ERG called pattern ERG. In full field ERG, what did we use as a stimulus? Light. Light, right? It's a luminance stimulus. In pattern ERG, as the name suggests, we just use a checkerboard. Okay, it's a response to a change in pattern, and it records response predominantly from the posterior pole, that to macula. So the peripheral retina won't have contribution in pattern ERG. Clear? Pattern ERG is mainly for the macular and ganglion cell function. So again, this has got three ways. Actually, there is a small initial N35 disflection. That again, that's from photoreceptor. We don't rely on that much. The two main things are like, first is the P50, which represents macular function, followed by a big negative deflection, which is N95, which represents activity of ganglion cells. Okay. So basically, it complements VEP. Okay. So for example, if you are confused with a disorder which is affecting the macula or the optic nerve, you need to do a pattern ERG and it will give an answer. Okay. So for example, if you give an example of glaucomatous optic atrophy, a patient has got completely normal retina, normal macula, but optic nerve is totally atrophied. So what will you get? So what will happen to the P50? It will be normal because macula is intact, whereas N95 will be abnormal. Okay. So we'll take one more scenario. If there is a patient with geographic atrophy of the macula, advanced AMD, so what will happen to P50? Vastly reduced, or any chloroquine toxicity or whatever subclinical. And what will happen to N95? Normal. Even that will be abnormal, right? First macula needs to be stimulated and it should generate the potential so that you can get an N95. So otherwise not true. So clear? So how to differentiate between the macula and the optic nerve function? Fine. So we learned full field ERG, which is for the entire retina, pattern ERG predominantly for the macula. So now coming to, there's something called multifocal ERG. What if I want to test each and every foci on the macula? So there is something called multifocal ERG, which we can do. So it usually allows detection of even the small foci of retinal dysfunction. Full field ERG represents the entire retinal function. Pattern ERG represents the entire macular function. So if you want to know each and every foci dysfunction, you need to do a multifocal ERG, where we use either 61 or 100 hexagonal elements, something like this, to stimulate each and every point on the retina. So at any point, only 50% of this will be eliminated, and we get a waveform corresponding to each and every point of stimulation. Understood? This is multifocal ERG. And you also get a pseudo color map whenever you do a multifocal ERG. We don't rely much on this because sometimes it can be false positively high or it can be false negatively low. So you need to look at this each and every waveform to ascertain which quadrant is affected, where area, where you are clinically suspecting, are you getting the corresponding response. Okay. So this is multifocal ERG. So to summarize, we studied full field ERG is the response of entire retina, pattern ERG predominantly from the posterior pole and the macula, multifocal ERG, we are testing each and every point on the macula. Okay, predominantly in the posterior pole. Clear? So ERG means is no one ERG, there is pattern ERG, multifocal ERG, and some non-ISCV standard ERG also. Okay, fine. So I think we'll go away for some case examples. Have time for that? Fine. So whenever you report an ERG, so you need to cover these 4 points. Whenever you cover these 4 points, you never miss anything. Okay. You'll always end up diagnosing correctly, not the disease, at least the report per se. So first, as I mentioned, first look whether the rods are more affected, cones are more affected, whether both are affected, or are there any negative waveforms? Just describe these things. Okay. So when they ask for first definition, they might ask origin of waves. If you answer both, they may give you this ERG printout. They may ask you to interpret. In PG exams, in some centers, they'll keep this ERG spotters, but in FRCS exams, you will have an electrophysiology station. Okay. So that's how we will go through the case example so that you can understand better. And before going to the case example, just a brief about electrooculogram. What exactly is that? So you know that eye is a closed structure and there are multiple electrical activities which are going on inside the eyeball, because of which obviously there will be something called resting membrane potential. Okay, that is predominantly contributed by retinal pigment epithelial cells. Okay, so how much is that? 5 millivolts. So UOG is nothing but you are measuring this resting membrane potential, whether it's normal or abnormal. So if the RP is not functioning for whatever the reason, this resting membrane potential gets affected. So then how to record this? So basically what we do is we place two electrodes, one near the lateral canthus, one near the medial canthus, and we will give the patient two targets, one on the left hand side. Ask the patient to move to the left and right. So once the eye moves, the dipole changes and it will give a electric potential, which is recorded as EOG. Okay. So it is done in both dark adapted state where the background light is off, and also in when the background light is on, light adapted state. This is different from dark adaptation and light adaptation. So lights off means the Gansfield light, the background light will be off, during which we get a negative response, which is called dark trough. When the light is on, the Gansfield light, the background light, we get light peak. So if we calculate the ratio of dark trough to light peak, we get something called Arden's ratio. Okay, so normal should be 2:1. If it's less than, if it's abnormal, and most commonly it will be abnormal in bestrophin related mutations. Okay, so fine. So coming to the case example, this is an 11-year-old male, BCV of 6'9", born out of consanguineous marriage. If you see his fundus, there are multiple vitaliform-like deposits in the macula. When you do an autofluorescence test, those deposits gets highlighted better. And this is his OCT, which shows subretinal fluid and also some deposits. This is not CSR. What is this? Hmm? Okay, we'll do a best macular dystrophy. Okay, fine. So in chronic CSR also you can get the subretinal deposit, but those are all fibrin-like deposit. Those are not what you call vitaliform deposit. They will not be hyper autofluorescent. And this were to be in chronic CSR, vision won't be 6'9", right? So usually the best patient will have good vision like 6'9", 6'6", like that. So we did an ERG in him. So can someone describe fulfilled ERG, whether it's normal or abnormal? Just go by order. What has happened to the dark adapted responses? Normal. Combined response, normal. Light adapted response, both normal. So the rod cone systems are completely intact in this patient. So we did an EOG in this patient. Can you see the light peak, which is supposed to be there? It's absent. So it's an unrecordable EOG. So this is what typically happens in Best disease. So because Best disease, the mutation lies, the bestrophin mutation is localized to the retinal pigment epithelium. And retinal pigment epithelium is the one which is supposed to maintain resting membrane potential, right? So obviously when that is abnormal, EOG will be abnormal. Retinal layers are intact, so fulfilled ERG is normal. So when you are in doubt, see, I showed you the classical case. Sometimes it can present in atypical form. If you do an ERG and EOG, a normal ERG is abnormal EOG is diagnostic of Best disease. What is that? Normal ERG, fulfilled ERG, and an abnormal EOG. Okay, because when the vitaliform, the patient presents in a stage where the vitaliform deposits are resolved, in that stage you may not be able to diagnose clinical accurately. You go for electrophysiological test. So fine. So this was a 10-year-old female, BCV of 660. I don't know whether you people can appreciate, the macula was atrophic. Again, born of consanguineous marriage. Look at the autofluorescence. So autofluorescence completely absent in the macula because both outer retina and RP is been atrophied. Okay, and also you can, if you carefully observe, there are multiple fleck-like deposits in the background. So this is a case of Stargardt's. This is how a typical Stargardt disease looks like. So we did a fulfilled ERG in her. So this is what we got. So what is normal? What has happened to the dark adapted responses? Reduced. By the way, the whatever the blue is the normative one. No, that is the normal. So any machine should have its own normative data, and you need to compare with that. Okay. So if you look at the dark adapted response, it's grossly reduced also and delayed also. The implicit time is also delayed. Amplitude also is reduced. Look at the right adapted response in the same. It's delayed and reduced. So both indicating, what does indicate? Cone rod dysfunction. Okay, both the cone system and rod system are affected in this patient. Okay, I'm not telling it as cone rod dystrophy. Whenever you describe an ERG, use the word dysfunction. Okay, dystrophy is a clinical diagnosis. Dysfunction is a conclusion you should draw out of doing an electrophysiological test. So you can ask me, so okay, sir, this is Stargardt's. We did ERG, cone rod dysfunction. What to do? What is the use? So the reason why we need to do an ERG in these things is the Stargardt's can be classified into three types based on the ERG response. In type 1, the fulfilled ERG will be normal, in which case the progression, the chances of progression is nil. If suppose we say only light adapted responses are affected, indicating a cone dysfunction. So in which there is a 20% chance of progression. If both cones and rods are affected, as in our patient, where both cone and rod system is affected, there is 80% chance of progression. So you need to counsel the patient accordingly, and they need to plan their career, lifestyle modification. It has to be according to the whatever the results you get. Okay. So dystrophy in any retinal disorder, any ophthalmic disorders, if there is no treatment, it doesn't end there. You need to counsel the patient to understand the limitation, and you need to counsel them to plan their career future accordingly. Okay. So otherwise, I have many RP patients who are like professional drivers. They tell, so Ratri solpa kashta aಗುತ್ತೆ, otherwise okay. So you need to tell them what's their limitation. You should not do that. You're not only risking your life, you are risking others' life who are driving on the road. Okay. So fine. So this patient had ABCA4 mutation. Okay. This was an interesting case. This was a 28-year-old male who had best-corrected vision of 638. He only complaint he had was photophobia. Can't open eyes in the light. Fundus on examination was absolutely normal. In fact, he was labeled as malingering. Some people diagnosed it as when he was kid as petit mal because he was not able to open eyes properly. So all that was there, and this was his autofluorescence, which was again normal. When you did an OCT, there is a small cavitation defect over here in the foveolar region. So that was the only abnormality which you could detect when we did all kinds of examination. So we thought we'll do an ERG. So this is the defect. So what has happened here? What has happened to the dark adapted responses? Both eyes completely normal. Whereas light adapted, it is absent, unrecordable. Okay. So understood. The defect what you're seeing clinically is such a small thing, but ERG is showing the cones in the entire retina are non-functional. Okay. So this is a case of achromatopsia, which is a type of cone dystrophy. Just telling cone dystrophy is not enough. You need to tell which type. So because cone dystrophies can be of early onset and stationary, late onset and progressive. Our patient, the achromatopsia falls in the category of early onset and stationary. So what does stationary indicates? The patient is going to born like that and is going to live like that. This vision is not a progressive disorder. What he needs is a photochromatic glasses and maybe a low vision needs for reading. So that's more than enough. Instead of that, if you label him as some petit mal, grand mal, cone dystrophy and all, he'll be on depression. His world is like that. So you need to counsel, you are not going to lose the vision. Only thing is you need to wear those glasses, don't drive during night, all those things you need to counsel him. So clear? So cone dystrophy, huh? Fine. This is the last case. This is an 8-year-old male who presented with blurred vision, which had a 636 vision. So this is his OCT. So what is the diagnosis? 8-year-old, this kind of an OCT. Hmm? Hmm? So X-linked juvenile retinoschisis. Okay. So sometimes you get this vitreous veils and vitreous hemorrhage because of unsupported blood vessels and all that. Let's not go into the deeper aspect of it. So what happens when you do an ERG? So I have put only the dark adapted responses. So what has happened to 0.01 ERG? It's grossly reduced. So what happened to the combined responses? See, A wave is forming, but it's not going to the baseline. It's coming here and it's going from here only. So this is a typical electronegative ERG. Okay. So why this is happening? B wave is from bipolar cell, right? A wave is from photoreceptor. In him, photoreceptors are okay. I mean, it's functioning to the extent, but retina is being split because of skytic. So it's not being conducted beyond. So that's why B wave is not there. So giving rise to an electronegative ERG. Understood what does an electronegative ERG means? It forms even it fails to reach the baseline. This is the 0 point. It should have come at least till here. It's going there. So what are the differential diagnosis for electronegative ERG? Whichever the disorder which affects inner retina. What all can cause? CRAO. CRAO photoreceptor and outer retina is intact, right? Because they are perfused by choriocapillaries. Okay, you will get an electronegative ERG. CSMB, congenital stationary night blindness, and juvenile X-linked retinoschisis, ischemic CRVO. Okay, in all these conditions, you get an electronegative ERG. Okay, fine. So this is the okay. Sorry, this is the last case, ma'am. I thought so. This patient presented with night vision problem. What is the diagnosis? Very classical. It's a case of RP, retinitis pigmentosa. So what will you get? This is his OCT. So what is abnormal in his OCT? For example, if I had not shown the fundus photograph, if someone gives this OCT as a spotter, see this ellipsoid zone is present only in the foveal region. Both in parafoveal region, it is completely atrophied. That's the reason they will have tunnel vision. Okay, the photoreceptor either side of the fovea are degenerated. They are surviving only in the central part of the fovea. Clear? So if we do a full-field ERG in them, what do you get? Both dark adapted and light adapted are unrecordable. It's a flat ERG. The reason being the photoreceptor which are surviving only in the foveal region are not enough to elicit a full-field response. Patient can still have 6669 vision. So if at all, if you want to, so there is no point of doing a full-field ERG if it's a obvious case of retinitis pigmentosa. Of course, in some cases of retinitis pigmentosa, sign pigmenta where there are no pigments, retinitis punctata albescens, if there is a confusion, do an ERG. Typical case, no point in doing a full-field ERG. If at all, if you want to monitor for any research purpose, which ERG you should do? A pattern or a multifocal ERG. Clear? So this is a 54-year-old housewife came for cataract surgery. She was interested in multifocal IOL. She was in hydroxychloroquine for 20 years. Fundus was absolutely normal. OCT was normal. Autofluorescence also had a doubtful changes. Otherwise, grossly it was normal. So look at when you do a multifocal ERG. What has happened to the central responses? It's grossly reduced, right? So what she has come for? She has come for multifocal IOL. If you put multifocal IOL, will she be happy? So she'll be behind your life for the reason being the central retina is being affected because of the chloroquine toxicity, which is not yet seen clinically. Okay. So any patient on hydroxychloroquine toxicity, you need to do a screening test. So after there are AO guidelines, you can go through that paper. They have clearly given the guidelines, what all test needs to be done, when it needs to be done. And it's always preferable to do a baseline recording so that after on subsequent visits, you can compare their own ERG, so which was done earlier. Okay. So rather than comparing to the normative, because it's very sensitive, the findings may not be classic like this. And if any case of systemic rheumatoid arthritis, if they're on these tests, if they're coming for IOL surgery, make sure their macular functions are normal. Okay. Or else they counsel them, because most of these patients are maybe fancied by the MFIOL and all. They'll ask for that, but you need to counsel them. Fine. So this is again 26-year-old male who presented with a big excavated lesion at the macula. OCT also showed this lesion. Right eye was completely excavated. Left eye foveal thinning with outer retinal loss. So we did ERG in this patient, which was completely normal. You remember the achromatopsia case? It had a very small defect, but still the ERG showed non-functional cones. Here it has got a big defect, but still the full-field ERG is normal. What does it indicate? So basically indicates whatever the lesion, it's a localized. Except this, the rest of the retina is functional. So this is a toxoplasma scar. That means it's indicating basically it's a localized disease. If it were to be because of some dystrophy, because of some mutation, so mutation has to happen in all the cells, right? All the cone cells. So the ERG will be abnormal. Since this is being a fulfilled ERG is normal, is both cones and rod system are intact. Okay. So basically the ERG, that's what we believe. Whatever we see structurally, it may not behave functionally the same. Okay. So clear? So fine. So that's it. Any doubts? Hope you understood something about ERG at least. It's very volatile, I do agree. So go and read about it. So revise the same thing. I think this will all be given as an handouts to you people. All this you need not know. Whatever I taught, it will be given as an handout. So
Thank you, everyone. So tea break se pehle one last question, and then we break. Everybody go to your mobiles. Shall I press it? You pressed it? Not yet. Wait, I'll press it. So all of you in your mobiles, here comes, array lock ho gaya. So here comes your question. Everyone knows the answer. The typing is what I'm testing now. Kya typing hai? Arey wah. This is the best typing speed, see? Any more typings? What is the answer? In the middle of typing, the spelling also has to be checked now. Everything. Okay. So the answer to that is fly ring a ring. And I think within Joe Christopher has got, na? Joe Christopher is here. Dr. Joe. Did you get an award before? Pakka? I remember reading your name before also. No? 100%? Okay. So, Dr. Joe Christopher, this award is not for the answer. This award is for your typing speed. Whoa, it was wonderful, man. 11:20 and 11:20. The time is also the same. Within a minute, you have answered this question. So, this one goes to you and the rest of you. Yes, so now we begin with our CPV sessions. Your stations are very well known to you. 1, 2, and 3 are within the auditorium. 4 is in the second floor. So look at your station. The cases you already know. I think once you have already attended the case presentation twice now yesterday, now you know things more better. So over to your case presentation sessions, and all the best. For anything else, we are always here. Dr. Joe, this is for you. Yes.
72 beats per minute with a regular rhythm. BP is 110 by 70. Blood pressure was 110 by 70 millimeters of mercury in sitting position. No evidence of pallor, icterus, cyanosis, clubbing, and lymphadenopathy. Systemic examination was within normal limits. Right eye, uncorrected visual acuity was 6 by 6. Nexa normal. Conjunctiva was normal. Cornea had normal size, shape, and luster. Corneal sensations were normal. Pupil was round, regular, and reactive to light. Lens was clear. Fundus examination, media was clear. Disc was normal size, shape, color. Neuroretinal rim was normal. Vessels over disc normal. Vessels arteriovenous ratio was 1:3. Background normal. Foveal reflex was present. Intraocular pressure was 18 millimeters of mercury. Extraocular movements were normal and full range. A ptosis examination of right eye. Vertical fissure height was 12 millimeters. MRD 1 was 6 millimeters. MRD 2 was 6 millimeters. Levator function was 15 millimeters. Lid lag absent. Leg of thalmos was absent. Bell's phenomenon was good. Marcus gun jaw winking phenomenon was absent. Ice pack test was negative. Fatigability was negative. And Cogan's lit twitch sign was absent. Left eye, uncorrected visual acuity was 6 by 6. Nexa, there was upper eyelid ptosis noted. Conjunctiva was normal. Cornea was normal. Size, shape, and luster. Corneal sensations were normal. Pupil was round, regular, and reactive to light. A lens was clear. Fundus, media clear. Disc normal, size, shape, color. Vessels over the disc were normal. Cup-test ratio was 0.3. Vessels arteriovenous ratio was 1:3. Background normal. Foveal reflex was present. Intraocular pressure was 16 millimeters of mercury. Extraocular movements were normal and full range. A ptosis examination, vertical fissure height was 7 millimeters. MRD 1 was 1 millimeter. MRD 2 was 6 millimeter. Levator function was 7 millimeters. Lid lag absent. Leg of thalmos absent. A Bell's phenomenon was good. Marcus gun jaw winking phenomenon was absent. Ice pack test was negative. Fatigability test was negative, and Cogan's lid twitch sign was absent. The diagnosis. Uh, Diagnosis is left eye congenital moderate ptosis.
For example, it has been written that family history is not significant. Is there any particular family history that should be asked over here? For any particular syndrome? Inner thighs is ptosis. We ask for blepharophimosis. If it is there, it will be there in other family members also. And if you observe most of the given data which has been given over here is kind of self-explanatory. So you have to now see why this data was given. For example, if you go back to history of present illness in the given set, whatever data has been given, it is clearly mentioned that the boosting has been since birth. So whenever we talk about ptosis, we start with etiology. We always start whether it is congenital or acquired. Since it is from birth, the first thing we do is put it directly under most likelihood of congenital. We are still not sure, but most likely to be congenital. Next thing which has been ruled out, if there is a ptosis, it has been ruled out that it is not associated with double vision. Then it is not associated with alteration in drooping of jaw muscles. That kind of rules out which condition? Yes. Markers and jaw winking phenomenon. There is no diurnal variation. Usually for adult or acquired onset, we'll be asking these questions like diurnal variation.
That is to rule out which disease? Myasthenia. And then recurrent ocular allergies. Similarly, most of the things already they have been covered in the form of negative history. Birth history, it is full-term normal delivery. Again, it is giving you some clue that it is not related to birth trauma. Okay. For example, in birth trauma, there can be some injury to the LPS also. So systemic ailments usually it won't be associated with. But yes, over here the measurements are important. So one clue over here which you have to remember is MRD1 and MRD2. They are very important to know the grade or the how much amount of doses is there. So whenever we add these two, they should be equal to the vertical height. So there are sometimes we are unable to elicit these for whatever reason. There are some more measurements which are taken like MLD and MRD3. So what is that MRD3 and MLD? Margin limbal distance. MLD is margin limbal distance. We measure from the upper leg margin in a person with extreme up gaze till the 6 o'clock limbus. A normal is taken around 9 mm. So with reference to normal, we can measure that. Similarly, MRD3 is again between the reflex and the margin in up gaze. Next is coming very important in doses is what is the levator function. Everything depends on the levator function. Your entire management protocol is based on the levator function. So how do we divide it? 15 and above is good. Anything more than 15 is good. 8 to 15 is moderate, yeah. And 5 to 8 is fair. Anything below 4 is poor. So if at all we have to attempt the LPS resection, the LPS function should be better than, it should be more than 4. Anything less than 4, you cannot go ahead with LPS resection. Again, here few questions will be there pertaining to the LPS muscle. A few questions like in lip elevation, what is the role of LPS? Is that the only muscle which takes part in elevation of the eyelid? Muller's muscle is also there, which is innervated by sympathetic nervation. How much does it contribute to Muller's muscle? 2 mm. 1 to 2 mm. Okay. So if it is a mild ptosis, we consider probably surgery to be done. Yes, fascinalis. Okay. And how much does LPS contribute with elevation? 12 to 20 mm. Around 12 to 20 millimeters. So it is the main elevator. Any other muscle aids in that, it may not be directly responsible for the elevation. Frontalis. That is why in children with ptosis, if you see, they tend to raise their eyebrows. The other thing about LPS you have to remember is it has a opposite innervation with orbicularis oculi. So just doing ptosis surgery is not enough. You should know the action of orbicularis oculi also. A person should not be having any weakness of orbicularis whenever you are going to perform a ptosis surgery. Because after surgery, if the eyelid does not close well, there is a risk, even more greater risk of corneal exposure. So always in assessment, you have to assess whether the opposite innervation of orbicularis oculi is enough or not. Other thing already it was mentioned was Bell phenomenon. It is very important to note Bell. What is the normal Bell phenomenon? Upward and outward. So some children they will not have a good Bell phenomenon. So again, we should not perform a ptosis correction if the child has a poor Bell phenomenon, because it will lead to again corneal exposure. Next, another thing which you should be checking is corneal sensation. Has it been mentioned in this? Yes. It is very important for the same reason that suppose a slit surgery has been done and there is a partial lack of thermos and the child has got reduced corneal sensation. Again, there is risk of corneal injury and exposure. Right? Now, ptosis, in congenital ptosis, it can be associated with Martha's jaw weakening phenomenon. So, we always look for any correlation with chewing movement or opening of the jaw, whether anything is there. Any other thing? Apparent innervation cases also it can be noticed. So here what they have given, almost all the points have been covered. These are the things which we look for prior to taking a case for surgery. Okay. The decision for surgery, when should it be done? Suppose the child is born with ptosis, when should we operate? That's the first question that comes to mind. Now that you have already examined, you have come to a conclusion that the child has got this much degree of ptosis. Now the parent asks, when should we get it operated? So you have different age groups. Right? At birth, if you notice, or say at 1 year or slightly older child. So what they say is, most of them correction for ptosis is for cosmetic purpose. It's very rare that the child has a complete ptosis and goes on amblyopia. Usually that amblyopia factor comes in case of congenital cataracts. There the urgency will be there. So in congenital ptosis, it's very rare to find a complete ptosis. Invariably it will be partial and it does not necessarily cover the pupillary area. So risk of amblyopia is relatively less as compared to congenital cataract. Okay. Majority of the cases, parents bring them because of cosmetic purpose. What is the posture of the child with congenital chin elevation? Right? So they come basically not because of the droop. They tell my child walks around with the chin elevated all the time. So they come with such a history also. So the decision to operate will be based upon how much the amount of ptosis is. If it is covering the pupillary area and there is a risk of amblyopia, do it as early as possible. And in case of such ptosis, invariably if you, it's difficult to elicit the LPS in a pre-verbal child. And they may not follow, look down, look up and all that. So is there any test wherein you can roughly assess whether the LPS is good? Look at the crease of it. Have it? Crease. Lid margin. Now it's good. So in very young children, how do you assess the LPS function? Is there any method? Crude method. What we can do is we avert the child's upper lid and just wait for it to snap back. If it snaps back immediately, then it indirectly tells that the LPS is good. You can consider a resection there. However, in case it does not, then we have to assume that it is severe or the LPS is not functioning that well. Invariably, these congenital ptosis children, they will be having a poor LPS. Those who are slightly older and you are able to assess their LPS function, it will be invariably below 4. So in such cases, we opt for a frontalis sling surgery. So many times this question arises, if it is unilateral severe ptosis, how do we operate on such a child? Because if you put a sling, what are the disadvantages of sling surgery? They have got it done for cosmetic purpose. Is there any other cosmetic problem which we may give rise to? Yeah, in down gaze, usually there will be more exposure, right? So when, yes, yeah. So we don't want that to be there, right? So what they say is if it is unilateral severe ptosis, it's better to go ahead with bilateral surgery and give a equal position to both the eyelids. So even if it is unaffected, we can go ahead for cosmetic purposes for both the eyelids. Since this is a case of congenital ptosis and it has been given LPS is how much here? Levator function is 7. So 7 is fair enough. So we can still consider LPS resection. Now coming to the surgery per se. Before we venture into the surgical procedure, you should be well versed with the upper eyelid anatomy. So all the layers and how the LPS contributes to the lid crease and its attachments. So you should be well versed with that. So insertion of LPS. Where is aponeurosis inserted? Upper lid only, correct. Yes, correct, huh? Exactly. One is into the tarsal plate. Some fibers go skin of the upper lid. That is how the eyelid crease forms, isn't it? Yes. And are there any other landmarks which you need to be well versed with before you do a LPS resection? You should be aware about its relation with the Wittnall's ligament and what else? Median and lateral horns, right? So you should be well versed with these three attachments. You should make sure you don't damage the Wittnall's ligament. And identification of the LPS is very important whenever the anterior approach is done. So usually the anterior approach is preferred as compared to the posterior approach. So when we are going through the anterior approach via the skin, we have to be sure the level, each layer by layer will be dissecting, isn't it? So how do we know we have reached the LPS? You have to go via the septum, you have to retract the fat which gets prolapsed, and then only the LPS will be coming. So these two landmarks you should always remember while doing. Okay. And then depending on how much you want to resect, let us say you want to resect about 10 to 15 mm, you can resect or you can clip. Okay. And then the sutures you have to tie to the tarsal plate. So what are the complications of this LPS surgery? See, one thing we have to remember is ptosis surgery is not a very precise surgery wherein if you tell you're going to reach that level, you will attain that only. So there can be slight either lid retraction or a partial droop. It won't be very perfect. It's not like a tailor-made thing, right? So we can anticipate that, though not necessarily it should happen in good expert hands, but that the patient should be well versed with. Now, suppose it was to be a severe ptosis, less than 4 millimeters, then we opt for frontalis sling surgery. Right? So what are the materials which are used in frontalis sling surgery? Fascia lata, that is a natural one. The artificial are silicone and what are the advantages of the natural, advantages and disadvantages of both? Fascia lata, what is the advantage? Pardon? Yes, exactly. Yes. It has more advantages only. The only thing is the patient should have experience in harvesting or someone should harvest and give, or we have banks nowadays wherein the facial latte is available also. Any particular disadvantage? Suppose a person requires a repeat surgery. You want to adjust the suture, it becomes difficult with the facial latte. It is much easier with the silicone. With the silicone, it's not going to merge with the tissues, right? It will never merge with the tissue. Unlike facial latte, which is a natural tissue, in silicone, you can easily adjust the suture. You want to make it more tight, you want to lift it some more, you want to loosen it. We have a sleeve over there, usually. So we can adjust with the help of that sleeve. And even the knots are not something which you cannot remove. You can anytime go back and remove the knots and you can always adjust the height of the upper eyelid. So these are the advantages and disadvantages of either of them. And in general, there are some problems which can happen. For example, suture exposure, especially in children, that is more common, and suture infection. If it is silicone rod, you can always replace it with another one. Sometimes suture related granuloma can occur at that site. And this frontalis sling, there is another one disadvantage is earlier there used to be 5 stab incisions for the pentagon type. So it used to leave 5 different scars, puckered scars. 2 are taken at the upper lid margin, 2 around the eyebrow, and 1 above that where the knot comes, right? So this was the pentagon which was there. Now newer ones have come wherein a single stab is made at the forehead and the same rod is passed in such a fashion that we get both the ends out. Actually, it has 2 needles. So you can start both from the same point and exit at the same point and then put a suture over here. So there won't be 5 scars at all. Okay, so that is one advantage of single stab type of frontalis sling surgery. Anything else which you feel you want to discuss in congenital ptosis? I guess in acquired ptosis there will be slightly different history. What we discussed here was congenital ptosis. In adults, what we see in acquired ptosis, the set of questions are a bit different. So what other questions you will be asking? Obviously, the patient will tell that earlier my eyelid droop was not there. Whatever number of days, months or years, it has been there. So it's understood it is acquired. So what are the acquired causes for ptosis? Trauma. So we divide them into neurogenic, myogenic, mechanical and aponeurotic. Right. So neurogenic common causes are third nerve palsy, Horner syndrome, third nerve palsy, yes. And myogenic, myasthenia gravis, muscular dystrophy, then just go on adding. Yes. Poisoning or toxic. Pardon? Congenital. Again, that comes under congenital, yeah. Yes. Mechanical. Any lid growth or edema or anything. It will be temporary if it is just edema, or if it is a growth, you exercise it, it will be gone. Then aponeurotic, which is most common in old age, right? So again, you have to ask some more history also. See, directly no patient will come and tell that I have got myasthenia gravis. So it is all in the history how you're going to elicit and the signs. For example, in this case scenario also, lot of points were given like ice pack test, fatigability test, Kogan's lid twitch sign. All these are helpful in diagnosing a myasthenia gravis patient. So suppose you have a high index of suspicion for myasthenia gravis, how do you confirm this? Like in these 3 only, you have come to know that everything is positive. Ice pack test is positive, fatigability, Kogan lid twitch. Then how do you confirm? The confirmatory test? What is the tensilon test or hydrophonium test? Yes, 2 mg is injected initially. Wait for any adverse reactions. If none, then you go ahead and inject another 8 mg of hydrophonium. There will be improvement in doses.
So that confirms it that patient has got myasthenia. Anything else? Antibody levels can be assessed. Then single muscle electromyograph can be done. Suppose a person has already got myasthenia gravis and has now improved. So usually we have to ask for a drug history also. So if any positive drug history is there. Okay. Anything else? Shall we go to the next presentation? Anyone else who is not presented? Six. Six number, six. Here is a mail the mic. A male of 40-year-old salesman by occupation presented to the OPD with a history of double vision since 15 days, with inward deviation of right eye since 15 days. Patient was apparently asymptomatic before 15 days when he developed sudden double vision, which was constant, binocular, and increases in right gaze, and disappears on right face turn and closing one eye. Associated with inability to move right eye outwards, there was no history of trauma or any fever, no history of headache, nausea, and vomiting, no history of weakening of the limbs or slurring of speech, no associated diminution of vision, tinnitus, or earache. Medical history, it is a known case of diabetes since 5 years on insulin, no history of previous significant medical or surgical history. Past history, there's no similar complaints in the past. Personal history, nothing significant, and family history, nothing significant. General physical examination was normal and systemic examination was normal. Coming to ocular examination, the visual acuity with corrected head posture in right eye was 6.6 with near vision N6, color vision normal, eyelids, lacrimal apparatus, eyelashes normal, cornea normal, clear, pupil 3 mm regular round and reactive, lens clear, fundus showed, distant direct ophthalmoscopy showed red glow, and posterior pole appears normal, disc with 0.3 CDR ratio, macula, the foveal reflex was present, background retina was normal. Refraction, there was minus 0.25 diopter cylinder and minus 0.5 diopter spherical and cylinder at 180 degree. IOP was 12 mm of Hg. Coming to the motor evaluation, the abnormal head posture, the face turned to the right with Hirschberg reflex showing right eye esotropy of 30 to 35 prism diopters. Cover uncover test showed alternate ESO, left eye more than right eye. Prism cover test, left eye was fixing. Ma'am, I mean the deviation. The deviation measured for FAR was in the center, in the primary gaze, it was 35 prism diopters. In upper gaze, it was 35 prism diopters. In down gaze, it was 35 prism diopters. In right gaze, 55, and in left gaze, it was 10 prism diopters. And for the near, it was 30 prism diopters in the primary gaze. And upper gaze, it was 30 prism diopters. Down gaze, it was 30 prism diopters. Right, it was 55 prism diopters and 10 prism diopters on left side. The secondary deviation, right, if with the right eye fixing, the secondary deviation was 45 prism diopters base out. Coming to the extraocular movements, ductions in right eye, right? Okay, ductions in right eye showed -3 in dextroversion, duction, sorry, in abduction, ma'am, in abduction. And left eye, it was full range movements. Versions, there was a restriction in dextroversion and dextro elevation and dextro depression. Coming to the sensory test, titmus fly showed 50 seconds of arc. Diplopia charting, there was a horizontal diplopia, more towards the left gaze. Worth 4 dot test. Right gaze, ma'am. So the diagnosis was isolated right eye sixth cranial nerve palsy, most probably secondary due to the diabetic mononeuropathy.
So this was because of the given data already to class have been given. How did they conclude? We will start from the history level itself. Here is a middle-aged male who has come with double vision. So first we confirm the type of double vision. Here the data is the same. So you should always elucidate whether the double vision disappears on closure of one eye. That we have to. It's a very basic question that is rule of yeah. Next, given data is inward deviation of the right eye since 15 days. So it tells us that it is quite sudden and onset. Yes, the other things which have been given is constant, it is minor, that it is observed only when both the eyes are open and it increases on right gaze. So always it will increase wherever the deficit of that action is. Isn't it? It's a case of right six nerve palsy. So on attempted right side gaze, the diplopia is and in order to overcome that double vision, the patient will try to adapt. For example, person has is not able to see to the right. What he will do? Turn his head only to that direction so that the diplopia reduces. So here there is a positive history wherein it disappears on right face and only one eye. Why did they ask for this? Anyway, history has been provided. So you should know why this history was asked. For example, no history of trauma. Because in etiology or causes of sixth nerve palsy, traumatic sixth nerve palsy is known to be there. Right? So there are certain characteristic features of the sixth nerve which we will discuss later. First, we'll just finish up with the history taking. There's no history of fever. Why is it relevant to ask for history of fever? Why is it relevant in this case of diplopia? Why should you be asking for that? Which part of the sixth nerve wherein it can be associated with infection? Basically, fever is one associated with infection. So it is in the cavernous sinus. Cavernous sinus based on various areas. Sixth nerve is cavernous sinus. So fever, chills and all that is only in this area it is appearing. Nothing like that history of fever. Next, no history of headache, nausea, vomiting. Raised IC. Quite straightforward to rule out. Raised intracranial pressure from a stiff motion. Next, history of weakening of limbs observing. CBS. Stroke and all. With respect to sixth nerve palsy, most of the questions have been asked retrospectively. Right? We didn't know to begin with when a person comes and diplopia, we don't know what is it. We are assuming it should be rather it could be third nerve, fourth nerve, sixth nerve. Right? Now some questions have to be asked after the diagnosis. What we consider. When you suspect a stroke palsy, you go back and you ask all along the course you'll be trying to find out where exactly this lesion might be. Right? So here there is history of weakening of limbs and slurring of speech. What is the association with weakening of limbs? Any hemiparesis you are interested to know? Contralateral hemiparesis. Where it can be fascicular part along with the pyramidal tract. Right? Similarly, we need to know whether other cranial nerves are affected. Suppose
So as we were discussing, we have to understand why this negative history was taken. Should I repeat? Okay. So we discussed why history of trauma, fever, headache, nausea, vomiting, weakening of limbs and slurring of speech were elicited. Next is associated tinnitus and earache for involvement of eighth cranial nerve. Okay. We'll discuss the associations as we go later. It's very common for isolated sixth nerve palsy to be due to vascular ischemia. See, otherwise it's less likely to be isolated. All along its course, nuclear will never be isolated. Always you have to remember, nuclear lesions will never be isolated. Similarly, fascicular, as it comes down, again it is associated with either seventh nerve or eighth nerve. Then as it comes down along the petrous part of the temporal bone, again it can be false localizing at that part. Okay. Then through the Dolores canal and then intracavernous part, intraorbital, and then to the lateral rectus. So when it is in the cavernous sinus, again it is surrounded by a lot of nerves and vessels. When it is in the intraorbital part, again it has got surrounding structures, right? So where is it likely to be if it is isolated? So whenever it is isolated, you think of medical cause like vascular ischemia arising from diabetes or hypertension. So in this particular patient, it is a known case of diabetes since 5 years on insulin. So probably it is because of vascular ischemia. So whenever you have a case of any cranial nerve palsy, please make sure that you know all the 12 cranial nerves, not just the one which has been affected here. So you should be able to name all the 12 cranial nerves and how to examine all the 12 cranial nerves. So would you like to enumerate them? The first one is the olfactory, second is optic nerve, third is oculomotor, fourth is trochlear, fifth trigeminal, sixth abducent, seventh is facial, eighth is vestibulocochlear, ninth is glossopharyngeal, 10th vagus, 11th accessory, 12th is hypoglossal. So each of this you should be able to elicit. I hope you remember the tests for checking for the cranial nerves. If at all a case is there, please make sure that you have mentioned that you have examined all the cranial nerves. In this particular case, in case of sixth nerve palsy, you should make sure that you have assessed the other wherein adjoining structures are there. For example, it is in the superior orbital fissure or intraorbital part somewhere. What are the other nerves it will be associated with? Third nerve, fourth nerve, sixth nerve. So you should make sure that you have assessed that. If it is in the cavernous sinus, in addition, you will have the fifth nerve also. So you have to look for corneal sensations like that, right? So which blood vessel is it quite closely attached to? Internal carotid artery. Any other? Internal carotid artery is much later. Much before that, it is in close association with AICA, anterior inferior cerebellar artery. Actually, among space occupying lesions or aneurysms are concerned, sixth nerve is less likely to be affected by an aneurysm as compared to third nerve. So aneurysms are less likely cause for sixth nerve as compared to third nerve. So what are the characteristic features of sixth nerve? It is the cranial nerve with the longest intracranial course, right? Then can you trace the pathway of the sixth nerve? Where exactly is the sixth nucleus present? Pons, yes. Just below the floor of the fourth ventricle. Okay. So why you need to know is, as I told you earlier, it is closely associated with other structures also, and it is very unlikely that you will get an isolated 6 nuclear palsy. So here it will be, it is associated with the seventh nerve. The seventh nerve actually winds all across it and then it will be going. So at the level, you will find a seventh nerve palsy also. PPRF is again in close association with that. So you will have lateral gaze palsy also. Okay. So then as it goes down, what is false localizing sign? At which part of the sixth nerve, if involved, we say that it's a false localizing sign? Yes, at the petrous part. Because whenever there is raised intracranial pressure, there is lowering of the brainstem, it will cause pressure on the sixth nerve. And both the six nerves, it will cause pressure. So it is very difficult to pinpoint and tell that this is the lesion, because raised ICT could be from any given cause. That is the basilar part. After that, we have the cavernous part, intraorbital, and then branch to lateral rectus, right? So always remember that this diplopia, whenever we are checking for diplopia, you have to check for far and near both. So in case of sixth nerve palsy, it will be more for distance than for near. Now here we have a case of sixth nerve palsy. Sometimes what other conditions can mimic such a scenario? What other conditions you will have? Restricted abduction. In case of restrictive myopathy, it can be there, isn't it? So how do you differentiate between a restrictive myopathy from a paralytic sixth nerve palsy? Forced duction test. So how do we do this forced duction test? So we instill a topical anesthetic and you have to take 2 forceps and you try to move it in the direction of the action of the muscle. Okay, if it is impinged due to whatever reasons, you will not be able to move. For example, if the medial rectus is impinged for some reason, the eye is again in esodiviation. When you try to do a forced duction test, you will not be able to move it in abduction at all passively, right? In case of paralytic, that passive movement is possible. So this is called as a forced duction test. There's another test called as forced generation test. So what is that test? Sometimes in case of partial paralysis of that muscle, there will be some residual function in that muscle. So what we do, similar to forced duction, we will put an anesthetic, hold the conjunctiva at 6 o'clock and 12 o'clock limbus, and then we move in the direction of action of the muscle. Sometimes if the muscle is trying to contract partially, you can feel a tug over there. You can actually feel that contraction. So this is called as forced generation test. Okay. So differential diagnosis for this. Differential diagnosis. Where else you will get a esotropia like position? Here medial deviation of the eye is there. Yes. High myopia, yes. So that is a pseudo deviation. Yes. Where else? As I told, thyroid ophthalmopathy has to be ruled out. So how do we work up and manage such a case? A case of isolated sixth nerve palsy secondary to diabetes. Yes. Yes. So the rule of thumb is you have to wait for natural healing. So usually these cases, they'll heal within 3 to 6 months. So you have to wait till then. Surgical option is rarely considered. Only if there is residual beyond, say, 10 months or a year, then only it is considered. If at all it is done, it will be strengthening of lateral rectus and weakening of the medial rectus muscle. For diplopia, to overcome that, can something be done? Prisms can be given. But if it is a large prism, for example, you think the patient can wear glasses with such a large prism? So exactly, we have to use Fresnel prisms, which are taken as add-on prisms. Or the existing spectacles, they can be put as a flap of Fresnel prisms can be given. What is the advantage of Fresnel prism? Yes, it is just like a thin attachment over the existing spectacle. Anything else in 6 nerve palsy? If not, we'll go to the next. I guess we have covered the course of it, the probable causes, and the management of uh, palsy secondary to medical cause. Here is a patient, a 42-year-old male who is driver by occupation and complains of diminution of vision in the left eye since 2 months. History of presenting illness. Patient was apparently all right 2 months back. Later, when he developed diminution of vision in the left eye for both distant and near, which was sudden in onset, painless, and progressed over 2 months. Patient hasn't consulted any doctor prior to this. No history of trauma, no history of using of thick glasses, no history of flashes or floaters, no history of headache or eye ache. No history of similar complaints in the past, no history of similar complaints in the other eye. Now coming to medical history, patient is a recently diagnosed hypertensive 2 weeks back and is started on oral antihypertensive agents. Patient is not a known case of diabetes. Past history is not on any prolonged medications. Personal history, sleep, appetite is normal, bowel, bladder are normal, and there are no habits. Family history is nothing significant. General physical examination. Patient is moderately built and nourished, well oriented to time, place, and person. Pulse is 82 beats per minute, regular and rhythmic. BP is 160 by 90 mmHg in sitting position. No history of pallor, icterus, cyanosis, clubbing, and lymphadenopathy. Systemic evaluation is within normal limits. Ocular examination. Head posture is normal, facial symmetry is symmetrical, forehead and ocular posture are normal. Now coming to the ocular examination of right eye, uncorrected visual acuity is 636, best corrected is 1.5 diopter spherical, which improves to 6.6. Lids, conjunctiva, cornea are adnexa is normal, conjunctiva is normal, cornea is normal in shape, size, and luster and transparency. Iris is normal pattern, no neovascularization of iris. Pupil is round, regular, reactive to light. Lens is clear. Anterior vitreous is normal. IOP is 18 mmHg and ocular movements are full. Right eye fundus media is clear. Disc size is normal. Shape is
vertically oval. CDR is 0.3:1. Neuroretinal rim is healthy. Margin is well defined. And there are no abnormal blood vessels over the disc. Blood vessels are normal. Background is normal. And macula is foveal reflex positive. In left eye, the uncorrected visual acuity is counting finger 1 meter. Best corrected visual acuity showed no improvement, and near vision is less than N36. Adnexa is normal. Conjunctiva is normal. Cornea is normal in shape, size, luster, and transparency. Iris is normal pattern. No neovascularization of iris. Pupil had grade 2 RAPD. Lens is clear. Anterior vitreous is normal. IOP is 16 mmHg and ocular movements are full. The fundus picture of the left eye, media is clear. Disc is 0.6 into 0.6 mm. Size is vertically oval. CDR is hyperemic. Margins are blurred and neuroretinal rim is not made out. The vessel over disc vessels are there are multiple flame-shaped hemorrhages present 360 degrees around the disc. Blood vessels are dilated and tortuous. AV ratio is 2:4. Background, multiple bright red superficial flame-shaped hemorrhages are noted in all 4 quadrants, and multiple small dot blot hemorrhages are seen in all 4 quadrants. Macula foveal contour was lost. There was macular thickening and multiple flame-shaped hemorrhages around the macula, which was suggestive of macular edema.
Before we go into the diagnosis, let us consider what likely causes can be there in this particular middle-aged person who comes with sudden diminution of, not sudden exactly, it is diminution of vision in left eye since 2 months. Right? What are the conditions which you think of when a middle-aged person comes with reduced vision for 2 months? Knowing that he is a hypertensive, right? So in a hypertensive person, there is a lot of negative history which has been elicited here. So let us go one by one to each. So how did the person appreciate the reduction in vision is important? So was it sudden? So that information has been given over here. It has been mentioned it is sudden in onset. So if you go by CRVO, the given diagnosis, when is the time when people usually come with this diminution of vision? Usually it is in which part of the day? Early morning, as soon as they wake up, right? So why is it so that a person wakes up with a sudden loss of vision? See, the explanation is the person is sleeping and there is some nocturnal hypotension, right? That causes some variation in the perfusion pressure. So this CRVO usually occurs in people who are predisposed to it. So we already know the predisposing factors, right? What is that virtuous triad? Virtuous triad in etiopathogenesis, we read that, right? One is the lumen alteration. Next is viscosity of the blood which is flowing through it. Then stasis. So if there is a predisposing factor like this and there is altered perfusion pressure, it just adds to the stasis. So already the risk of thrombus formation is there and the person will manifest it with because of that hypotension. So that is why the first thing they get up in the morning is they experience this symptom. So it will be sudden in onset. It is usually in the early morning part of the day. The next thing is it is painless and it has progressed over 2 months. So probably this information is being given so as to let us know that the vision has been involved,
See, not every retinal vein occlusion will end up with some kind of visual morbidity. So visual morbidity always is only in two conditions. One, if there is macular edema, or if there is a hemorrhage, like NVD has occurred, it has resulted in a vitreous hemorrhage, or here it is only 2 months, but sometimes if the patient has presented much later, it could be even because of glaucoma. Patient hasn't consulted any doctor prior to this. So this tells that it is not a recurrent episode. But as we know, it's not necessary for it to occur recurrent in the same eye, but sometimes it can recur. So which type of retinal vein occlusion can recur in the same eye? The non-ischemic type. Okay. No history of similar complaints in the past. Okay. So no history of similar complaints in the other eye. So you should remember that the fellow eye can be affected, though asymptomatic initially. Since it has been sudden onset, reduced vision, history of trauma is very important because at this stage we don't know what it is. It could be retinal detachment also, right? Then no history of using thick glasses. Why is this history important? Yeah, if it is a myopic. In case of CRVO, which type of eye is going for CRVO? Which refractive error has a tendency to go for CRVO? Hypermetropia. No history of flashes and floaters again probably has been elicited because this is a case of sudden loss of vision, painless loss of vision, again with respect to retinal detachment. So the positive history over here, medical history is patient is a known hypertensive. So that helps us in finding out the etiology. So whenever we do the examination, there are certain signs which help us to diagnose, right? So here we know that after seeing the fundus, we know it's a case of central retinal vein occlusion, but that is not sufficient. You have to understand so many other aspects to it. For example, is it ischemic, non-ischemic, whether there is associated macular edema, whether there are collaterals, whether there is NV or NVD. So based on the findings, we'll come to know. The other thing, there are indirect ways to know whether it is non-ischemic or ischemic also. So can you tell before fundus examination, are there any points which will help us to identify and differentiate? Not audible? Depending on vision, yes. RAPD. Very good. Neovascularization of iris and angle also, isn't it? So these are more common with ischemic type. So it is very, very important to do a gonioscopy in all these patients wherever suspected CRVO is there. Where do you look for NVI? On slit lamp examination at the pupillary margin. Yes. It's very important to look for the cup size and the disc in case of the fellow eye also. So how do you find, what are the findings which are seen in the fellow eye in such patients? Yeah, pre-existing we'll discuss about the etiopathogenesis. So just before that, in the fellow eye, you can find a small cup, okay, and small disc. So coming to the findings in this particular case, in the left eye, there were multiple hemorrhages. Where else will you get a similar picture? Still, you have not made a diagnosis of CRVO, you are seeing such a fundus picture. Similar picture can be seen in case of, you should be more precise about that. Just hypertensive retinopathy, you don't get. Grade of hypertensive retinopathy should tell. Grade 4, yeah. Then anemic, it won't exactly give similar picture because there'll be a lot of rod spots and more pale looking retina. Then diabetic retinopathy mimic this? Definitely, they are differential diagnosis for each other, right? Radiation retinopathy, diabetic retinopathy. So here is a given case wherein this given data is there. Is this diagnosis enough? Left eye central retinal vein occlusion with macular edema. Now you want to know what type of CRO it is. Data has been given. So what type of CRO is this? Probably ischemic type. So what investigations you would like to do? Fundus already has been done. Imaging has been done. Would like to do a FA, isn't it? So in FA, what are the findings in case of CRVO? In case of ischemic CRVO, don't go directly to that. You start from the starting. What happens to the filling time? Prolonged filling time. Yes. The AV transit time is delayed. Then block fluorescence because of hemorrhages. Then go on telling. Yes. Yeah, capillary non-perfusion areas. Simply just mentioning is enough, or you need to measure that. More than 10 disc diameters is in favor of ischemic type. Usually it will be like that, or it will be much more. Telling is easy, 10, but usually it will be the tune of 60, 70, like that. Okay. Then CNP areas. Then what? You have to gather more information, no? Yes, you need to know the macular edema. Then some more is there here. Neovascularization. Yes. How do you differentiate neovascularization from collaterals? These will go for collaterals. Do they go for collaterals? Yes, they do go for collaterals, isn't it? So how do you differentiate new vessels? See, new vessels, NVE or NVD, they are more fine network. Whereas these collaterals will be in the caliber itself, they will be more. These are more leaky. Collaterals are not. Yes. Yes. Then macular edema. So these are the things which we will be gathering information on FA. Apart from FA, any other test you would like to do? OCT, exactly. Now with the advent of anti-VEGFs, OCT plays a very important role wherein you need to know the amount of macular edema which is there. So here in this patient, we already know that patient has got a macular edema. So we assume it to be ischemic type. So it's a case of left eye ischemic CRVO with macular edema. So how do we go about management? Now that we have diagnosed, how do we go about the management? Pardon? Depending on the macular edema and the vision, isn't it? And associated features like whether NVA is there or not. So if macular edema is there, what are the treatment modalities? Anti-VEGF, yes. So there are so many trials which have been conducted with respect to intravitreal. So earlier it was with steroid. So which steroid was given? No, triamcinolone. Later, obviously, ozurdexianol came. So the trial was with what mg of triamcinolone was given? 4 mg versus 1 mg, isn't it? So with 4 mg, what were the problems which were noted? Raised intraocular pressure. So that is with the intravitreal triamcinolone. 4 mg versus 1 mg. What was the name of that trial? It's difficult to remember this unless you add some very funny thing with that. Unless you cruise for it or something like that. I thought you people will be more well versed with that.
English, if you know common trials, very These are where examiners will ask you each case will be something to discuss about the study.
Cruise study. Then came the Bravo and yes, that was with respect to ranibizumab. Okay, for macular edema in CRVO. Then came aflibercept, ILEA, that is the Geneva and the Copernicus study were done basically to test. They have found good results in all of them. The end result you have to remember which drug was given in which study, what was the end result. So in CRVO, whenever we diagnose that condition, we have to see the associated whatever findings are there. We have to treat the person as whole. So systemic findings also are important. So we have to investigate them. What we now discussed was just the ocular part. We have to go ahead with the systemic workup also. So before we go to the systemic workup, we should know what are the conditions we predispose a person to CRVO. Systemic conditions which cause CRVO. Hypertension, yes, hypercoagulable diseases, yes, hyperviscosity conditions like, yes, polycythemia, coagulopathies, leukemia, even that can be. Any other ocular things are still there? Glaucoma itself can be a predisposing factor. Anything else which you people will be giving? Cataract surgery. Sometimes you have to postpone the cataract surgery because of that incident. Retrobulbar hemorrhage. So once you have a person with CRVO, there has to be a blood workup which has to be done. Apart from diabetes, you have to get a blood smear done, a routine complete hemogram with blood smear. And if you have inflammatory conditions, then you must go for specific. Like SLE is known to cause this, then Behçet's, vaginas, sarcoidosis. So chest X-ray helps. In Behçet's, you can get a HLA-B51 done. And if it is vaginous, C ANCA can be done. So chest X-ray and these specific investigations can be asked for if a person either is a known person or if you are suspecting an inflammatory cause. So etiopathogenesis and accordingly the workup. And we discussed about ocular examination and ocular workup of a given case and management, right? So this is only one aspect. Macular edema is just one aspect. Now suppose a person has got, you have tackled the macular edema, but person has got NVE. You have noticed that there is florid NVE. How will you manage such a case? Yes. So you have to go for laser photocoagulation. So usually in CRVO, it will be pan-retinal photocoagulation. It's in BRVO, we go for other studies and all that. Sometimes in macular edema, only with injections, it may not be enough. You may have to go for rescue grid laser also. So here you need to know what kind of grid laser is given, what are the settings, okay? Which laser is used for grid laser? Yes? Yes? Argon, that is green laser, yes. Or frequency doubled Nd:YAG green also can be used. 532 nanometers. What is the spot size for grid laser? 50, if you're going very close. Usually we don't go so close to the fovea. There's a strict no zone, right? It's usually 100 microns. You say away from the fovea. And how many spots are given? Hundred spots are given. It can be given in the form of a C shape. Rescue laser is very less, but that is in case. Usually the requirement is not there.
Basically, PRP. You should know what is the rationale of PRP in any kind of neovascularization, NVD or NVE. How does PRP work? So basically, it is a hypoxic retina which is elaborating VEGF. So the amount of oxygen that is going in or any nutrients is insufficient. So basically, you destroy the peripheral retina, which is less functionally important. So you can divert the same to the central retina, which is more functionally important. Okay. At the same time, by destroying the peripheral retina, which is hypoxic, which is elaborating VEGF, you will also downregulate the VEGF production. So basically, you cannot increase the oxygen supply or the blood supply. You can only redivert the blood supply to the more important retina. So that is the whole idea of PE. So even though destructive, but it is saving the functional vision by rescuing the central retina. So this is the whole idea. Okay. So you should know all about PRP, like it is done in how many settings, what is the spot size, what is the number of spots that you can give per session, what are the immediate post laser problems, what if you do too many in one setting, and what are the latest advancements in laser therapy. Well, can you answer the last one? How can you make the laser treatment more easy for the surgeon as well as the patient? What is it called as? Have you heard of a pattern laser? So normally laser beam is one by one you are going to put the laser beam. You can have 25 spots like a pattern. Okay. At one time you can put 25 spots, just focus it. Okay. So the trade name is Pascal laser, but it's got a pattern. Okay. Laser where you can choose a pattern of 25 spots and put it there. You need to first know where you're hitting. You cannot be hitting the blood vessel or anything. So you need to first put that pattern there. Okay. And then when you apply laser, all the 25 spots will be at one time. So you can reduce so much time, less time. It will be much faster. What happens if you do too many spots? You get 1,500 spots in one setting. If you do, what will happen? Because severe inflammation, it can even cause choroidal detachment, the choroidal effusions, okay, because of the amount of inflammation that you are creating. Okay, what is the dreaded complication of CRVO, which is sight threatening? Neovascular glaucoma. Okay, what is the usual period that it appears?
90 days. 90 days.
Okay, so approximately 3 months, but it can be early, it can be late also. Okay, so that's why follow-up is up to 7 to 8 months we do. So normally by around 3 months, so it's called a 90-day or a 100-day glaucoma. Okay, so let us say you have a CRVO patient who did not come at the time when he had it. He has come with the neovascular glaucoma. Okay, so patient says he had lost vision 4 months ago and now he has come with a florid NVG. Cornea is extremely hazy because of the high pressure and he has got a florid neovascular, okay, vessels on the iris. So how do you manage him? It's a CRVO. First you have to control the intraocular pressure. Huh? Once the media clears, what will you do? No, how will you manage CRVO then? Okay. Now he has vision. I mean, it's not a no perception of light. He has some vision. Okay. Why? How does it make a difference? Huh. So what will you do? Cyclocryopexy. Okay. See, you should know what is the ideal treatment and sometimes what is the practical treatment. So here, as he said, if there's a visual salvage possible, you should try for that every time. The problem with a florid, CRVO with NVG is the media clarity. Okay, which is very difficult to reduce the intraocular pressure, sustained IOP drop to keep the cornea clear enough for the retina people to work on it for few weeks. It will take few weeks. When you give an anti-VEGF injection, it will take around 4 to 5 days for the rubiosis to regress. That you will visually see it, but it will not reduce the intraocular pressure. It will not make any change. It will make some changes in the retinal hemorrhages and the NVI, but the IOP won't come down. Already the angle is closed, zip, because of the fibrovascular zipping. Okay. So you need to use your medical management to bring it down, which is sometimes very difficult. Okay. So then you will have to go for a PRP. The PRP takes around 2 to 3 weeks for the effect to come. Okay. Then you have to do a definitive glaucoma surgery, like in case of trabeculectomy. So this is the usual teaching. So you basically treat the retina at the back. Once the neovascularization reduces, then you do a trabeculectomy, because if you do it in the actual initial period itself, it's very difficult to do a PI. There'll be hyphema, and because there's a lot of inflammation in the eye and the neovascular, of the angle, it will get closed very soon. There will be a failure of the trabeculectomy in such cases, and also hyphema is a serious complication. Okay, so this is the problem. But now with the advent of glaucoma drainage devices, which does not require a PI, we can actually put the tube into the anterior chamber, causing minimum problem. So you can do a Ahmed glaucoma valve implantation, even in a florid active neovascular glaucoma with CRVO, so that the intraocular pressure drops suddenly, IOP normalizes, the cornea clears, and the patient can be left to the retina department to manage the CRVO. Because what kills the eye in this situation is the IOP. Do you agree? It is not the hemorrhages at the back. At this point of time, why the patient becomes no perception of light and loses vision forever is the intraocular pressure. So if you just do a glaucoma drainage device as a first primary event, then you're taking care of the basic important factor, which is causing a damage to the vision. And now you have all the time in the world to manage the posterior segment. So you can reverse the sequence of things also. So depending upon the situation, you can first treat the IOP, then leave the rest for the retina people. Or if it is not such a severe case, the cornea is clearing with medical management. And very importantly, there is also inflammation in a neovascular glaucoma. It is not just intraocular pressure. Patients are very symptomatic in view of inflammation also. See, a lot of patients or chronic glaucomas come with 60 IOP and they're absolutely fine. But an NVG with 40 IOP will be extremely symptomatic. For one simple reason, it's an acute elevation. Number two, there's a severe inflammation happening in the eye because these vessels, there is a lot of blood aqueous barrier breakage. So you also have to put the patient on steroids. So you need to manage the steroids. You have to put all a neovascular glaucoma patient should receive, apart from anti-glaucoma medication, intensive steroids also, topical steroids, so that the patient becomes symptomatically better. It will also reduce the inflammation. Okay, so this is a very important thing. Anti-VEGFs have changed the way we treat CRVOs and NVGs, and the glaucoma drainage devices have really reversed the sequence and made it very beneficial now. So now we'll be able to salvage vision in most cases. So you finished the Viva?
Three case presentations.
ಹೌದಾ Viva ಮುಗಿಸ್ಬೋಣ ಇನ್ನು ಅರ್ಧ ಗಂಟೆ ಇದೆ.
We'll finish up with the Viva also.
ಯಾಕಂದ್ರೆ ಈ ಬ್ಯಾಚ್ ಮತ್ತೆ ಬರಲ್ಲ. ಈ ಬ್ಯಾಚ್ ಬೇರೆ ಕಡೆ ಹೊರಟೋಗ್ತಾರೆ.
Afternoon is a different batch.
No, this will be same. The batch will be different. Also, I think ಇದನ್ನು ಕೊಟ್ಬಿಡು. We'll start with this.
Okay. Sir is given here. This is looks like a pen.
It's written Ozurdex. So you can tell what is Ozurdex? Dexamethasone.
Intravitreal dexamethasone implant. So how much, what is the strength of this? 0.7 mg. So what are the indications for its use? Macular edema, secondary to same what we discussed now, CRVO, BRVO, or even diabetic macular edema. Okay. So for how long does the effect of this last? Usually around 3 months, roughly around 3 months. So if it is still persistent edema, we can consider a repeat injection of Ozurdex for 3 months. What is the advantage of this? Over, let us say, if we are giving ranibizumab or bevacizumab, what is the advantage of using Ozurdex over those for treatment of macular edema? Yes. Yes, the patient need not undergo multiple injections. But before you think of giving Ozurdex to a patient, there are few things you need to check. One is the patient should not be a known case of glaucoma, or at least should be well controlled. Okay. So what are the side effects? And of course, the patient should not be having any infection of any kind in the eye. Two things which you should always check for is no infection of the eye and no raised intraocular pressure. What are the side effects? Common side effects of this drug? Raised intraocular pressure and cataract. Yes. Yes, identify the instrument. What is the name of that bone punch? Citellis bone punch. Yes. Where is it used? In which surgery? External DCR. Yes. So, which bone are you going to use it on? Yes, lacrimal bone. How do you know that you have to reach that bone? What are the landmarks? Anterior lacrimal crest, the lacrimal fossa, and the posterior lacrimal crest. So, which is the first bone which you will be going through? And just prior to the bone punch, what step do you do? With the blunt dissector itself, you can just press. There will be lamina papyrus in that part. Very thin part of the bone will be there in the posterior part. Once you give a break, then you can put the bone punch and you can do. What is the ideal ostium opening? 15 to 18 will be too overboard. At least it should be 10 millimeters. It should not be less than 10 millimeters because of the risk of osteal closure. Of course, nowadays burrs have come, so they have an advantage wherein you don't get ragged ends. With this bone punch, there is a risk of getting ragged ends. So with the burr, nice clean ends we can get. So that is about the bone punch. You should be aware about indications and contraindications of DCR. So contraindications for DCR are young age, below 4 years, then nasal indications like atrophic rhinitis, malignancies, tuberculosis, and if it is an extremely fibrotic sac. What is this? This is a measuring caliper. So what are the uses of this measuring caliper? Yeah, for beginners, you can measure the length of your corneoscleral tunnel. Usually we want it around 6 millimeters, at the most 6 to 7 millimeters. So beginners can use this for cataract surgery, SICS. But more commonly, where do you see? We don't sit and measure the tunnels. Yes. In intravitreal injections, there it is very important. So where do we give in phakic individuals and where do we give in aphakic and pseudophakic individuals?
4 mm, 3.5 in, yeah. Why we have to go slightly away? So as we should not inadvertently hit the lens. So sometimes we have seen, because of the excessive use of intravitreal agents, sometimes a tract can be formed in the lens itself. Sometimes the intravitreal injection needle, if the person is not aware about it touching the lens, it can create a tract there. Then subsequently the patient develops a cataract in that particular part. So it will be a localized cataract, and then performing cataract surgery later would be a bit challenging. It is possible, but for the operating surgeon should be aware that there is a dehiscence of the posterior capsule in that part. Where else?
Measuring the graph size.
Glaucoma surgery. Yes. Anywhere else? More commonly used is in squint surgeries. You need to know, right? In squint surgeries, it will be used. Anywhere else where you need to measure from the limbus? Pterygium, okay. Doses, usually we don't make use of this. Other places for SFIOL, you need to know where you need to put the sutures or where you need to pass the needle. Where do we pass the needle for SFIOL? How many millimeters from limbus? About 1.5 millimeters. If you come closer, what may happen? You may damage what? Pars plicata. It will immediately cause bleeding and there will be hyphema. Okay, the entire thing will be filled with blood. So you have to be careful not to come any closer. Any other place where you need to do something from limbus? For cryoablation also, you need to measure. There you have to be around 3 millimeters away from the limbus. So this is about what is this? Jackson's cross cylinder. I think it's a favorite amongst examiners. If it is kept, you should know what it is. It's a sphero cylinder. It is available in two strengths, 0.25 and zero point 0.5. Okay. So it is basically used for verification, subjective verification of axis and power of the cylinder. Okay. So what is the principle used over here? How do we assess? Which one will assess first, the axis or the power? Always the axis is analyzed first. And axis, you can use either of them. This is more gross, doing for 0.5 is more gross. Axis is more important. Power you can always change 0.5 and check. But this is very useful for refining the axis of the given cylinder. Sometimes it's very difficult for the patient to tell for sure whether that particular axis he is seeing clearly or not. I'll just give an example. For example, if a -2 at 180 has been kept in the trial frame for an individual. So what we will do is make the person see the best line whichever is possible and then fog that by adding a +1. Okay. And then we place this Jackson's cross cylinder in such a manner that we have equal cylinder on either side of the given one. For example, if it is 180, I'll keep it like this. Okay. So I have a minus cylinder above and a plus cylinder beneath. So we ask the person whether this position is better, or you twirl it, flip it and ask whether this is better. One of the positions the person will tell is better. If he says it makes no difference, that means the given correction is correct. You don't have to proceed any further. But if the person feels in either of the position it is better, for example, with the red up, suppose he sees better and you have a minus cylinder placed in the trial frame, then you move that cylinder towards the red. You got the point? So here the cylinder is above. So from 180, you just move it slightly above. Say at 175, always the movement should be done only by 5 to 10 degrees only at any given time. You shouldn't move too much. You go on repeating that till the patient feels there is no further change in either of the positions. So this refines the axis of the cylinder. Is that clear? How to keep it is, this handle should be parallel to the given axis of the trial frame cylinder, so that you get equal cylinder on both the sides. Now coming to the power. Suppose you have a -2 at 180, already the axis is correct. Now you want to know whether -2 is correct or not. So you place this in such a manner that you are keeping the minus parallel to that minus axis. So here you will keep the minus cylinder parallel to that. Axis of Jackson's cylinder minus is parallel to the axis of the trial frame cylinder. Okay, and then you have to just turn it. That means you are adding a plus over here. So whether the plus is better or the minus is better. If minus is better, you increase, make it minus 2.50. If with the plus it is better, you reduce it, bring it to minus 1.50. Is this clear? So this is about Jackson's cross cylinder. Next, we have finished this. There are some simple instruments like this is, what is this? This is a colibri. Okay, it has a fine tooth at its end. It is swan neck shape. It's a colibri. So there are certain structures which you can hold, certain structures which you are not supposed to hold. For example, in cataract surgery, you can hold the conjunctiva with this, but you should never hold a colibri for trabeculectomy. You don't want to traumatize the conjunctival flap. So there we'll make use of Hoskins, non-traumatic type of tooth forceps. So that thing you have to keep in mind. You can touch the cornea with this, for example, for putting corneal sutures also. This is tooth forceps. What is this? Bowman's lacrimal probe. So this is used in probing in case of congenital dacryocystitis. So management of congenital dacryocystitis usually will be asked. So within 1 year, we do the curriculum massage. Then if it persists beyond 1 year, then you have to consider probing. So probing is available at different strengths. For example, it will be written over here. The number of zeros will be written over here. The more the number of zeros, the more thin it will be. Okay. So in very young children, you start with very thin ones. You should not traumatize it, basically. You're not supposed to traumatize. Some drugs are kept here. This is natamycin, 5% natamycin eye drop. So this is an antifungal. What are the indications? Yeah, fungal corneal ulcers only, but which type of fungal corneal ulcers this is preferred? The first choice in case of filamentous type of fungal corneal ulcers. But few things you have to remember, this drug will not very easily penetrate through epithelium, intact epithelium. So this requires frequent debridement. For better penetration, natamycin requires frequent debridement. Usually the course is refractory. You need to give it at least for 6 to 8 weeks. Usually by 10 days to 2 weeks, you should be seeing a positive effect. So you should know what you mean by a healing corneal ulcer. How do you know that this natamycin is effective and you need to continue with the same drug? Before that, before vascularization, infiltrates will reduce. Definitely the infiltrates will reduce. If the hypopion is there, it will again reduce. What is the difference between a hypopion in fungal ulcer and a bacterial ulcer? Sterile in bacterial. In Bacterial, it will be sterile. It's just a reaction, isn't it? Actually, every corneal ulcer, some amount of inflammation will be there. It's just a reaction. It is outpouring. There is no bacterial content there. Whereas in case of fungal, there will be fungal elements will be there. So infiltrates will reduce, hypopion will reduce, and you can continue. Suppose by 2 weeks you don't, then you have to consider either a change in drug or addition. Not many known side effects are there for this drug. There's one more drug here, antifungal. Let's finish it. It is written as 1% voriconazole powder. So this is also antifungal. Where all it can be used? This drug is used in treatment of fungal corneal ulcer. What are the routes of administration? See, nowadays even the ready to use eye drops are available, or if it is powder, it has to be reconstituted. So in the form of topical eye drops, then it can be given intracamerally. It can be given intralesional also. For fungal endophthalmitis, it can be given intravitreal also. One advantage of this over natamycin is it does not require any frequent debridement. It can be given even in presence of an intact epithelium. This drug is lubricating eye drop. So what are the indications for lubricating eye drops? Dry eyes. So before we go to dry eyes, we should know everything about keratoconjunctivitis sicca. What is primary Sjogren's? What is secondary Sjogren's? And other conditions where you will be giving lubricating drops for non-dry eye conditions also. For example, corneal ulcers, post-cataract surgery, nocturnal lag ophthalmos, post-trauma if there is a lid which cannot be closed properly. Frequent lubrication will be required in such cases. And for asthenopic symptoms. But if you have a person with keratoconjunctivitis sicca, there you have to use, we have to plan it which type of lubricating drop we need to use. So various ones are available with preservative, without preservative. We should know what are the preservatives used and what are the disadvantages of preservatives. Okay, so which preservative is the most notorious to cause harmful side effects? BAK, benzyl ammonium chloride. So we want it to be BAK free. So nowadays newer preparations are coming with oxychloro complex as the preservative. Totally, if it is preservative free, they don't come in the form of 20 or 2 ml, 3 ml packs. They come as single use unims. Those which are absolutely preservative free. For example, post LASIK or a chronic contact lens wearer or a very severe case of uh, keratoconjunctivitis sicca, where you don't want the side effect of the preservative, you should ask them to use preservative free lubricating eye drops. They are available as single use unims. Small unims will be there. Okay. So this is about lubricating. We have HPMC, we have CMC, 1%. This is eye ointment, Occupol. So it's a antibiotic eye ointment. Uses for this is usually for blepharitis. Okay. Especially in case of ulcerative blepharitis. For squamous blepharitis, you can use a steroid preparation with antibiotic. For posterior blepharitis, we call it as, it's nothing but MGD. So there the management changes slightly. So there we'll be doing more of hot fermentation, lid scrubs. You increase the omega-3 fatty acids. Okay. Doxycycline, where is it used? Yes. 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 It is used in case of strengthening of the cornea, basically in case of corneal ulcers. Yes, it can be used. What is the this thing which precaution which you need to take prior to starting this? Is it toxic to any system in the body? Small children, I don't know efficacy of that, but in adults, do you need to check renal function tests? Yes. Soline 6 is sodium chloride. It is available as eye drop and ointment. Hypersol 5 and 6. Okay. So indications for this is corneal edema. If it is an eye ointment, it has to be used once. Otherwise, eye drops you can use up to 4 times a day. So that is basically used for post-operative corneal edema. Next is ganciclovir, antiviral, okay, or acyclovir, whichever is kept, you have to answer that. Mechanism of action, it prevents the viral DNA replication. It is actually a synthetic nucleoside analog only. It will go and inhibit the viral DNA replication. Indications in herpes simplex keratitis. So how frequently is it used? It is available as 0.15%, whereas acyclovir is available in 3%. Yes, there it is 5 times a day. This can be used 5 times or 3 times a day. Depending if it is 3 times a day, you have to use for a slightly longer period of 2 weeks at least. Any prophylactic role it plays? Yes, in stromal keratitis following what? See, to prevent recurrence. Especially in say person has undergone keratoplasty, for them we have to use for months together. Usually it does not have much side effects. Another common drug is mannitol. Yes, this is mannitol. Indications? Yes, when you want the intraocular pressure to be reduced as early as possible. So it is used as a IV. What is the strength? 20% mannitol. And how much do we give dose? You have to evaluate per kg. 1 to 2 grams per kg body weight. So it's considered as a hyperosmotic agent, and it can be used even in people with diabetes. Unlike oral glycerol, this can be used in those people also. Which type of glaucoma will use this? Acute angle closure glaucoma. Yes, what is this? Simcoe? Simcoe cannula, yes. What is it used for? In cataract surgery for irrigation and aspiration of cortical matter removal. Any other use? Yes. In case of hyphema, to remove the blood clot through a paracentesis. See, few precautions you need to take whenever you use a Simcoe's cannula. Before you use one, you have to check the patency. You have to check whether the aspiration port and the irrigation port both are functional. And there are two types of cannulas which are available. The regular Simcoe's cannula, wherein the irrigation is from the side and aspiration is at the tip. Sometimes you have the reverse also. It's called as the reverse cannula. So you should make sure which type you are using. There's one more variation in this cannula. It's called as a J cannula. So earlier it was used especially for sub-incisional, wherein the side ports were not made, where everything was done from the main port. So for sub-incisional cortex removal, a J-shaped cannula was used. So this is about Simcoe's cannula. Then some lenses have been kept. You are very well versed with this, routinely used in OPD, and this is a 90 diopter lens. So you need to know some differences between 90D and 78D. Both are used in slit lamp biomicroscopy for fundus examination. So which gives a slightly magnified view? 78D gives a slightly magnified view. Always remember, whenever the magnification is there, the depth perception slightly reduces. So when you want better depth perception, go for 90D. When you want to have a slightly magnified view of the disc, for example, in glaucoma evaluation, you can use the 78D. So you want to know the depth in case of, say, macular edema is there, you go for a 90D. I think this also you are well versed with. This is a 20 diopter lens. 20 diopter lens, and you need to know the magnification which you see with this. In IDO, usually what is the magnification? Around 3x. And the field of vision. See, in this 90D and 78D, at the most you'll be seeing till the equator only. Whereas here you can see, with the help of indentation, you can see up to ora serrata also. So it is very useful in complete evaluation. There are some charts which have been kept over here. So this is called as a Amsler's grid. So this is a conventional type wherein we have a white background with black grid lines. So what are the different types of Amsler grid which are available? 7 types are there. Yes. Black with white or white with black comes under similar, the type 1 only. Some people, they cannot fixate at this. So in them we can make use of diagonal lines. I think you can go through the books wherein we have black background with red lines also, isn't it? So basically, where is this used? Uses you need to know. For macular diseases, like especially in case of ARMD. So some form of metamorphopsia they will be having. So either there will be distortion of the line, or the some part of the grid is not visible to the person. So depending on where it is, we get to know whether person has got some scotoma or wavy lines. In case of epiretinal membranes also, they'll have this, that macula pucker. There also they'll have a distortion of lines. This basically helps in evaluating the prognosis, whether the number of injections which have helped or not. So management of ARMD, usually we'll be giving anti-VEGFs, right? So if there is a CNVM, we'll be giving anti-VEGFs. So every time in the follow-up, we can do this to know whether there is improvement or worsening. What is this? Balanced salt solution. How is this better than ringer lactate? Main is the pH. It's a very physiological pH. Around 7.4 is used. And it is perfused with various salts like sodium, potassium, calcium, magnesium, all that which is required. This is Perkins tonometer, I think handheld tonometer. Can you just open it? Yes. So the different types of tonometers you need to know. Okay, we have indentation tonometer and applanation tonometer. Indentation is out of this thing nowadays. Nobody uses a shear tonometer. So in applanation, again, we have different types. Goldman is the main one. In that again we have handheld and the one which can be used with fixed to the slit lamp. So here the advantage of this handheld is it is portable. So we can go, especially in case of pediatric glaucomas. For example, in pediatric glaucoma evaluation, you can't go on giving a GA for each and every investigation which you need to do. So in pediatric glaucomas, usually this can be carried to the OT where the GA has been given. You can do a direct gonio there itself and check the intraocular pressure and evaluate the optic nerve head in the same sitting itself. Next is what are the uses of prisms in ophthalmology? So we divide them into diagnostic, therapeutic. Diagnostic, wherever remember you want the ray of light to bend, you need prisms. Wherever magnification is there, again you will end up using prisms. So you name the instrument, wherever magnification is there, some amount of prism will be there. Like operating microscope, slit lamp, your doubling prisms are there in keratometer. Then diagnostic, where else? I'm holding, for example, the prism bar cover test, single prism for Krimsey's test. Then I think the first case which we discussed, there also prism was used to know the amount of deviation basically. Okay. Therapeutic, where do we use prisms in treatment? One is to overcome diplopia. Temporarily we can use Fresnel prisms can be used. If a person has got a convergence insufficiency, there also we can use. Whenever a very high plus lens has been given, that will cause strain to the eye. So we incorporate a weak prism so that both the eyes can converge in near position. Such glasses are used by which type of professionals? Watchmakers and goldsmiths. Because they'll be wearing a very high magnification, they'll end up with eye strain at the end of the day. So weak prisms are incorporated in their spectacles. So the prism bar cover test is basically for measuring the amount of deviation. So we have a horizontal and vertical both to measure horizontal deviation and vertical deviation. Even single prisms are used, that is for Krimsky's test. Are we left with anything else? What injection is this? Vitamin C, folic acid, it's all multivitamin. But basically to discuss vitamin C, where is vitamin C used in ophthalmology? Subconjunctival hemorrhage, okay. In management of corneal ulcers, it will be given. See, vitamin A is basically required for normal functioning of the epithelial structures in the body. Vitamin C, wherever collagen connective tissue healing is required, usually vitamin C helps. So both have got a role in case of corneal ulcer management. Both vitamin A and vitamin C can be given. Vitamin C is available in the form of oral tablets also. 500 mg milligram tablets. You can give BD or TID also. In fact, now in the recent, you can add one more use of that. COVID. It has been given as a supplement throughout COVID. It was given up to QID. Safely up to QID was given. I think that covers almost all the instruments and things which have been kept here. So all the best for your exams. Have a good day. Over here, we just missed out. It is important, and that is Ishihara chart. So a question may be asked about color vision assessment in a person. So it could be congenital or acquired. So this congenital is usually seen in what type of inheritance is it? X-linked recessive, right? So it will be usually seen in males. About 8% of males we get to see this. Routinely, ECRS chart is used in the outpatient department. And I think if you would have counted, there are about 38 plates in this. So the first plate, if you have observed, is always a number 12. And it has been given in such a manner that even a colorblind person should be able to read it as a number 12. And similarly, there's one more chart wherein they have to just trace the line that is probably at the end, and that is again something which even a colorblind person should be able to do. It's at the fag end of this, the last plate wherein every person should be able to do the 38 plate. Okay. In between, four plates have been kept in such a manner that few plates, a person with normal color vision initially will be able to identify. Colorblind cannot identify the next four plates. Okay, the next four plates only a person with normal color vision will be able to analyze. After that, after the 8 plates for red and green respectively, there are some in gray shades. If you note, there are in gray shades. And in some, a normal person cannot see any number, but a colorblind will be able to see some numbers. So these are called as hidden numbers, which they will be able to appreciate. So red green deficiency person, for example, will see a 2, but a normal person, normal color vision person may not perceive any image. Similarly, the gray ones with some number written on it, they'd help to differentiate the protanopia from deuteranopia. Okay, this is a crude method because it does not tell anything other than whether this color deficiency is present or absent. It does not grade. So which method is better? 100 UTS, isn't it? That is much better because it helps even for subtle shades of deficiency also it will help. So what are the acquired causes for color deficiency? Macular diseases. It is optic nerve diseases also. Which color is more lost in case of optic nerve diseases? Red color. More in case of macular diseases? Yellow. So that is about this also. I think we have completed all of them. So all the best.
Without mic.
But there it will be audible on the Zoom.
Zoom.
Yes, yes. Yeah, because it was coming in through better radio masks. Every station approach.
So, okay. I request one of you to present this case, diabetic retinopathy case. Any of you, just volunteer. I mean, this is the place. I mean, make use of this opportunity to make maximum mistakes. Okay, fine. Go ahead and be loud. Okay.
Mrs. Rajeshwari, 65-year-old woman, hailing from Bellary, homemaker by occupation, came with chief complaint of diminution of vision in both eyes since 1 year. Patient was apparently normal 1 year back when she noticed diminution of vision in both eyes since 1 year, which was insidious in onset, gradually progressive, not associated with pain, redness, watering, photophobia, no history of trauma, no history of wearing thick glasses. There were no similar complaints in the past. She's a known case of type 2 diabetes mellitus on oral hypoglycemic drugs and insulin since 20 years. There was no history of hypertension, bronchial asthma, ischemic heart disease, or stroke.
So, in your history, you mentioned so many things, no, like a history of no renal problem, cardiac problem, and insulin. What is the importance of this history? Did you ask this history for the sake of asking, or can we link these history findings to our ocular findings?
Yes, sir.
Hmm?
Diabetic can cause microvascular problem or microangiopathy.
So microangiopathy can happen anywhere. For the moment, let's forget this patient has diabetic and whatever. She may have anything. Okay. So, for example, if the patient has some cardiovascular ailment, so what are all the cardiovascular diseases which can have eye manifestation, or but they will all. Okay, okay, fine. No, now it is okay. Okay. So, can you mention some diseases of cardiovascular? We can have some bad impact on eye. So, thing is, per se, they can have a manifestation or they can worsen existing eye conditions. What are they?
Septal artery.
No, that's an eye. I'm asking cardiovascular diseases.
Ischemic heart disease.
Exactly. Ischemic heart disease. What risk it will carry? Okay. Hypertension, carotid stenosis. Okay. It can cause ocular ischemic syndromes. If the patient has undergone some valvular surgeries, they are prone for developing embolic episodes. So the Chinton can lead to CRAO and BRAO. Okay. So then in case of any history of ischemic endocarditis and all that. So anything, whatever you ask, it should have some relevance. In case if the examiner stops you at that point, so simply why did you ask? You should be able to defend it. So that's what. So don't go on mentioning everything just for the sake of it. Mention only those things which you can link, and if you're able to defend it, if the examiner asks a cross question. And also insulin, it's written 20 years. Why is it important?
Know the control of sugars.
Yes, insulin is an first thing is you need to know the from how many years they are taking insulin. So because we don't know whether it's a type 1 diabetes or a type 2 diabetes. Okay, because both type 1 and type 2, so the prognosis of ocular features will differ. The how you manage, the follow-up you call, prognosis, everything will vary depending on is it a type 1 or type 2. So that is one thing. And the second thing, as she rightly mentioned, it is an indicator for glycemic control. For example, whose patient was an oral hypoglycemic agent, if he or she has been shifted to insulin recently, so that indicates so glycemic control is not been that great. Okay, so like that. So this is just an example. Like this, whatever the leading questions you ask to rule out negative history, you need to have a logical explanation for that. Okay, fine. Next.
Insulin, when you ask, you also should ask about the units they are taking. Okay, if they are taking about 10, 12, or 14 units, which is less than about half of the body weight, then probably it means it's still a reasonably well controlled. But you will have people who are having about 30 units of insulin. There itself, you know that when the insulin requirement is more than 1 unit per kg body weight, it indicates that the glycemic control is very poor. So mentally, you are already thinking that you are thinking more in terms of diabetic or diabetic retinopathy complications. So clinically, you can just have a note of that.
Basically, you need to give a patient holistic approach when you take the history. Remember, even for autoimmune disorders, anything in the body can be linked to the eye problem. So whatever the patient, in case if they try to tell, don't ignore it, it may have some relevance. I'm telling this point not only from exam passing point of view, even in your practice, this holistic approach is very important. Okay, fine.
Patient had no similar complaints in the family. She had a mixed diet with undisturbed sleep, bowel, bladder, regular. Patient had mixed diet with sleep undisturbed, bowel, bladder regular, and no addictive habits. General examination was unremarkable.
So what is the general physical examination we should like to,
Pulse
what
rate,
is the importance of general physical examination?
pulse rate, BP, and
No, no, all those are what you do in. Why?
to,
Okay, peripheral neuropathy is an indicator of okay diabetes. Then what else you check for general physical?
any hypertensive
Wounds, all those
components.
pickle is there, no pallor, icterus, and all that. Why you should look for those things?
It,
Yes. What if there is a
systemic
pallor?
anemic
Exactly. So the thing is,
cons.
most of the times, not most of the time, there are some case reports which have been published where anemia itself can manifest as mimic diabetic retinopathy. So unless and until you correct these existing disorders, whatever you give the local treatment in the form of panretinal photocoagulation, injection, will not have optimal effect. Okay. So for example, if the patient has proliferative diabetic retinopathy with an associated anemia, again, what happens? It will worsen the existing clinical scenario or not? It will definitely, right? So most of the advanced diabetic retinopathy complications happens because of the hypoxia. Hypoxia means less oxygen delivery. So as such, there will be an hypoxic condition in diabetic retinopathy. Along with that, the patient is anemic means it is basically adding salt to the wound. Okay. So similar way, if the patient has an ASD, a VSD, shunting disorder, cyanotic, again existing this thing can worsen. Like someone mentioned pedal edema. Okay, that will give an indication for either cardiac or renal parameters. If the patient is renal parameters is not great, it's a lot of protein loss, and you have some exudative macular edema, don't resolve no, unless you go and correct those things. Okay, so all these things are important. Okay? So just don't mention okay general physical examination normal. Whatever the thing you mentioned like lymphadenopathy, cyanosis, everything will have a this thing.
Sir,
And one
ocular
more thing, what is important in anemia? Why is it important? That
anemic
is one way I've already discussed. Okay? Anemic retinopathy, sometimes correcting anemia itself can correct this retinal manifestation. You want to know his HB, no? For example, patient with low HB, if his HbA1c is 6.57, it's not relevant, right? So HbA1c in an anemic patient which is like 6.5, it's a pseudo indicator that it's a good glycemic control. Okay, for HbA1c to be relevant, first is HB should be normal. Okay, so you can't take 6.5 HbA1c as normal in an anemic patient. Okay, so first of all, you need to know what is this thing. Fine. Next.
ocular examination. A patient had erect head posture, facial symmetry maintained, and was orthotropic. Right eye uncorrected visual acuity was 6 by 36, improving to 6 by 18 parts on pinhole. Best corrected visual acuity was plus 1.5 diopter spherical with plus zero point 0.5 diopter cylinder at 180 degree. Near vision was N10, improving to N6 with 2.5 spherical lens. Um, uh, Lid and adnexa was normal.
Why refraction is important? Let's assume this patient has some diabetic retinopathy, whatever it is. So why is refraction relevant here? So one is basically to know if it's not improving, is there any macular
Macular
complications
cataract.
because of which it may not be improving? Then what else? Okay, very good. Second is glycemic fluctuations can itself cause fluctuation refraction. Then that way the diabetic retinopathy, all that is come. Then, is there any particular types of refractive error which Huh? Hyperopia is what? No, if a patient is diabetes since 20 years, if it's a high myopia, whether is that a protective factor for diabetes or risk factor?
Protective.
Huh?
Protective factor.
Yes, high myopia is a protective factor from developing diabetic retinopathy. Now, next question is why? Damaged. That means all those myopes were wearing glasses. Yes, you know the answer, but she's not telling it the thing. So basically, in myopia, as such, the retinal thickness, everything is thin. There's some dystrophy. The metabolic needs of retina as such is less. So obviously, this is a metabolic disorder, right? Diabetes. The final common pathway it has to start from those all those glycation and products and all that. So since the metabolic demand as such is less in myopics, obviously diabetic retinopathy related and its complication will be less. Okay, so this you should know.
The thing is, the surface area of the retina is also increased.
Yes, yes.
So the thinned out fibers and more surface areas, they are just able to maintain a balance between the oxygenation requirement and the need of the choric capillaries.
Conjunctiva cornea normal, AC normal depth with Van Herrick's grade 3. Iris normal color
Does
pattern
your
and no
AC
NVI.
normal, does it end with that? Is there anything which you want to do in AC? Kinetics you
NVI.
told. Yes, very good.
NVI.
New acceleration where?
Iris
Angle. So ideally, all
angles.
diabetic patients should undergo a must gonio undilated gonioscopy. Okay, because sometimes you never know anterior segment neovascularization, especially in the angle, may precede posterior segment neovascularization, especially in the vascular occlusive disorder, venous occlusive disorders, and this is a known thing. At this point, you don't know what patient has, but you have to examine them comprehensively. Okay, and iris always look for any diabetic patient when you describe the examination findings, when you describe iris, mention whether NVI is present or not. And what are the grades of NVI? Go and read. Okay, there is a classification of NVI and there is a name also given for that. Teak and Walsh classification. So you need to, if someone asks what are the grades of NVI, you should be able to answer that. Fine. Next.
Lens.
So never forget this. Not only for exam, even when you are practicing, without gonioscopy, your examination is incomplete. Okay.
Lens showed a cortical cataract with an nuclear sclerosis grade 2 and a posterior subcapsular cataract. Anterior vitreous face was clear. I'll finish the left eye or I'll continue fundus.
Left eye also more or less. Yes, same. See, most of the time in exam, what happens is at this point, the examiners will not be patient to listen to all this. The thing what they ask is tell the positive findings. It happens in 95% of the examination. We are discussing in detail just to cover all the aspects. They'll ask for positive. Now tell the positive findings.
Of left eye, sir.
Both the eyes,
Both
positive
eyes.
findings.
Both eyes show decreased vision. Right eye 636 and left eye 612, but they are improving on pinhole. There are no significant changes with lid adnexa, conjunctiva cornea. AC is normal depth, and lens shows cataractus changes in both eyes.
Yeah. Fundus positive findings.
Fundus positive findings of right eye showed right eye shows vessels are arising from center, but the AV ratio is not appreciated because of
No, I can appreciate the various. This is a gross arterial thinning, right? Is it normal 2:3
arteriolar
or thinning? Yeah.
1:3
Yes.
suggestive of
So,
arteriolar.
and she's not an non-hypertensive. So this should give a clue that maybe it's a combined retinopathy. Okay. So you need this warrants regular BP monitoring for this particular patient. Look at the arteries. Okay. It's not a look at the arteries and venous ratio. They're quite attenuated, and look at the crossings. There are some nicking which is happening, right? There are hypertensive retinopathy changes also in this patient. And the veins, what are the striking change?
So, veins look tortuous,
Tortuous.
suggestive of
Tortuous. Is it dilated, or is it what's exact, which is a grade of diabetic retinopathy?
venous looping,
Excellent. It's venous bleeding is seen as
bleeding.
obviously. I've seen the CRVO cases. The tortuosity is that one. Okay. It's an obvious venous bleeding which is happening, which is maybe making you people see it as maybe it's tortuous, dilated, and all that. So that place is carefully observed. It is constricted. It's a classic bleeding.
Sir,
Then
sir
never miss. Most of the time, people will have the tendency of missing this venous findings. Arteries you will tell attenuated and all that. Crossing changes also you will tell. End up telling. Venous changes never forget. It's a part of EDDRS grading, right? Venous changes. Yeah. So it is important. Never miss that.
Background retina shows numerous red pin-headed shaped lesions, not continuous with blood vessels, suggestive of dot hemorrhages, more in the temporal quadrant along the more in the superior temporal quadrant. Um, then there is retinal thickening seen at the parafoveal area, and it was confirmed using a slit lamp microscopy with plus 90 diopter lens. And the yellow waxy lesions with distinct margins suggestive of hard exudates arranged in clumps at posterior pole, present inferiorly and superiorly in the temporal quadrant, adjacent to the fovea, with adjacent retinal thickening. Fibrous band is uh, proliferation. Uh, Left eye with distant direct ophthalmoscopy at one arm distance showed a good red fundal glow. Distant direct ophthalmoscopy close to face revealed clear media. Disc was vertically oval, normal in size, pink in color with well-defined margins and having a CDR of 0.3 with healthy NRR. Neuroretinal rim. Vessels arise from center of disc branching dichotomously and having an AV ratio of 1:3, suggestive of arteriolar attenuation. Background retina shows venous bleeding is caliber is variable along the venous. Background retina shows numerous pin-headed shaped lesions not continuous with blood vessels suggestive of dot hemorrhages in more in the temporal quadrant. Yellowish waxy lesion with distinct margins arranged in clumps were arranged in clumps, 2 disc diopter temporal to disc and also 2 disc diopter temporal to the fovea, suggestive of hard exudates. A dark red, well-defined lesion with accumulation of blood is seen in the inferior retina, obscuring the view of underlying retina vasculature, suggestive of vitreous hemorrhage.
Is it vitreous hemorrhage? The way you described was very excellent, but someone else other should comment. What kind of an hemorrhage? It's a pre-retinal where vitreous or subhyaloid. Subhyaloid. So why is it subhyaloid hemorrhage, and why is it important for us to differentiate this location? What is the prerequisite for a subhyaloid hemorrhage? Excellent. Posterior vitreous detachment should not have happened. Posterior vitreous should be an intact one. If there is a complete PVD, SHH is not possible, right? So attached hyaloid compartmentalizes this blood. So that's why it is have a well-defined border. Sometimes the boat-shaped hemorrhages and all that you can get. That's a clue that it's a subhyaloid hemorrhage and PVD has not happened. Why are we so concerned about this PVD status? Vitrectomia. Yes, the tractional the most blinding complications of diabetic retinopathy happens when the PVD starts happening, which leads to tractional retinal detachment. So PVD is a physiological process, right? Normally, it will try to separate from the retinal surface. In diabetic retinopathy, what happens? This blood vessels will grow into the scaffolds of vitreous phase. There's a fight. There's a natural process which is trying to separate from the retina, but these blood vessels are not letting that happen. In the fight, retina suffers and retina gets detached. So if the diabetic retinopathy happens in proliferative diabetic retinopathy in a patient who has already PVD, these blinding complications will be less. At the max, we develop vitreous hemorrhage, we can clear that, we can do PRP. So if they develop anterior segment neovascularization, NVG, that's a different ball game. So otherwise, having a PVD is a protective factor. If the PVD is not there, so all those things are there. That means the moment you see SHH, that means there is no PVD. So if there is a PVD, SHS is not possible, right? So for that reason, where is the localization of the level of hemorrhage and its clinical significance is important. Next, and never miss this SHH. SHH will be very typical, no? It's very difficult.
Macula showed a dull foveal reflex with retinal thickening, which was confirmed on slit lamp biomicroscopy with plus 90 diopter lens, and the indirect ophthalmoscopy showed peripheries were normal. Provisional diagnosis: right eye proliferative diabetic retinopathy, and left eye high risk proliferative diabetic retinopathy with subhyaloid hemorrhage.
What is missing in a diagnosis? Exactly. So whenever you diagnose, even though it's a posterior segment case, don't miss the anterior segment diagnosis. There's cataract also, right? So that needs to be mentioned. Even for if they have some, maybe having pterygium or corneal this thing and all. So diagnosis has to be comprehensive. You need to mention everything about the diagnosis. Okay. So, and especially if you sit for exams like FRCS and all that, the next question they ask is, you mentioned high risk. Why is it high risk?
Sir, we subhyaloid hemorrhage is there.
Subhyaloid. What are the
Already
definition given for high risk PDR in ETDRS? Yes, excellent.
NVD.
Yes. Then? Vitreous hemorrhage, precluding the grading of the diabetic retinopathy. Okay. So all these four criteria you need to know, like to diagnose as this thing high risk PDR. Okay. So at history level examination, any doubts?
One extra point which probably I would expect is when you are mentioning about a PDR, you also have to mention about cystoid macular edema, CSME. So the macular status should be there. So if you have to give a diagnosis completely, how would you like to reframe this diagnosis? Right eye and left eye. You can try out. You have the findings. Complete diagnosis.
Right eye proliferative diabetic retinopathy with
Senile cataract. Yeah. With
the clinical
macular edema.
edema.
Again, we always people have the habit of missing out this anterior segment. This thing because of posture, never miss out. You never know your examiner may be an anterior segment person. You not know this thing. They may feel the retina person. They will ask. Then they will ask about anterior segment. You miss that. Now they will go to the cataract management. All those things. Never miss that.
At your level, you are treating the patient or you are referring the patient, right? So if you have to treat the patient, you are treating the patient as a whole. So even if it is a fungal ulcer, even if it is a uveitis case, even if it is a retina case, never miss the comprehensive diagnosis, because that is what is expected at your level. Okay.
Exam basically they want to assess when you pass this person, is it going to cause some harm in the society or not? You may not be able to do so. You have to develop that knack of developing comprehensive diagnosis, comprehensive approach to the patient. That's why I was stressing upon systemic history and all that. The more and more you focus on this thing, you may not do it intentionally. That will give an impression that this person has read only retina, it doesn't know cataract, or if it tell only about cataract in detail, this person is not like that. Your answers it will be balanced and comprehensive, whatever you want. But how will you manage this patient? No, that's not given an answer. What? How will you manage the patient? Loud, loud. Not manage. First, you need to order some investigations, right? Yes.
Okay, no.
Management include two parts, right? Investigation and the treatment part. What investigations? Excellent. Blood test. What all blood tests you will do? Okay. Before doing that, anything else you want to order? We discussed earlier. CBC you need to do. No? Yeah. You never know. It could be maybe having some myeloproliferative disorder. Can also have some manifestations like this. No? Then other metabolic parameters, blood urea, serum creatinine, lipid profile, renal profile, LFT, AV, yes. And whatever that comes out abnormal, we need to address everything. Okay, diabetic retinopathy management requires all these things. It's not like a patient does not give injection, do laser. It's not like that. So fine, you are to the blood test. Then next, yes, yes, you need to get an OCT done. Why OCT? In this case,
To confirm the
okay, you mentioned in the diagnosis clinically significant macular edema. I want to confirm the extent and this thing. So what are the patterns of diabetic macular edema which can be seen on OCT?
spongy and cystoid.
Spongy,
Cystoid.
cystoid with neurosensory detachment. Grade 4 is taut hyaloid with traction without RD. Grade 5 is traction with RD. Why this classification is important? Yes, excellent management. Up to grade 3, it's medical management, either focal laser injection. Once it goes to traction and this thing, you have to do a surgical management by doing vitrectomy and all that. So that's why you need to do an OCT. Okay, then what else? What else you look for in OCT? You need to look for photoreceptor, no, whether the outer segment, whether the ellipsoid zone and ISO is disturbed or not. Okay, which indicates the long existing macular edema. Right? In which case, even if you bring down the edema, vision may not improve to a great extent. And also, you need to look at the inner retinal characters. Is there any disorganization of inner retinal layers, which can indicate macular ischemia? So along with this pattern of edema, whatever I described, these things also you need to note it down. And also the hard exudates extent. So these hard exudates may be there in the parafoveal region. Once we give injection, once the edema subsides, they might migrate to the center and form a thick plaque, which will never go. So these things also you need to assess in the when you do an OCT for any diabetic patients. So then what else you do? Would like, okay, FFA is telling why you will do FFA in this patient. Neovascularization is seen probably preretinal membrane, subhyaloid hemorrhage, NVD, everything is there. Huh?
macular
CNP areas, why anyway we are going to ablate.
macular ischemia.
Excellent. So you need to know the whether macular perfusion status. Okay. Otherwise, we don't do FFA in this particular case to rule out the proliferative process because clinically it is seen obviously, right? If you want to do an FFA, it is to assess the macular perfusion status. So there are some OCT clues also. Recently, they have come, whatever I described few of them. So in this case, if you want to do FFM means it's not for ruling out NV, NVD or these are there to look for perfusion status of the macula. Okay, fine. OCT is done, FFA is done. Then how will you treat this patient now? In blood investigations you have done.
Sir,
So for example, I'll say OCT, what I was grade 3 that macular edema,
Go for the pars plana. Plana PP. Anti-VEGF and pars plana. PFP. 3 seconds.
When it comes to LIO laser, whereas in Pascal, the scar expansion is less, you can give more number of burns in a single sittings. Okay. So, and sometimes if there is any, what are the, I mean, things you counsel the patient before you give this injection or PRP?
Vision.
This is one of the favorite FRCS question.
Vision
In
might
that
go.
FRCS, when you, if any of you are planning to appear, they'll be least bothered about your diagnosis and all that. And most of the time, the examiners will be expressionless. Even if you answer wrong, they won't tell it's wrong. Even if you answer right, they would be knowing what you are going to counsel the patient. Okay, tell me,
Vision
yes.
might drops.
No, what complications can happen because of the first anti-VGF and constriction of field that can happen is any laser, that is laser related complication that you need to counsel. Then I didn't get what? No. See, there already you saw something nasal to the disc. No, there is what was there fibrovascular proliferation. No? Those can contract and then traction can increase, right? Which can happen with both anti-VGF and also the lasers. Okay, you need to caution them against this one. And even when you are doing this laser, better to avoid these areas where the probably the contraction is going to worsen. And this contraction, if it extends and it becomes a macular threatening, we may have to go and do surgery, vitrectomy.
How does anti-VGF act? It causes something called as a vascular crunch. So it causes something called as a vascular crunch. So whatever fibrous tissue is there, it is accelerated to form more amount of from immature fibrous tissue, it becomes more mature, and hence it can cause tractional detachment. So when you are talking about the management, now sir is retina surgeon. I am not into retina that much, but in this case, what would be the other intravitreal agents which you would like to explore?
Steroids.
Okay, steroids. So which steroid?
Triamcinolone.
Okay, what about the dosing?
Dexa implant. Dexa implant.
Okay, that is, what is it called?
Ozurdex.
Ozurdex. Okay, and what would be the reason for using steroid?
Fibrous bands.
Okay, now one point sir had mentioned when you are talking about the presence of hard exudates or edematous areas, that time I don't know, but probably anti-VGF is done under the cover of steroids because the steroids stabilize the membranes and then the anti-VGF drains the fluid. If you use anti-VGF alone, then it precipitates the proteins and causing more amount of hard exudates. Also, in this case, if you see the fibrous tissue which is there, so nasally, one point which probably everybody has missed is what you are seeing here. You are seeing the posterior pole only. You all have not seen the periphery. So when you are asked in the examination, you should first tell that I want to check the entire periphery. There may be some proliferative tracts or there may be some FPPs or tractional detachment already in the periphery. So what you are looking at it is only at the central posterior pole. So whenever you want to talk about it, you should tell I would like to see with an indirect ophthalmoscope the retinal periphery. Okay, or else you can ask for a widescreen, what do you say, wide field imaging, so that gives you a more complete picture of the retinal condition.
Also, there can be a fractional element that you're discussing, there could be a small micro breaks also, in which condition we call it as combined retinal detachment. So these also you need to note down. And steroids, as sir was telling that it will, the chances of hard exudate migration is also less when you use steroids. And the contraction of this proliferating membrane is also less when it compared to anti-VEGF. Whereas when it comes to regressing this floridly looking NVEs and NVDs, anti-VEGFs are good. Okay, but anyway, you should always counsel this patient. They probably might end up requiring surgery. And when you're planning for any steroids, always keep this glaucoma also in mind. Okay, steroid responsiveness. As such, they are risk for developing this neovascular glaucoma and all that. But as I rightly mentioned, this will still have a role to reduce the amount of exudation, the tissue contraction, the fibrocytes accumulation. All that will be less when you give steroids. Okay. So, but as I always, when I teach my fellows, I mentioned there is nothing, there is no like a single track of management for diabetic retinopathy. It has to be a tailor made. So, it depends on what exactly the patient has, which drug might help, and all that. So, in this particular, as there is an solid vascularization also is there, edema is also there, and the tractional bands is also there, which is slight contraindication, but it's not okay. Periphery we have not seen. So that much usually it will not cause that much of worsening of thing. So by giving anti-VEGF, you are conquering two things. One is you are addressing the edema part. Second thing is the proliferative process also. So and that will act for at least 3 weeks. In between, you can complete your laser. Other thing, what happens if you directly do the laser? One is contraction and also existing macular edema can worsen. So earlier, when there was no intravitreal injection, no, for that reason, any patients who was undergoing PRP, there used to be a prophylactic focal laser also, so that the macular edema should not worsen. Yeah. So
Tell with sir, the only time when you have a blanket plan for treatment of diabetic retinopathy is when you're giving the exams.
yeah.
Once you come into the clinical practice, each patient is different and you have to tailor made.
Any doubts in diabetic? See, diabetic retinopathy, I went in some detail, all the points, because diabetic retinopathy is very important. And you are not allowed to make mistake when you are presenting a diabetic retinopathy patient. At the level of post-graduation, you are supposed to know everything about diabetic retinopathy. And there is 90% chance you may get diabetic retinopathy as one of the cases. Okay, most of you will have. And if you answer well in diabetic retinopathy, it's very easy to pass also. If other rare things, if you have got some neuropalsy, some contracted circuit, they may still excuse and all that. But if you fumble in diabetic retinopathy, that will give a bad impression on you for examiner. Okay. So all this, whatever we described from the history level, systemic investigations, everything is important. You need to know the classification anti-VEGF, the laser, how it acts, and the last thing is landmark clinical trials, DRVS, UKPDS, ETDRS, and DRCRNet. Okay, these are like must-know study. These are all landmark trials which give the treatment how it should be. DRVS, UKPDS, ETDRS, DRCRNet. Okay. There are other studies also which you need to know, but these are like must-know. You have to know. Okay. So still, like most of the treatment what we gave when we do laser and all that, most of the guidelines it has come from the ETDRS. Okay. So anything else? Any doubts so far regarding this particular case? Yes. Yes, of course. If it's a myopia and all that, why not? Myopia is a diagnosis. And when it comes to diagnosis, don't avoid mentioning the findings. Finding is a different, diagnosis is a different. High myopia can be a diagnosis. Why not? Yes, you can definitely mention. Yes, definitely. Why not? With hypermetropia, stigmatism, pathological myopia, whatever. Diabetic retinopathy, case presentation, management, treatment, investigations, clear, crystal clear concept. Exam. So read diabetic retinopathy. Okay. discuss with your colleagues and all that. So otherwise, all our exam going only, right? Any first year, second year, first years, all exam going on. Second, first year. When most of your reading you'll experience, when you're reading for the fourth time, you'll feel like you're reading for the first time again. So that's how it is. So that's why try to remember things by logical reasoning, why it's happening like that and all that. That won't make you forget. If you just read for the sake of the present testing, okay, no pedal edema, no pickle, no pallor, no icterus, no cyanosis, no clubbing, ball bladder, not like that. Each and everything, whatever you tell, you think of it. Why is it like that and all? So that it will help you also to write in theory also. So if there are no more questions in diabetic, shall we move on to the next case? Okay.
So just to make a little bit light of it, it is like if you look to your right, look to your left, you will see two of your colleagues. One of y'all will get a diabetic retinopathy. Okay, so it is as simple as that. So
More than that, actually.
yeah.
GNP exams and all that, one case will be diabetic.
Okay. Corneal ulcer presentation. Anybody wants to volunteer? Go ahead.
A 40-year-old female comes to the OPD with pain, redness, and watering in the right eye since 20 days, with diminution of vision in right eye since the last 15 days. History of present illness. Patient was apparently normal 20 days back when she developed vague discomfort in the right eye, after which she rubbed her eyes. Patient gives history of using locally available eye drops, after which redness and watering developed. Patient complains of dull aching, constant pain localized to her right eye. She also complains of diminution of vision in right eye since the past 15 days. It was insidious in onset, gradually progressive for both near and distance. There is no history of eye trauma, no history of contact lens wear, and there is no history of any skin lesions. Coming to past history,
I'll
there
just
is
interrupt you. What was this history of any skin lesions? Okay. So when you're talking about herpes, then you have to talk about no history of any periocular skin lesions. So patient may have a foot patch, doesn't contribute to the history. So you be specific.
past history, there is no history of ocular surgery in the past, no history of similar episodes in the past, and she doesn't have diabetic, hypertensive, or any other systemic illness.
So can you summarize the history?
40-year-old.
Okay. Okay. So can you summarize the history? You need to be a little bit loud. Is it she or me? Okay, both of us need to scream. Okay. So probably
A
yeah.
40-year-old female, she complains of pain, redness, and watering in her right eye since 20 days. And she developed, I have to say, she was normal 20 days back, following which she had these symptoms, after which she rubbed her eyes. She used some over-the-counter medications, following which it deteriorated further. And there is also associated diminution of vision in the same eye since 15 days. And
What studies are seeing? What are the positives? Here, a patient who has pain,
okay,
who has redness, who has watering, who has diminution of vision. Along with associate, there are two contributing like rubbing of eyes. So using all these points, what you can think of? You have to give a detail. Summary means you have to look at the history.
Don't repeat.
So arrive at the differentiate diagnosis.
So she has told. What do you think based on what she has said? What analysis are you deriving? What comes in your mind? Okay.
Then what else? Possible. Okay, what kind of varieties?
When you have to summarize, you have to be as vague as possible. and as specific to the history. So if you have to summarize, I'll just ask few questions. Is it a progressive condition? Yes. There has been progressive deterioration. Was there any inciting agent? Yes. Was there any aggravating agent? What was the aggravating agent? Rubbing was not the aggravating agent. Installation of drops. Okay. So most probably what would have happened? So that is what you are telling. So she might have had a history of trivial trauma. So now when you are summarizing, you have to be specific with your words. Vague in the sense, not specific to any one diagnosis. So she had some history of trivial trauma following installation of topical medicines. There was a progressive deterioration. So most common cause for progressive deterioration would be what kind of etiology? Infective etiology, right? So based on this, you are coming to a provisional diagnosis that this may be a corneal lesion or infective corneal lesion, right? You are having a thought process. Are you going to expect any retinal problem in this? No. So which segment is going to be involved in this?
Interior segment.
Anterior segment. More specific, you cannot expect a dacrocystitis, right? Is there any watering or any pus purulent? Yeah. So you have to explain that it is a cornea, mostly cornea or the ocular surface, right?
Personal history was unremarkable. General physical examination. Patient is moderately built and nourished. Is conscious, cooperative, oriented to time, place, and person. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Coming to ocular examination, right eye visual acuity is PL positive, PR accurate. Eyelids, there is lid edema with mechanical ptosis. Lacrimal sac shows Roplas negative. There is a circumcorneal congestion. Cornea shows an ulcer. AC details cannot be made out. Iris, peripheral iris is hazily visible. Details is not clear. Pupil is not visible. And fundus, there is no view.
Okay.
So shall I describe the ulcer?
Yeah. Now you are not mentioned about the other eye. So as an examiner, if you want to direct me towards the right eye, the easiest way of seeing is the left eye was essentially normal, and I'll be describing the right eye features. Now here also, you have mentioned like cornea ulcer is there, anterior chamber details are not. So in a short way, what you should tell is the lids and admix are normal. The cornea is as described. So because when you are telling the cornea, you very well know that the rest of the clinical findings are not going to be visible. So if it's a whole big corneal ulcer, you are not going to comment on the, I mean, you should just be more precise. That's all I want to tell. Okay. Okay, you can, anybody else wants to try regarding describing the corneal diagram? You can try.
Coming to the corneal examination, size and the size of the cornea looks normal. Shape is normal. Surface, there is a epithelial defect of 9.5 into 9.5 mm with three satellite lesions located at 10, 12, and 7 o'clock position, and with the nasal, superior, and superficial corneal vascularization.
Okay.
And, it also has a dense, nearly full thickness infiltrate, which measures about 3.5 mm in length and 3 mm in breadth.
Okay. Can you describe any particular word which will describe this infiltrate? Now, based on this ulcer, the diagram of it, what is going in your mind? What kind of an infiltrate could it be? What would be the differential diagnosis?
Differential diagnosis. Infiltrate.
Uh, so, so is there any description about the infiltrate and the margin? So that is one point which is missing. Number two, anything else describing the infiltrate? How would you probably describe the infiltrate? Any particular word I'm looking at?
Yellowish.
Okay. Fluffy margins is not there. It's not been mentioned. So when you are drawing it, you have to mention it. So I'm just going to think away from this case, and I just want to ask you all, looking at this ulcer, what would be your differential diagnosis?
Fungal corneal
So,
ulcer.
so you are telling it, is it fungal? Yes or no? Can it be fungal? Yeah. So what are the points in favor of it?
Satellite lesions.
Okay. So you need to note that when you're taking writing the infiltrate and describing it, that word feathery margin should be there. Okay. Then satellite satellitism is present. So okay, that is one more point in favor of a fungal ulcer. Anything else? Dry. The appearance of it. So that is important. You should mention it. It is not there in this. See, why I want you all to know is that when you all know what is a fungal ulcer, you all know what all points you have to describe. See, examiner will have less time. You have to guide him towards your diagnosis, right? When you are summarizing the history, it is vague. But now when you are seeing the patient, you should come towards one particular etiological diagnosis. Okay, anything else? Okay, color of the infiltrate could be, but if you put more grayish white rather than yellowish, I mean different shades of yellow and all, then it will just confuse. Grayish white could also be viral, right? So if you have to describe the fungal ulcer, it is more fluffy. One word which I would probably put is patchy looking infiltrate, which means that it is not a uniformly the extent of the epithelial defect and the infiltrate is not uniformly across the epithelial defect. At some areas it is more, at some areas it is less. Now, when you talk about satellitism within the epithelial defect, you cannot talk about satellitism. When you talk about satellites, it is beyond the intact epithelium. Okay. So based on that, in this diagram, only the one at 12 o'clock is the one which is beyond the epithelial defect. The rest of it is within the epithelial defect. So hence it is more amount of a patchy infiltrate. Now the next diagram you have also mentioned that it is mostly full thickness in the center and it is decreasing as you go towards the periphery. Right. So most probably the central infection was initially at the center and hence there is some circumferential spread. At the same time, there is a posterior deeper spread. Okay. So what you have mentioned over here, no, the 3 satellite lesions at 10, 12, and 7 o'clock. See, the satellite lesions has been drawn within the epithelial defect. So satellite lesions cannot be inside. It has to be beyond the epithelial defect. What other differential diagnosis can you think of? What? Bacterial. So what is the point in favor of bacterial? So, okay. How would a bacterial ulcer look? Patient would have much amount of congestion, right? The infiltrate would be, there is one more point which you have not drawn in this. What would be striking in case of a bacterial infiltrate? Hypopion is there in this. What about the stromal edema? So in this disk diagram, you have not mentioned anything about the stromal edema. The rest of the stroma is more or less compact. So when there is a compact stroma, it goes more in favor of a non-bacterial origin, right? If you had expected the epithelial defect and beyond that to have a lot of edema, you would have expected it to be more amount of bacterial or a mixed infection. Could it be viral? God is fortunate for us that he doesn't give everything in one patient. Okay. So there is something which is suggestive that it could be a geographical ulcer. What is it? Okay. See the epithelial defect. It is irregular. It is almost a geographic pattern. One point which I would probably ask in detail is how about the margin of the epithelial defect? Whether it is not elevated, whether it is distinct or indistinct. Okay, in simple terms. Plus the presence of superficial vascularization is more suggestive of a viral etiology rather than a fungal etiology. So if you have seen fungal ulcers, you will never get so much amount of vascularization within 2 to 3 weeks. So the diagram itself is, kind of misleading. I am not sure if you have seen the patient, but I am very sure that it will not have this kind of vascularization. So when there is so much amount of vascularization, the etiology for me would probably more shift towards more like a chronic HSV infection. So why I'm just telling you is when you are drawing or noting down, there are so many possibilities for the examiner that you are digging your own grave. So think about what you can do to save your skin. So when you're talking about fungal ulcer, make sure that the epithelial defect, everything is mentioned. Plus, the description of the infiltrate. Then also that word dry looking surface. So those are the important catchy terms. Okay. Any doubt in this?
I think whatever, I think most of the points that is already covered. Now, as far as I know, like when people are answering this cornea related, once you know the diagnosis, be specific in your findings. So basically your answer should lead to the whatever your final diagnosis. Otherwise, what happens if you mention in non-specific words you're describing, there could be many DDs which can come. As you're telling, someone can, if the examiner is intelligent, he can defend as viral also. Possible, right? Depending on the thing. Once you know the diagnosis, your findings has to be specific. Those words which was mentioned like feathery, leathery base, the margin, satellitism, you have to be more specific in describing that. Then the margin characters, like that.
Guide the examiner
Yes.
towards your case.
Yes.
Otherwise, he will take you away from what you know.
And also history of injury rubbing, maybe you should take it in detail. What exactly the thing, vegetative matter, is there any chance of like incident of injury? Is it happened in a situation where is there more chance of bacterial or a fungal inoculation? Okay, so that might give you some clue. And corneal sensation, should they check the examination.
One extra point you could probably add is it's a 40, 65-year-old lady, 40 year. If you tell it as a 40-year-old farmer, then invariably you are again directing the patient towards a fungal. Okay. So if you tell it is a 40-year-old doctor, then you are confusing the matters. So use the words which strengthen your case so that you can take it more closer to yourself. The examiner will not go and ask the profession, but it is like these are the terms which help you to come towards the diagnosis, at least the etiological diagnosis.
Basically, describe findings in a so specific way, finish off presenting and then go to the treatment aspect. Otherwise, once you get into this viva of differential, viral, bacterial, no, you will get confused. And remember, on that day of examination, you need to remember other things also, from squint, everything and all. And once you get into this kind of discussion, your thought process might get distracted, especially when it's obvious things, maybe fungal corneal ulcer, a PRV, CRV. In this, there is nothing, no ambiguity in like whatever, there is a specific point. Beyond this, if the examiner, if they want to ask, check your knowledge, ask question, what could be in viral, margin character, bacterial, that you answer.
We can go ahead. Next. And talk about the investigations. You want to talk about the investigations? What all investigations you would like to do? You are correct, but the way you put it is more important. So you want to ask for systemic investigations and ocular investigations. So if you want an ocular investigation, what is the investigation you are asking? How many of you all agree with it? Yeah, so the words are important again. You don't ask for gram stain. You don't ask for KOH. You ask for a corneal scraping and staining. Because again, you are not going to take a sac or you are not taking a conjunctival staining. So specific, it's a cornea case. So it's a corneal scraping and staining. So what all do you want to stain? Then you talk about gram stain. Now again, in case of examination, don't speak in abbreviations. So KOH, what is it? You speak specific. You are asking for a potassium hydroxide. Then anything else? Calcofluor white mount.
KOH, how will you do? Can someone describe? That's from how you take it.
Use it.
8 pellets of KOH should be mixed in 100 cc of a normal saline and then normal saline or distilled water, and that is how it's prepared.
What will you see?
Okay. After that, over the scraping part, we have to put the 10% KOH, and then we have to leave it for at least 30 seconds to 1 minute so that the fungal elements are more visible.
What is the principle of potassium hydroxide staining?
What the steps you told is correct. Why we are following that particular step? So what you want to see so that it becomes more. Yeah, because if you know the KOH doing and all that, when they ask this question, you'll get stuck. Whoever knows it. Okay, one is one. Okay, correct. Yeah. Basically, you want the fungus element to be highlighted. But what you exactly mentioned is that is the correct fungus scraping after 2 to 3 seconds. That should be written, and there should be sufficient contact time for these processes to happen. Anyway, this is must know question. This if you get a corneal ulcer, this question will be asked. All whole time examiners they ask these questions. They like asking this. They will not be worried if you don't answer this time. And also these routine things, clear things, clear.
you do the gram staining, what all do you see? So if you all have not read, I say that it's better you read about how to do a gram stain, what are the procedure involved, what is the reagents involved. Okay, so that is okay. So how you are doing the procedure doing a gram stain is important. Now the next is calcofluor white. So what does calcofluor white help you in? Okay. And also in case of fungal, it helps in highlighting it gives you a calcofluor white. What kind of filter do you use? It's a UV blue filter, right? So that is important for you. When you see a calcofluor white, you're seeing in a blue light. Okay, that is important. We are not going into the magnification, but even that is sometimes can be asked. So these are very basics. So what are the different culture media since sir has started? What are the different culture medias you are going to once you take? So you are doing corneal scraping, testing for the staining and culture. So what are the 6 culture media? I'm being more specific now. I'm giving you a clue that it is only 6. So what are the 6 culture media you would like to use? Okay, I think one of you start. Okay, next. Subarots. And what else is for fungal? SDA, PDA. What is P? Potato dextrose and subrods. Okay, for fungal. So bacterial, if you ask more specifically, aerobic would be blood agar, chocolate agar. Okay, then for anaerobic, Robertson's cooked meat media and BHI infusion. So these are the 6 routinely used. In addition to this, what else is used? Is it routinely used? No. Yes. So parasitic is non-nutrient agar. So 6 plus 1, 7 are the ones which are routinely used. Okay. Anything else you want to-
To answer, but we never know. But for example, some previous segment, many new latest treatment, and also because I think the suggest they respond. Not commonly used, yeah, but you should know that there is something called intrastomal oriconazole given in these cases.
non-invasive way of diagnosing this ulcer? Yes. So what all do you see? What all organisms are being routinely detected in confocal microscopy? Fungal and parasitic acanthamoeba. Okay. So this is one more point you have to note down. Okay. So regarding the management and all, I think even if we take 10 classes, it is going to be less. But broad classification, how do you want to manage? What all are the points you look for recovery? I will not go into more into individual management. I would ask you one question is, how are you monitoring the progress? Whether it is progressing, improving, worsening. So what all are the points you would like to see at each visit? What do you want to see? At what different durations would you like to follow up this case? How soon do you want to follow up this case? Okay, I'm just asking first. When do you want to see the patient next? You have written the treatment. Yes, so you have to see in case of a fungal ulcer or any microbial keratitis, you need to see them at least every 3 days till what heals? Yes, till the epithelial defect heals, you need to see them every 3 days. So what all are the points you are going to monitor at each visit? Okay. Okay, so again, you have to classify that symptoms and signs. So symptoms is patient is feeling more comfortable, watering is less, irritation is less, everything. What are the signs? Decrease in the size of the epithelium. Something beyond that, before that? Yes, so there is decrease in the inflammatory signs of lid and the conjunctiva. The conjunctival congestion is coming down. So don't just focus on the cornea, but you have to tell them. Lid edema is regressing, conjunctival chemosis or conjunctival inflammation is coming down. Then coming to the cornea, what all are the points? Epithelial defect is decreasing, infiltrate, size is decreasing, and intensity or the depth of the infiltrate is decreasing, or the density of the infiltrate is regressing. It is contracting. Then something else, the edema is coming down. See, go step by step, you will not miss out anything. The corneal edema is coming down, the cornea is becoming more clear. Then you are coming to the anterior segment and your anterior chamber, and you're talking about the hypopyon, whether it is coming down. Subsequently, what happens? Iris visibility is improving, posterior segment visibility is improving. So these 5 things, when you talk about it, it means that you are following up the case correctly. So when would you like to stop the treatment? Since it is a case of fungal ulcer, when would you like to stop the treatment? Okay, 2 weeks after healing of the ulcer. Now, I will ask one question. What do you mean by healing of the ulcer? So what remains? Okay, so once there is a complete regression of the infiltrates and there is formation of a scar, up to 2 weeks beyond that, you would like to continue the antifungal. Okay.
No format it is. They are very friendly examiners. Any of you want? Any of you will sleep me?
Maybe on 3-4 ಪಕ್ಕದಲ್ಲಿ ಸಿಕ್ಕೊಂಡು ತಗೋತಾರೆ ಹಂಗೆ ಕೇಳಿದ್ರೆ ತಗೊಳಲ್ಲ ನಾವು. Yeah. Anything else they might take. Coffee they may not take.
Okay. So I think what we have discussed is in a very
brief examined it. We just want to get you what are the playing a devil's advocate, like what can be asked. Everything under the sun can be asked. See, these cases and UVI, diabetic retinopathy, one corneal ulcer. These are the two cases which will decide whether you are passing or not.
Remember all these points, you are past 90% you are past. You can answer. So if you take a probability, if they are asking 10 questions about these diseases, 9 out of 10 will be one of these questions, whatever you ask. You need not predict anything. If you noted down whatever you discussed, that is more than enough to pass the exam. Of course, clinical practice is that's a bit say different ballgame. To pass exam more than enough to answer whatever you are discussed. This corneal ulcer and diabetic retinopathy, you have to know kind of things. Again, just like it's not a whatever you are discussed is nothing at fellowship level as a hospital. Anything which you are expected to know and manage. So please volunteer for next time. We can take the right side from this. Be loud. Don't be very specific in telling white patches over the skin. What if you have some other patch? What are you thinking in your mind if you're asking for a specific white patch? Okay, is that the only thing you want to rule out in this condition? Huh? See, history level, it has to be a broad kind of a, don't use the specific terms. So coming to, if I understand your history, I have not seen the patient. This patient is a 45-year-old software professional coming with diminution of vision associated with redness and watering. Is there a pain? Pain. So what all comes to in your mind? Unilateral. On these to answer, it has to come like spontaneous. I should not be buying time for fumbling these things. Yes. This is there in the Kurana undergraduate. No, redness, this thing and all. I'm asking the same thing. You people must have taken classes to UG. So angle closure, glaucoma.
What is the simplest thing which can be done? Okay.
Then keratitis, good. The diminution of vision goes with that as then.
What is the simplest thing which can come to your mind?
And the most common one. So suppose if I say same symptoms without pain, this is a bit tricky. Redness is there, watering is there, diminution of vision is there, no pain. Conjunctivitis, okay, maybe conjunctivitis, redness, tear film disturbance, diminution of vision, okay, fine. Then neurotrophic ulcer will not be short history like that. No? Yeah. Severe dry eye. They will have more symptoms. They will be behind your life. But it's a bilateral condition again. Episcleritis can be there, but diminution of vision may be rare, but can be there. Okay, then conjunctivitis, episcleritis. What else?
Very specific. No pain.
No pain.
Sir, no, these are retinopathy.
Viral keratitis. Stromal keratitis. Okay, sir. Is it Okay, I mean, we can give at least it's not wrong. Okay. Yes. First, anti-uveitis also sometimes can be painless, right? So after mentioning all these things, any of the posterior uveitic diseases, they can have redness, they can have watering, blurring of vision. Still, they may not have pain, uveitis, whatever it is. So this area is bit tricky without pain.
Just add and
Yes,
this. When will they develop pain?
Why will they develop? What will be the reason for the development?
Very good. So when there is a posterior uveitis, until and unless there is an anterior chamber spillover associated with ciliary involvement, patient will have all the symptoms of inflammation without pain. Okay.
Inflammation, rubor, pallor, pallor, it's a pain in that. That's why I was asking the question without pain. I'm asking only question which examiners have asked. Specific. Pain by definition may be there for the patient, but it will not be of that severity for the patient to express. These things are possible without pain. And history, what you can be careful when you mention. So after knowing the diagnosis, don't be very specific.
Too specific. Huh?
No skin lesions. It can convey the same thing. No? Than the examiner. It's not the examiner. If I tell no white lesion, no skin lesion, it's the same interpretation. No skin lesion. They ask which type of skin lesion you want to look into, then you can describe. Okay. Yeah, sorry. Finish the first. Again, when we compare to this personal history and well bladder and all, why is it important? Because any ophthalmology, personal history, bowel bladder and all. From previous days, we are telling a person for three bowel bladder, normal, normal. Excellent. For autoimmune diseases, it's one part, bronze, circulatory, chronic, then all the small absorption symptoms also can have ocular manifestation in the form of anemia, night blindness, cirrhosis, and also there can be a nutritional output in the body. If someone asks what is the importance of GIST, you should know this. It can be broadly classified into two categories, autoimmune and small absorption symptoms. Everything comes under this body. It's a for a few. They like urinary tract, yes. Triamcinolone they use for BPH. Okay, if you are doing cataract, they can collapse all that. Okay. What else? No, she's general telling all the bladder related thing. Yeah.
Reiter's disease.
Proteinuria, good. Yes, that is nephro more than bladder. Okay. Anything which can happen, burning micturition, huh? Reiter syndrome. Huh?
Don't get fixed to the syndrome. First, take what you are expecting. Correct? Urinary tract infection. You are expecting that.
Yes.
So when you are expecting, see, we have not even gone halfway to the presentation. Only in the personal history, your examiner can harass you. I'm not telling the examiner he can harass you in this because each point is important. You are asking about bladder, bowel, so frequency of micturition, any disturbed micturition like in case of burning micturition or recurrent urinary tract infection. So recurrent urinary tract infections in an ophthalmologist view, What do you want to think of? Two conditions. Liters is one, and what is more commonly? Which other syndrome is there? Behcet's is also there.
This is an autoimmune, looks like this thing. This is history, right? Recurrent pneumonitis, cancer, and all that. So basically, why we are doing here is we need to develop the cycle of thinking. Why are we asking and all that? It's very important. And this is the time where you should practice this thing. In examination, you will be tense unless you practice, make a note, and discuss with others. Suddenly, if they ask a question, you'll be fully prepared. You'll go into the Viva room, you'll be thinking about, okay, anti-uveitis, I will answer that, USC, APs, everything. And suddenly, we'll ask some question like urinary infection. Your mind will totally go blank. You will not answer this also, that also, you'll forget. So, this is the time, and this will be common for most of the ophthalmic disorders. Why you ask bladder, why you ask pallor, why you ask cyanosis, and all that. Just make some notes of it and discuss with that. Once you know it, it's very easy. And when you answer these things, even if you don't answer the main thing also, they will just ask what's the final diagnosis. So then they will, okay, fine, the treatment they will ask, which you obviously will know. Because before going inside, you'll prepare, no? Now it's very easy, mobile. Our time, we didn't have that. This thing. Ask some senior or whatever this thing. No? So they will know, examiners will know all these things. If you ask treatment, you will tell. If I ask the diagnosis, you will tell. If you ask the classification, you will tell all that we know. We want to assess how your approach to a patient, how you can manage it well, and your way of understanding the disease. This is what they want to assess. Okay? And if they give right marks to this, you are passed. They will not be worried even if you diagnose wrongly. So basically, you have to be right at basics. Okay? So clear the GI and the urinary symptoms and the relation to the eye. Fine.
Complaints of the patient are seen and picked up first by the ophthalmologist.
In fact, you must have added a plasma ISA window to the body. Last year.
Last year it was there. That
Many times it happens, they come to us, and when the patient says that there's something good rate is there, it's not from examination point of view, it could be linked to it. Whatever they do, just note down in the
fine.
feel totally irrelevant. What is that? Note down in the
Okay. So we'll concentrate. The left eye is normal. So we'll concentrate on the findings of the right eye. Who wants to speak?
Right eye, findings of the ocular examination, findings of the right eye, uncorrected visual acuity of 6/24, not improving. Best correct visual acuity is not improving. Eyelids were normal. Conjunctiva showed circumcorneal congestion. Sclera appeared normal. Cornea showed keratic precipitates, normal size and shape. Endothelium showed keratic precipitates. Anterior chamber was of normal depth. Cells of 4 plus and flare was normal size, shape, and normal size and shape.
Describe.
Oh. Non-pigmented, arranged inferiorly along Al's triangle.
basically, you all need to know the different types of keratic precipitates, their description, and their link to the diagnosis. So, what are the different types?
Granulomatous and non-granular.
Village, fine, pigmented,
Mutton. Large,
greasy appearance.
There are many things large in the world, but why they find only the mutton fat?
The greasy.
All around. They used to cut that used to go splash on the get deposited on the glass wall. Those deposits used to resemble this thing. Next time in case all these history, this thing. We'll be thrilled to ask questions. We're not going to details of meanings of each keratic precipitate, but we should know. Function UVA case, keratic precipitate description is a must.
So I'll just ask. I think you complete your examination, then I'll ask the questions.
Anterior chambers of normal depth, cells 4 plus and flare 3 plus. Iris showed posterior synecave at 1 o'clock, 6 o'clock, and 8 o'clock position. Pupil appears festooned. Lens is normal, and dilated fundus evaluation. Any atrophy, iris atrophic patch,
Okay.
nodules.
Any presence of iris nodules,
Nodules.
or iris atrophic patches. Again, when you talk about the synechiae, any presence of broad-based synechiae, or they are small-based. These are not broad-based, these are very small, right? Okay. Something which you have described wrong. Is there any hypopion over here? It is not there. So it is not 4 plus cells. When you talk 4 plus cells, it means that there is a hypopion uveitis. So this can be probably put as 3 plus, maybe. Let's put as 4 plus cells. Taken the photo.
Dilated fundus evaluation showed cystoid macula.
So what is a provisional diagnosis? Summarize. Now I want somebody from here to summarize what you have heard. So what would you think based on this history? What are the thought process?
There's so many positive patterns. If you put all these positive patterns, what comes to
uveitis. Intraocular pressure. Nodules. Amsler sign. Vitreitis. IOP.
which group? This okay. Sorry, I was just describing this thing. What all the points which have been mentioned missed? Like one is the gonioscopy you need to do. Anterior vitreous face you need to examine. In any uveitis case, you need to know the technique of examining anterior vitreous, and you should do an indented indirect ophthalmoscopy with indentation to look for any pars plana exudates. Okay. So then what else you look for? Retinal examination. You need to look for mid-peripheral changes, any perivascular sheathing, exudates. Okay. And how far the vitreitis is extending. Any granulomas, choroidal findings. So can you describe this OCT?
Um, vitreous interface appears normal with
See, any OCT description, no, you should describe under the 5 headings, which I keep telling. First, you look at the vitreoretinal interface and describe what is there on the surface of the retina. Then comment on the foveal contour. Then describe what is inside the retina, the substance of the retina. Then subretinal changes. Then RP and choroidal changes. If you go by this order, you will never miss a findings. So vitreoretinal interface is not normal. I can see some dot echoes there. This is a 45-year-old male, right? So usually the premacular bursa should be clear, right? I can see some dot echoes which are more hyperreflective in the foveola and the surrounding also. So that means there is a vitritis in this case. And there is a cystoid macular edema. That means posterior segment is also involved. Okay. Cystoid macular edema with neurosensory detachment is also there. Can you see the small neurosensory detachment is there? It's clear? So fine. So what is the probable diagnosis? Is it limited to the anterior uveitis? Could be a pan-uveitis, posterior segment. It could be because of vitritis and presence of this thing. You need to examine the periphery and all that. So you need to know the uveitis classification, which I will not be discussing, and the anatomical localization. What is anterior uveitis? What is intermediate uveitis? What is posterior uveitis? These things you should know. And when you call pan-uveitis. And you mentioned in the diagnosis acute and chronic uveitis. What is acute? What is acute and chronic? And what is recurrent? You have to know this. Just use some basic common sense, you'll be able to answer. Acute, chronic, acute and chronic, and recurrent. These 4 things. Again, one of the most commonly asked questions.
If you have the American Academy of Ophthalmology book, the first that working sun classification, all of these points are very important. As sir mentioned about measuring examining the posterior vitreous, anterior hyaloid phase and the vitreous cells. Similarly, the question will be asked, how would you like to examine the AC reaction? Okay. So these are very basics. See, there are something like which you need to know, like your ABCs. So in case of uveitis, these definitions are your ABCs. You need to know them, because if you make any mistake in this, the discussion will never go to the clinical management. You will be stopped and it will be, kind of, it won't go further. They will know that you may not have done much. Okay, so these definitions should be at the tip of your tongue. All are each word is very important here. So for just like we were having the discussion about diabetic retinopathy, the clinical definition of clinically significant macular edema. Now in this case, so these definitions are something which you can never manipulate. They have been thought by experts after years of practice, and each word is very important. So these critical, like these important things, never miss out. So you make sure that when you're describing any case, you use the correct terminologies. So that helps your cause a lot, because most of the times the words themselves and the definition themselves are self-explanatory. Acute and chronic, recurrent, whether it is a chronic, unilateral, bilateral, pan-uveitis, intermediate uveitis, you cannot miss them, because you're talking about an acute and chronic inflammation when you're telling you there is a presence of vitreous cells. right? So there itself your discussion is going haywire. It means that you are not examining the periphery. So you are kind of digging graveyards for yourself. So be very specific. One extra clue what I would probably put it is that when you are having such a kind of confusion, this looks like a differential diagnosis would be, uh, again, I am going to specify this, the presumptive diagnosis. So when you are talking about it at the end of the summary, you come, my presumptive diagnosis would be right eye, chronic anterior or recurrent uveitis or pan uveitis with, now would you call it a cystoid macular edema? What are you dealing with? With uveitic macular edema. Okay. Why does cystoid happen? Cystoid is more or less more specific to, I mean, you when you talk about uveitic cystoid macular edema, it is more specific. You are dealing with the, you are not thinking about diabetes in this case. So you try to specify that. Okay.
Also, definition acute, like this, why this has been mentioned as acute and chronic means chronic is persisting. Okay. So there is never been a symptom-free interval. And there can be an episode of acute exacerbation. The moment you use a recurrence word, there should be a symptom and a treatment-free interval. Okay. So these are very important when it comes to diagnosis and management of uveitis patient, because it will have a significance. What to start on, whether to continue the same medications, to start on oral medication, all depends on what exactly you diagnose. Okay. So clear what are the examination findings you should not miss, and what are the points in diagnosis, that acute and chronic, recurrent and all. So now, lack of time, I think we'll go to the investigations. What all investigations would like to do? Comprehensive fundus examination is a must for any uveitic patient. It may be a typical anterior uveitis, but you may end up finding this. Yeah.
Ocular investigations, OCT.
OCT has been done. Next, what you will do? OCT is showing macular edema. That means retinal vessels are affected. There is some exudation. There is some fluid leak which is going on. Okay. What would you like to do now? Huh? No, systemic it's mentioned already. It's mentioned something.
Systemic,
I don't know.
systemic blood workup, complete blood count with ESR.
In the history, there was one particular point which was mentioned. Patient was having arthritis and he was on etanercept. Okay, so what is that telling you? What clue is it giving?
Non-brand.
Again, in this, you have to be a little bit vague. Spondyloarthropathy is one term you could use. More, that's what you have to be more, a little bit more vague, because you're talking about a spondyloarthropathy. You all have not taken much of the history regarding which joints are involved. If you ask the central joints are involved, it goes more in favor of HLA B27 or spondyloarthropathy. If you ask him that he has peripheral joint involvements or knee involvement, whether it is relevant, rheumatoid arthritis, can it cause uveitis?
Can more of scleritis and
Yes.
scleritis and episcleritis.
Rheumatoid arthritis is associated more amount of scleritis and episcleritis because they are vasculitic. Okay, rheumatoid arthritis is more vasculitic, whereas HLA B27 is more amount of inflammatory. Okay, so hence in this case, you would probably ask the history properly about what all joints are being involved, whether he has a similar history in the family. And joint examination, one more point you would probably ask in this patient is any involvement of
small joints would be more favor of rheumatoid. Something more specific, involvement of the distal interphalangeal joint, which is more suggestive of psoriatic arthritis. Okay. So HLA B27, I'll just, since we cannot go in depth, just for the convenience of time, you know the PAIR. P for psoriatic arthritis, A for ankylosing spondylitis, R is for Retter's syndrome, though now it is not called as Retter's syndrome, it is reactive arthritis, and R is inflammatory, PI, inflammatory bowel disease associated uveitis. So these four things, when you are asking the history, when you have the back of your mind, it's a unilateral case. So always make sure that you are asking the relevant questions. Okay. So in this case, you are asking for the complete blood count. Yeah, yeah.
That's it. So then that is whatever the systemic investigations you need to order, considering all these DDs in mind, whatever that's been. So coming to the ocular investigations, you have to do an fundus fluorescent angiography to look for extent of vascular leak. Okay, that will confirm you're dealing with a panuveitis case. And if you diagnose a recurrent, then you have a case of 45-year-old male who is coming with a recurrent attacks using different medications. Now there is a macular edema, do an angiography, there's a perivascular leak. The next thing you need to do is always take an opinion from a rheumatologist. Okay, because whatever you're giving topical steroid, that may not be enough. You may have to be started on systemic, like oral steroids, immunosuppressants, and things like that. Okay, so then what are the drugs which is something is on, what is that etanercept? It's a biological agent which is given in most of the arthritic cases, conbercept and all that. So now what are the drugs which can cause uveitis? Drug induced uveitis. Rifabutin. Okay, then most common topical medications, if you can start, prostaglandin analogs, then pilocarpine, brimonidine, and etanercept also can cause drug induced uveitis. Okay, these all these differential diagnosis for drug induced uveitis also we should know. Okay. So clear. So when it comes to an uveitic examination, it's about comprehensive examination, because uveitis can be related to anything. Literally you can connect to any disorders, starting from the cornea to peripheral pars plana. Okay, that is one thing. And description of the keratic precipitates, second thing. Third thing is classification, the anatomical localization as anterior, intermediate, when you call it as so and so. Diagnosis part, acute, acute and chronic, chronic or recurrent. Use these terms wisely. Then comes systemic investigations and the logical reason what for whatever we discussed now for systemic investigations. Then if require rheumatological opinion, and then ocular investigation, in which angiography most of the time is a must. So clinically you may not be able to see it. So if you cover all these points in any uveitis case, it's easy, you're done. Like, you'll be able to answer and pass. And even for rating theory exam also, when you're writing it anything, try to describe this any uveitic related condition. If you write what is acute, chronic, acute and chronic, it will be relevant. No, so try to this thing. So try to cover or study under these headings, whatever I described, these 7 to 8 headings, you will never miss and it becomes easy. Okay, to rather than mugging it up. So any doubts so far in uveitis, this particular case? No doubts? So clear, no? Because uveitis is something like quite vague. I mean, you can't come to a specific thing. That's why it's always better to have a vague, broad headings under which you can describe or study or write. Okay, fine. No doubts. So we'll go to the instruments. Oh. And most of the time when it comes to instrument, examiners will tell pick up one. They may tell, and most of the examinations they will have this kaju biscuits and all that. It so happened in our exam asked pick up one. He was hesitant. It's okay, pick up. And he, thank you sir, and then you know what is it happened in our center only last time. Okay, fine. So what is this? Enucleation scope. Commonest indication for enucleation. Cadaveric eye donation. Okay, excellent. So then how will you, okay, what is that group for? Optic nerve guide. Okay, so enucleation you want to ask now? What are other?
Which are the common conditions for enucleation in a different age groups?
In pediatric
Age group
adults.
and adults. So I'm specific in pediatric age group. Retinoblastoma. Okay. So what is the normal enucleation and what is the modified enucleation? Is there any modification in the surgical technique?
And if it is done, why it is
If
done?
it is done, why it is done? So read about it. Okay. So how does a extra length of optic nerve? Okay, that is important. In case of elderly, the most common indication for enucleation would be, again, it would be a tumor, but which tumor? Choroidal melanoma is the more common. Okay.
Enucleation, what is the indication for evisceration? Panuvation. This 45-year engineer will do evisceration.
Don't make a blunder like that.
What fungal? Basically, case of panophthalmitis with no perception of light. Okay, and never tell endophthalmitis. Okay?
So that again, sir has told one particular word: no perception of light. If you say the patient is having PLPR and you are going to do a evisceration, then he will tell that the community is better without you.
So
Okay.
doubtful PL also you should not do. So you can absolutely no PL. Okay, what is this? Wire vacuum. Where is it used? How will you deliver? Candid technique. Okay, what all complications which can happen during that procedure? PC rent. Okay, start from cornea. Go from anterior to posterior. What we can do for cornea? Yes, endothelial test, damage, and all that. Then iris hydrolysis, hydrogenic hydrolysis. Then you can pull bag also, no? That can happen. Then if the bag after that, what else you can pull?
PCR.
PCR can happen.
Cause a PCR and vitreous prolapse.
Vitreous strands, and vitreous also, if you pull, what can cause? It can cause retinal breaks and all that. Okay? So any instrument study like this. So what are the uses? Primary uses, and while using it, what complications can happen specific to few instrumentation. Okay. So if you study like that, you will not miss anything. So what is this? Very good. What is it used for? Regular test. What? Macular function test. Excellent. What are the macular function tests? One by one now. Okay, color vision testing over. Maddox rod. Contrast sensitivity. Armsler card. Potential visual acuity. 2-point discrimination. Entoptic phenomena. Then what ERG? Yes, multifocal array pattern ERG. Excellent. Very good. If you remember something. Okay. Next. Photo stress test. I think one we missed. I don't know whether you repeated. All 10 macular function tests you're supposed to remember. Okay. So then, what is this? I know that. So what are the different aperture in it? When do you use it? Different apertures are there, no? How many are there? There's 2 filters and 4 apertures. Okay. Yeah. Where do you use red free? Okay, to obscure any media opacities which are red. Okay, then blue, cobalt blue, or any staining. And there is a vertical slit also. Where you can use that? Yes, excellent. Any elevation or uneven in the posterior surfaces, macular edema. Then what else? Some test which you can do with that. Excellent. Ward-Scaling test in case of macular hole, you can do it. Okay. This also polarized aperture. If the patient is too photophobic, you can use that also. That will not be available with all the instruments. Company, and then some companies it will be there, some it will not be there. So these things you should know, and also they will ask about distant direct ophthalmoscopy, what distance you do, and media opacities, how to localize the opacities depending on the movement. These things you should know when it comes to display. So start with any principle. What is the kind of image is formed? What is the kind of image formed? Direct ophthalmoscope. It is erect virtual magnified.
How many times?
Erect virtual magnified. How many times? 50 times. 15 times. 100 times. 15 times. Okay, fine. Okay. So on the difference between IDO and DO you should know, and principal you should know, and aperture you should describe, and distant direct you should describe, and the slit and all that. If you describe all this, you can nicely write for 10 marks. And you can answer in examination also. Instruments, okay. No, yeah, what is this? This is neperphenol. I know that. Which class is written over there. And whenever you've been given a drug, don't tell the drug name and keep quiet. It's written over there. You should whenever they give any drug into your hand, you should sorry, I forgot. So you should describe under 5 headings which class it belongs to, mechanism of action, indication, adverse events. Okay, so these if you study and describe under these headings, you never miss out. Clear? Which class is it belongs to? Mechanism of action, dosage, indication, adverse events. 5 things. Okay. For all the drugs, study under these 5 headings. Finish. Make a notes of it. Any drug for that matter. Okay. Beyond that, if they ask something else, they won't ask you to fail and all. Maybe they will ask you to give extra marks. So that's all. So clear. So what class it belongs to? NSAIDs, non-steroidal the mechanism of action. Lipo or cyclo? Cyclooxygenase. Okay. Then indications. Any procedure which is done on the eye which can induce a kind of a pro-inflammatory conditions like lasers, post-cataract surgery, post-anti-segment, any surgeries we can give it. Then dosage. Commercial retina. Yeah, you can give it. Yes. Anything you can give. Never know. They give left and right. Okay. Dosage. How many times? 5 times or 6 times? 4 times. Okay, it has to given TID 3 times. Okay, last point is adverse event. What can happen? Sir will be, cornea surgeon will be. What can happen? What can cause? Exactly. It's covered 5 points. So, like the moment they give the drug, they'll spontaneously and slowly so that they can buy time and they don't have time to ask other questions. Okay.
What are the other drugs in this group?
Ah, yes, exactly. What is the one more ophthalmic use? Yes. What is the difference? Once daily. Yeah. BD, yes. That is the only difference. Rest all, whatever the 5 things I told, no, it's common to both. Only difference is that is BD, this is TID. Again, one more favorite question. So, the other drugs also you can study. I just took an example which we commonly use. Other drugs you note down and make these 5 edits.
One more point is, what are the, if at all it is a drug, any preservative which is used?
Yes.
For a cornea person, they will ask that whether any preservative is used. What are the different preservatives?
Okay. See all of you. These things must be there with you guys. No? Okay, fine. It stops here. Buck stops here. Just right. All of you saw, no? Describe the B scan. If you are an examiner, that's how they will give. On printout also they don't give. Nowadays they keep laptop, describe. B scan class. So B scan again is very important. So B scan whenever you describe, you need to describe under few headings. First, what is the type of scan? It's axial, transverse, or longitudinal. This you may not be able to identify all the time just by looking at the printout. When you see the lens and the optic nerve shadow together, most of the time it should be axial scan. If you see those two things, then only comment on the type of scan. So then you should start describing lens, whether it is seen or not. Describe the vitreous cavity, what is seen. It can be either a dot-like echoes or a membrane-like echoes. Multiple dots are seen, multiple dot-like echoes are seen, or membrane is the membrane-like. Then comment on the retinal surface. What is on the retinal surface? Whether retina is detached or attached. Then comment on the optic nerve head status. Okay. And retinoporoidal thickness. Okay. This is how we should mention. And if you are doing it actually in a video scan, whenever you find something that needs to be described in three headings. One is kinetic evaluation, topographic evaluation, and the reflectivity. For example, there is a mask lesion. First, describe the topography. What is the size, measurement, and all that. And next is the kinetic. When ask the patient to move, how is it moving? The last is reflective, hyperreflective, and within the mask, what are the characteristics? If you describe under these three headings, will not mention. Understood the first order what you should go, and once there is a positive findings, you should come. Kinetic evaluation will not be possible in a with the photograph and all. But this is how actually you should describe the base scan. Okay, now you describe. Only the retina. Before the if it's not visible, don't mention. Usually B scan it will not be visible. Only if it is seen, then they will ask you, okay, which scanning modality will use to see the anti-segment UBM. So in this one, this is a B scan. Vitreous cavity lens structure is not seen. Lens structure is the only structure which can be seen in B scan, right? Not other anti-segment structure. Lens echoes are not seen in this particular. Vitreous cavity appears anechoic. Okay. Then there is a, what is that? Membrane. Okay. Inferiorly it's moving. Okay. Then more than which is more positive point which is calling you to describe. I mean,
The optic nerve head, there is a hyperreflective
okay, very good. Huh? Okay. Well, how many? She's telling this is an optic nerve head with a display. She's telling back shadowing. Who is correct? Both of them can be correct. She's telling optic nerve head drusen. One is telling after shadowing. Who is right? How many for optic nerve head drusen? Raise your hands. One half. Raise hand. Half what you have got. Okay. After shadowing. They're not raising anything. Okay.
They are playing it safe.
There is an basically for description purpose, just describe there is an hyper reflective structure echo noted on the surface of the retina. Okay. This is typical hyper structure which is an after shadowing. This is not optic nerve head. So look at that optic nerve occlusion, will it be projecting into the vitreous cavity like that unless the patient has a papilla edema and also an associated this thing? And oh, sorry. And whatever this is, there is an hyper echoic thing which is an after shadowing. Disc will not be seen like this. So what is the probable diagnosis in this case? Malingering, IOFB. Okay, so this is a typical intraocular foreign body. Okay, clear. So specifically they have given some scan which can resemble this optic nerve with a drusen. Sorry. So optic nerve will be even much more bigger, right? And also it will have an invagination like this. And this after shadowing is corresponding only to this area of hyperreflectivity or hyperechogenicity. Understood? So what is the differential diagnosis for this after shadowing? In where else you can get this after shadowing effect? Calcification you can get. Then if there is a history of trauma, there can be air bubbles also can cause, no? Air bubble also will be hyperechogenic, and that can also cause after shadowings. How will you differentiate the two? Air bubble will cause? No, that's what both will cause reverberation. That's what we call after shadowing. Location. Where will be the air bubble? Most of the time it will be superior. No, foreign body, if it's inside the clot, that also can be superior. Even then also, if it's confusing, you do a serial follow-up. If it is air bubble, what will happen? It will disappear. Foreign body echoes will persist. And if you are in a doubt, what is the confirmatory test? What will you order to confirm whether remove the eyeball? Huh? What? Can it? Yeah, movement. No, movement. No, not this. Exactly. She says CT scan. Yes. Huh?
But ICT scan
Yes, it could be a metallic foreign body. It might suddenly come out. Okay. So always when you're in doubt, this thing. Or if you're very sure that there can't be if you ask the history, there can't be any trauma which has not gone inside, you can serially follow up. If it's an air bubble, it will disappear. So clear? Oh, how many more minutes I have? 2 minutes? Over. Ideyana? Okay. This one. Next, most commonly asked. This is like B scan will be kept for your table, and this question will be asked. All of you see once. Okay. So what is what? What is the thing which is on my right side and what is on my left side? RD. Excellent. So what are the points to differentiate? One by one. First. PVD will be? Okay. So the PVD will have more after movements. It may be or may not be attached to the disc, whereas RD will always be attached to the disc. On decreasing the gain, PVD will disappear, whereas RD will disappear. But in chronic cases, RD also can have free after movements and all disappear. But chronic RD will have other signs like cystic changes and all. Okay. I need to repeat again. So the differentiate between RD and PVD and in B scan is PVD will have a great after moments. So it may not be, if it's a complete PVD, it will not be attached to the disc, whereas RD will always be attached to the disc. On decreasing the gain, PVD will disappear, RD will not. Whereas in chronic RDs, there can be a stiff movement. It can also disappear because of atrophic changes, but they will have other signs to suggest like cystic changes and all that. Okay. So all these points should be mentioned over time when they ask about this thing. And don't mention that the PVD will not be attached to the disc and all that. Incomplete PVD still it can be attached, right? Okay. So other kinetic evaluation, like when the eye moves, how it moves, all those things also you need to consider. Clear? RD and PVD? No confusion. These are all the basics. You can't fumble. It has to just answer fast. Not fast, slowly, but spontaneously. Huh? Fine. Next. What is this? No, no, no. First, see, I will come to it. It's not that easy. I will come to. I'm not worried about diagnosis. Even in the exam, patients will not be worried about diagnosis. Sorry, not patients. Examiner. Examiner. Okay, describe this. Okay, you describe. You have the mic, no? You are the one who was making me repeat two, 3 times. Now my time has come. Come on, repeat.
uh, vitreous
Start from lens.
huh,
Lens echoes.
lens echoes are seen
Yes.
which is suggestive of cataractus changes.
Ayo, no. Lens echoes will be seen in normal this thing. Lens echoes are seen. That's all. Don't comment on cataract and all that line. If it's there, just tell it is there. Then vitreous cavity is relatively anechoic. Okay, then
And there's a mass occupying in the
yes, a
posterior
mask-like lesion. Yes.
with the calcific spots noted within
Mask-like lesion measuring so and so thing, which is hyper-reflective. And there is inside the mask, there are foci of very strong hyper-reflectivity, suggestive of probably calcification. All these words are important. classification. So what would be your diagnosis? Where is back shadowing?
Retinoblastoma.
Back shadowing is only corresponding to the calcification that you mentioned. Okay, then gold medal. Otherwise, you would have failed. Okay.
Retinoblastoma.
Yeah, retinoblast. So the dystrophic calcification is the one which gives clues to that. Yeah, you're asking.
No, which is the one which is most common? What other question would you like to ask in this case? Age of the patient. Okay, why? So intralesional calcification with such a kind of structure, dystrophic calcification, or would be more suggestive of retinopathy.
So which is the other condition which can be confused with this one, which will also be kept commonly in exam? Coats disease. What? Excellent. Melanoma. Okay. Now she was told melanoma, I will give answer also. Excellent. One is collar stud appearance. Then melanoma, typical B scan characteristic. Collar stud, correct. Then
Hypo.
yes, hypo. What is that? Just below the lesion, there will be choroidal excavation will be seen. Then what else? Angle kappa word. Angle kappa people don't know. The gradual attenuation of the A scan, which is, goes through the mass lesion. This is called angle kappa, which will be present in melanoma. Okay. So these three are more specific for a melanoma than a retinoblastoma. Whereas calcification and all is more in favor of retinoblastoma. When it comes to tumors in B scan, either one of these will be kept. Very rarely they may keep choroidal hemangioma, which will be uniformly reflective. They don't have well-defined margins like that. It will be arising from the choroid like that. So I think this melanoma of 3 we have told, no, color stud appearance, this choroidal excavation, angle kappa. Is one more. What is that? One more. 4 things. I'm also becoming listening. So one more just to find out this thing. Color stud appearance, choroidal excavation. See, you can blank out like this. Huh? I'm teaching this. Stress condition blank out. So these things you need to differentiate. How to differentiate between a melanoma and this thing. At the maximum, as I told, other condition which can be kept is choroidal angioma.
Rarely, if you want, that choroidal osteoma.
Great things. Usually posted, they won't keep the. This one. This is the last one. Again, don't come to the diagnosis, describe. Okay, all of you see, I'll come to the description later. Never any investigative modality when it given to your hand, don't tell the diagnosis, because the dictum is any investigative modality for that matter in isolation cannot tell anything. You have to comprehensively correlate with the clinical science, other industry, then only you can come to a diagnosis. Okay, remember all this dictum always, even when you are practicing. Fine. Now you describe. Who will describe? Yes. Describe. Just make an attempt, whatever you can. Lens echoes are seen, not seen.
Vitreous
I can't
appears.
see. Okay, fine. If you see, that's okay. Fine. Come to the vitreous.
Vitreous appears anechoic.
Anechoic. There are some, no, in this case. Dot echoes are seen. It is not anechoic like other thing, no, where it was completely black.
Hyperreflective.
It's a very dot echoes are seen.
Dot echoes.
I'm not telling in this condition it will always be seen, but this whatever they have given.
Hyperreflective dot echoes seen in the
Yes.
anterior part of the
Excellent.
vitreous.
Anterior vitreous, yes. Then
The retinal surface.
retina appears attached. Then after
retina
vitreous, I
appears
told you
attached.
should describe the retina on the surface if there's something, or attached or detached. Attached. Then
Retina appears attached.
Then
And the RCS complex appears to be
excellent.
widened.
Yes, there should be a gross thickening of the retinochoroidal thickness. Increase
Thickness.
retinochoroidal thickness. Then
Hypoechoic shadow seen. Hypoechoic shadow seen between
Corresponding to the subtenon space.
corresponding to the
So this is the
subtenon
way
space.
she described. You should describe this B scan. Okay, it will fetch you more marks. Avoid more questions also. Don't tell if you directly tell the T sign, then they will go for next. Some other which is not known, they might ask you. Okay, describe this. So suggestive of probably a
T sign.
posterior scleritis with T sign.
T sign.
You should tell like this. Okay. Where else this subtenon fluid can be seen? Yes, panophthalmitis also. You can see the subtenon fluid. Okay. So clear. So B scan. Any doubts? You know, whatever I was starting. Hyper-echoic. B scan, it's a sound-based thing, no? So it has to be echoic, not reflective. Reflective is also not this thing. See, even sound is also going. Reflection is a broad term, no? Even when it hits something, it is getting reflected. Okay. Even if you use reflective, it's not. You're not wrong.
Basically, you are
Yeah.
trying to quantify that. Black and white.
Multiple hyper-echoic output. That old-timers examiners who are into lot of bases, they would like to listen to these words. Final phenomenon, we are seeing the echo because of the sound reflection. So better to use the term echoic, hyper-echoic, not like hyper-echoic and then like hyper-echoic. Any doubts on what? See, these I think ERGs have already covered in the morning. Only BEP, I think I forgot. I was showing the case example and all that. There is a time I will try to speak this type of people on the. Go on.
Scared for the Viva.
Viva?
For the examination.
Very, very, very lenient type. Any doubts? Any doubts? Any doubts you can ask. Anything about life.
You make the mistakes before the exam.
Exactly.
Make as many mistakes as possible for the next 1 or 2 months. But probably once your exams are there, make less mistakes. I won't say that you won't make mistakes, but make less mistakes.
The stress and your post-exam practice and fellowship are inversely proportional. More the stress, once you are panic, you will be scared for when you are examining the patient and all that. If you pass the exam with more confidence, if you scare the examiner, then you will also don't try to do all this. I'm telling. Let it be a beautiful, memorable event. This thing it should not be a panic event.
Be confident of your process, not of
Be
the
calm.
diagnosis. Because you may have a lot of the cases, the diagnosis may not be correct. If your approach is correct, then you have one half it. Don't fumble with it and few things as sir has told, diabetes, fungal ulcers, case of glaucoma, number of things. They are like your Bible. If you don't know them, the questions don't move on. All these basic related, make sure that you are following. Okay.
Basically, stay calm. Don't be tense. We have gone through all this case. What I used to experience, I used to read 4 times, 3 times, and all that. Every time you read, the more you read, you feel like you're reading for the first time. Don't get scared. Somehow, once you start writing the theory and all, it comes out. Theory will pass. I don't believe in theory examination concept at all. This is like mucking up and then reproducing on the paper. How much you read, 6 months later, you will forget. So what I want you to consider practical exams and acquiring clinical skill and logical reasoning for history taking of examination, which will help you to practice also. Okay, so these things will remain forever. And this is the time which should make you to read and understand. And these type of reading won't happen again. Even in fellowship, most of the time we'll be working and all that. Reading, this is the time to yes, strengthen your basics. So how many months are there? 2, 3 months are there. May 5th, no, earliest exam. Andhra one. May 5th. June 11. 1.5 months is more than enough. Divide it. 7 days retina, 3 days glaucoma, 5 days like that. Finish one round of revision. And the first paper, Whatever the topic is, keep it 3 to 4 days before that and don't read that now. 3 days or 2 days or whatever, that should be before that. So I don't know whether you get gap in between or not. That should be your approach for theory. And practicals, whatever you're discussing, it's morning. So that's how you should look at
When I put it a little bit more symbolic, this is the only time in your life when you will read so much. Okay? So I'm just telling you in a lighter way. The next 2 months or 3 months, the only time in your life when you're going to read so much. After that, once I'm going to some specialty and all, I don't think you will know anything other than what you're reading. That too, what you're doing, and that too, you will never read about it. It is like practice.
it. By practice, it comes maybe for presentations you'll write. The last time in life you'll be reading in bulk. Whatever the misconception you had when you entered after both comprise and all that is absolutely wrong. After this anesthesia and this thing pathology, after has got amazing. Medicine, nothing. Whatever they see routinely, they will go on right.
But Optal has the biggest literature in any postgraduate field. You see, Duke Elders has about 17 or 18 volumes.
Most of them they reach Kansley and this enough. They don't actually in Jacobi, then Beckerschoffer, Krashmer, Rand, and Musenblot. And what is that for Neuropathy Pajantas? If you write these 6 books, no, then only it will. It's not possible. These are all the movies they display, no, in this in the ancient imagine. This is not possible. But what I suggest you is, I don't know whether this is the right time to go. If you are confused about a particular topic, like if you are reading again and again, if you are not able to remember, okay, and every time you read that you're forgetting the concept, so better to write it down from a 2-3 sources. Okay. So, for example, NAION, you will go to the NF in general, neurophthal is given generally. Write it on what are the factors, things, and all that. Go to some latest review articles, read it, and write it down. When you revise from the same place which you have handwritten. Don't go to the textbook and read. This helps. Okay. There will be some 10-15 topics like this which will be like puzzling in your mind. Make a list of those 10-15 topics and put an effort to make a notes on that. Don't take much time. 1 or 2 days will be able to. And when you read for the second time, read from your own handwriting from the same place. Otherwise, these 10-15 puzzling confusing topics will spoil the whole thing, entire thing, which you are supposed to know.
So one extra thing what I would suggest is for fundus and for cornea diagrams. Draw a diagram, describe everything in the diagram. It is self-explanatory. You don't need to write the theory. You want to explain something like say for keratoconus. You draw a circle, picture there is a yes stripping and some bone stride, there is some thinning, then there is some enlarged cornea. That way, you not miss more. It is only impossible to remember everything. Sometimes if you are able to remember 6 or 7 important points, you have done a reasonable job. So, for example, drawing up a transparency, giving marking, few things you need to drop. You will recollect it, you will be able to diagrams, charts, and good speed.
Yeah, good speed is sleep for minimum 7 to 8 hours. That is the example. And don't exceed that. So get that comfort zone of 7 to 8 hours. Or working in time. Don't do that. And see, teaching is the best way to remember. Keep discussing with your colleagues. For example, divide the topics into like batch of 50 people. I will read about pegs today, you read about RP and all that. When you read the topic out, tell that person. Once you speak about it, you can make it. And remember one last thing. No examiner will come prepare for this thing. They won't read on the previous year's exam. They are going to ask all the questions based on their experience. It will all be practice, clinical skills based on the basic. The examiner from previous year will be read and remember this stuff. All the questions. Okay.
First, just remove all of these things, clear up the area first.
शानू जी मैच है नहीं रे ऑन करी का ना
So we have finished 4 sessions of CPV. Hope you have presented all the cases and gone through all the viva. There must be definitely some gaps here and there, maybe. So whatever that you're not, you have not felt adequate, whatever viva items that probably needs, because we might have asked you a question, but maybe we would have not told you exactly how to answer it if it comes next time. So tomorrow is the time where it's a very flexible program. We have a wrap up. We have some cases which are not in these 8 cases, which will be presented by our postgraduates in the hall, so that we can have the right one common platform to discuss such kind of cases. We'll be presenting a proptosis, a thyroid, a myasthenia, okay, some cornea cases, which are not in our already list. And also probably we'll go through all the viva items, and probably we'll tell you the format, how you need to answer, so that you can probably make a note. See, you need not have to write down the answer. Probably make a note to prepare an answer at home and keep it ready for the exam. So exam is all about making some, preparing notes and learning it and going to the exam for that particular thing. And also the refraction is remaining. I think we'll take it up in the morning, first in the morning itself. And corneal diagrams. I think we have seen retina diagrams. Tomorrow morning will be the corneal diagrams. And the final part of topography, how to read a chart, that is remaining. So that we will finish. And also some people are asking about the some definition, some understanding about basic refractive surgeries like SMILE, or what are all the different techniques. So at least for your understanding, we can probably discuss some basics of it, and also the different endothelial keratoplasties. Now there are so much of DSEC, DMEC, PDEC. So what exactly they mean, that will also be covering in the grand rounds. And some idea about how to write a theory exam, and maybe a few discussions about the career and soon after the exam. So what will be your, so some interaction we can have. So now it's time to thank our guest faculty who have traveled, far and wide for this program. You must have seen their brilliance, their patience, their wisdom, and their experience of being such good examiners. They were not only asking questions, also answering them. And probably that must have hiked your confidence to take the exam. So without whom, I think such programs will never be possible. And they always have been coming regularly to these programs. And because of them only, this program has been so successful. Okay. So it's our duty to thank them with a small token of affection, starting with Dr. Sandhya Ramchandra. So we have been together for a long time. And she's a person who wears many hats. She's not just a pan-ophthalmologist, a very good pan-ophthalmologist with a retina background, with a retina degree and retina practice. She's also into many other things, medical ethics. She's into medical legal law. She's probably a master of everything, and always a very chronic examiner. She knows the pulse of the students so well. Thank you, Sandhya, for making it here. Thank you so much. And Dr. Anupama Desai, she's our own home faculty from SDM College, Dharwad. She's extremely patient and always very useful, just like I told our home faculty. Thank you, Anupama, for making it to Hubli and taking care. Thank you so much. And Dr. Kavita C, she runs one of the most disciplined department in Hassan Institute of Medical Sciences. One of the very well-known teachers, had a penchant for teaching. Thanks, Kavita. Thank you so much. And Dr. Purna Chandra, his enthusiasm to teach postgraduates is never ending. He's a retina guy, but he's mainly into his passion is postgraduate training. Thank you, Purna, for completing the ordeal, making it complete. Thank you. Tops? You are not starting? So we have 3 small talks. I think we will clear that first. And then had certain promises to fulfill. I think we have not discussed the neuro-ophthalmology roundup. there are some basic neuro-ophthalmology which I wanted to discuss, which are both important for the theory and practicals. What I'll do is I'll just only touch upon the aspect which are difficult to understand. I think the rest you can read up. At least if you know something about these entities, it will be, you'll be able to understand it better, and at least remember that much. That is one thing. And also about the oculoplasty, the common oculoplastic conditions which are kept in the exam, and the confusion regarding the management of these conditions like ectropion, ectropion, and such things. So we will probably cover that after the these three talks. At morning, we were discussing one of the batches about the management of glaucoma. We said, how do you manage this case? Now, there was a case that was presented. So they started with a drug directly. Okay. See, whenever you are asked to tell how to manage a case of glaucoma, medical management, if you are planning, you should always start with the concept of a target intraocular pressure. See, that is the most practical way of managing a case, because intraocular pressure is the only modifiable factor. And with that, we will be able to manage the glaucoma for that period, unless if you are planning a surgery. So always start, say, sir, I would like to fix a target IOP for this patient. So the thumb rule for target IOP is what is generally accepted. There are many things about target IOP. Don't get into the nitty-gritty and complexity of it. Okay. The simple thing is, if it is a early glaucoma with an early damage, okay, it is higher teens, like 17, 18, 19. Okay. If it is advanced glaucoma, okay, or a moderately advanced glaucoma, it is lower teens, maybe 13, 14, 15. And extremely advanced glaucoma, it is usually 12 or below. You cannot reduce the intraocular pressure, below the, can you complete the answer? Below the episcleral venous pressure, because obviously it has to drain unless you do a surgery. With no medication, you can reduce the intraocular pressure below the episcleral venous pressure. If you do a surgery, of course, you can make the IOP 0 also. Okay. So target intraocular pressure. So you just say there is no way by which you can arrive at that number. Let us say you got like today we had one case, very advanced glaucoma in the right eye. Okay. We almost had biarcade scotoma with very low VFI. So that's where the pressures are 36 in one of the cases that has been given to you as a model. So here is a patient who has got a right eye glaucoma, advanced damage. Pressures are still 35, 36. So definitely that is not the target IOP. In this case, I would like to keep the target around 12, 13. So in this case, how many drugs you would require actually? So if you start medical management, if he is not on medical management, probably you think that any amount of medication probably cannot reach 12. Okay, you may say individually each may work 30%, 25%, 15%, like prostaglandin analogs reduced by 25 to 30% from the baseline. Timolol in the beginning will work to 20 to 25, but with tachyphylaxis slowly the effect comes down. In fact, any receptor blocker drug will have a tachyphylaxis because it will not be effective after some time because the number of receptors will increase. So you have to give a holiday to the drug, then the receptors will come down. Again, you can restart it. What you call is a drug holiday for timolol. Okay, so it will later come down to 15 to 20% only. Dorzolamide, carbonic anhydrase inhibitors as well as alpha agonists will work to 10 to 15% only. But if you put all of them together, it won't add up. That is the problem. The side effects will add up, but the effect won't add up. Okay, so we'll never be able to bring the pressure with medication to 12. So in that case, and also that patient had eventually a cataract also, that's given. So it will be an ideal situation to do a combined cataract and a glaucoma procedure. So bring down the pressure to around 12, which is not probably pharmacologically or with a pharmacotherapy possible. Okay, so this is very important. So you'll have to probably give a reason why you want to bring the pressure to that. There may be another case where there's an early damage. A similar patient, 36 IOP, first timer with a very early damage, just hardly a starting of a superior arcade scotoma. So maybe we'd like to keep the pressure between 1920 like that. Okay, in that case, maybe you can start a prostaglandin analog, maybe add a beta blocker, maybe you can add a, so only thing is you won't start everything together. You start one drug, wait for 15 days or month, and then you can add the second drug, like third drug. The third drugs can be, see, always you start with a prostaglandin analog. So what drug you start with, you always have to say, sir, I would like to start with a prostaglandin analog, because usually it is well tolerated, there are no contraindications. And I would like to check the pressure after 15 days. If normally if the target IOP will not be reached most fully, so I would like to add the second drug. Okay, that is the beta blocker. If there are no systemic contraindications, you always add this suffix to the beta blocker. If there are no systemic contraindication, I would like to add a timolol. Okay, then I would like to do a diurnal variation of IOP to see whether it has reached the target IOP. If still it is hovering on the higher side, maybe I would like a third drug, either a carbonic anhydrase inhibitor or a alpha agonist. So always use the pharmacological name, don't use trade names, don't use the actual name. You say the class of drug, because there are many options in the same class of drug. So the third and fourth will be the carbonic anhydrase inhibitors and the alpha agonists. So you have basically 4 drugs. The rest all will not really much. In an angle closure glaucoma, chronic angle closure glaucoma, maybe you can add pilocarpine. That also works to some extent to reduce the intraocular pressure. So you have only limited, medical management scope, and most of them which will require basically multiple drugs, 4 drugs or more, and pressures not really coming to really the target IOP would be a good cases for surgery. You can as well take the decision right in the beginning also. Okay. So whenever you are discussing medical management of glaucoma, start with target IOP. Then always say that you will start PG analog, next a beta blocker, next a brimonidine. So like that, in that sequence you need to tell. So this really have to build up a discussion. So that is very important. You will go with this?
Yes.
So we'd like to take a vote, like how many are women here? Huh? What is it? So actually, there are sessions in conferences called, so she was supposed to teach you squint actually, but he said, I think I'm seeing their faces. They're all, totally, they've been drained out of fun and energy from morning giving cases. So we talk about life. Okay. So for those very few things that people I can see around here, okay, this is important. Okay. If you understand this talk well, you will live as a minority, okay, in future. You will live in harmony and peace. Okay. And for the rest, it's actually an eye-opener. In fact, I've heard this talk once and I found that probably this is a very, very important talk. See, because you people are just at the very cusp of the beginning of your career. Okay. So women always, I say, no, you people, you women in ophthalmology, if you think you are equal to men, it is foolish. It is foolish to think that you are equal to men. You are actually far superior. Okay. So being a woman in ophthalmology, so what it takes, how you can, manage and try to become a very effective ophthalmologist of tomorrow. Yes, I was talking to you about the importance of cataract surgery in your life. So similarly, how do you manage multiple things and still end up as a successful, ophthalmologist? You have to hear it from the person who's actually done it. Okay. So Dr. Deepthi is known for her, penchant for making complicated things look easy. Okay. I think we'll hear it from her.
Okay, so why did I select this topic? You are all drained of ophthalmology from morning. Yesterday, you people like that one talk. I found out that how to write the theory paper. You loved that talk because it was something out of the box. I think that really woke you all up for the next session. So the next session by sir is really important. So before that, drain mat ho jana. So something out of the box. It is important for you also because you have a wife. If you don't have a wife, you will have a wife, and you have sisters. I think you are supposed to know that as a woman, we are multitasking and you need to give an equal amount of space to us also. And as a woman, I think I need to understand what my husband is going through or what everybody is going through. So everything is important. Balanced life is very important. Sir said we are superior, but recently I gave a talk on Women's Day. I was called as a chief guest elsewhere, and I said nobody is superior. Women is equal to men. That feminism is all absolutely, I can use that word bullshit. There's nothing like that. If they were not there, we wouldn't be here. If we were not there, they wouldn't be here. So more or less all of us are equal. So let me go to the first one. So why? Because nowadays 72%, this I had done this research because I was asked to write a paper in Yosi as to how is it being a woman in pediatric ophthalmology, kids with outside the OPD and kids inside the OPD. How do I feel whether I give equal time to my children versus the children in the OPD is what I was asked to write. That's when I went through some research. American Academy of Ophthalmology as of now says, so this is American data, in Indian data will be way above this. So 72, 90. So India maybe 90%, but then it's 72% residents in women in ophthalmology are basically women. Yet very few women are at the top. We know few of them who are at the top, but there are lots of men who are at the top. Striking the work career balance, somewhere people get exhausted in the middle and they start blaming we start blaming ourselves that I did not manage this properly or I did not manage that properly. Well, that is nothing. We can manage everything properly. Women are known to multitask, and definitely ophthalmology as a field is much better. We all have thought that before taking ophthalmology, isn't it? In fact, frankly speaking, I did not, my parents wanted me to do gynecology, but without telling them, I had filled up. I think the St. John's guys here know that we fill up our interests before we give an entrance exam in St. John's. So I had just filled up ophthalmology and my parents had thought I have filled up OBG. So my mindset was very clear that I don't want to, I want a happy family also in addition to a happy career. That is what was my thing. So you people have taken ophthal with that woman, you have thought that and you have taken, otherwise maybe all of you would have been in OBG. No harms for OBG, but still, so we have already chosen the much better career in our life. Why not make it more better? The most important, so this is among the fellowship, which all of you have a question in your head. So what fellowship to take next? This is again a survey which has been done by American Academy of Ophthalmology, which shows that women are maximum, I'm sorry. So women have, majority of the women are seen in this pediatric ophthalmology is what they have noticed. Maybe because we bond more with the children, we have children at home also, and maybe that, what to say, that femininity, that emotion, that bonding, it's nothing like, I'm not saying males are less. There are so many pediatric ophthalmologists, including KP sir, Pradeep Sharma sir, Rohit Saxena sir, everybody. There are so many eminent ophthalmologists who are males too, but still somewhere women score over that. So that is what most of the women end up taking that. Other than that is the glaucoma, the refractive part, and then the rest of it comes. So the most importantly, you need to remember that what you take is that would be your future. You will be spending your whole life into that one field, and there are some fields which have constantly got an emergency. You know your family very well. So if you take up a cornea, you can never say that if there is a corneal tear in the middle of the night, cornea just doesn't mean refractive. Let me make it very clear to majority of the people here. You all think cornea means refractive. No, cornea means corneal ulcers. Cornea means doing PKs. Cornea means correcting corneal tears in the middle of the night. So there are some fields, retina, when there is an end off in the middle of the night, you cannot tell no. So think about it in that way. I don't tell that there is no emergencies in pediatric. There is still corneal tears in pediatric. There is still emergencies with respect to glaucoma, phacomorphic, phacolitis, which come in the middle of the night. So make sure that You know what your interest is, because that is one thing which you will be leading throughout your life. And so my interest was with pediatric ophthalmology. I had always loved children from the beginning, but still somewhere sir had actually influenced a lot in my taking of fellowship. But I am enjoying my fellowship. Well, that is me with whole lot. They are not my kids, all of them, but then they are my kids. Somewhere over a period of time, all of them have become my kids. So that's how I can say them. The most important funda I would like to say is dedicate yourself. The first question which people ask me, marriage. It is compulsory. You need someone to scold and scream at when you go back tired from home. You can't do that throughout your life on your parents or on your friends. Frankly speaking, to remove all your temper out, to just feel loved when you go back home, well, that is, you need a life partner. It is compulsory. I would put it as a compulsory. It's not like compulsory from what to say, rule book point of view, but you will enjoy your life. You have somebody to lead your life throughout with someone, and you don't realize it now, but maybe 15-20 years down the lane, that life partner is the most important person in your life. So marriage is important. Next question comes, when do you get married? How many women here are married now? How many men are married here? 1, 2 are there, okay, but the percentage is fine. There are only 4 of them, of which 2 are married, so I think that is okay. So I was wrong in telling you have a wife. Okay, so so yeah, majority of the time I would like to say that PG period is the best time. You're already ending your PG and I'm giving this thing in the wrong time, but PG is the right time to get married, because number one, that's the right age. From the gynae point of view, there are so many of my gynae friends who tell that you need to have your first children within about 30 years of age. It's not like compulsory, but I see so many people, really so many well-to-do couples who have had children after 35 or 36 years of age, who bring their children with me with some or the other abnormality for the eye checkup. They have been referred by the pediatricians. So I don't tell you it is compulsory that you need to have a child within 30 years of age, but I think our body is made up in such a way. We all know what are the side effects of elderly primary and all. So I think that is one of the reason. Now, but then the other reason being that fellowship doesn't leave you. You don't get so many leaves in your fellowship. PG days, you do have your leaves. I used to come, maybe during my PG days, I used to travel every Saturday night and reach here Sunday morning, meet Dr. Srinivas and go back on Sunday night. You can't afford to do this in your fellowship, because the fellowship Sunday also has a work. So I have all my 3 years of my PG, I had roamed every Sunday, alternate Sunday. I used to be here, he used to be there. Both of us were PGs, maybe. So things, I think you spend a quality time with your better half if you do it in your PG. So PG, I would consider the best. Whom to marry, that is left up to you, because that is the second question whom I put there. You all might have already selected whom do you want to marry. Like my PGs here have already, they have their own selection, so I can't tell them anything. But then someone, be very clear from the beginning that you are going to work. So that is what, if you are thinking, so if you are really, so your better half should know what are your requirements. I was very firm from the beginning that I want to work. I would be working. I wouldn't be leaving my career. That is something which I have earned my seat, and I have struggled for my MS ophthalmology. So I want to work, not like I will leave the family and work pura din kaam karti rahungi. No, but I have a dedicated time, 10 to 6, sharp 6 I'm at home. Everybody here knows this, my PGs, my fellows, everyone knows 6. I just close the OPD and I run home for the sake of my kids. But 10 to 6, I dedicate it for the sake of others' kids. So whom is a very big question. When you're marrying, make sure that your better half knows what are your requirements, what are your needs. These are some small things, but makes a long difference when you are going through, because this marriage is going to last throughout your life. So that's what I've written down. It is compulsory. The next, after that, pregnancy, that is again up to you. But in short, I would like to put it like, again, the age part, and either finish your PG and go for a child, or finish your fellowship and go for a child. When you have it in the middle, it becomes like neither idhar ka nor udhar ka. So plan it in a, you people are all very well what to say, you know things better than me. At your age, I think 10, 11, 12 years back, I was not really very clear with all these ambitions, but you people know it better than me. So when is a very big thing, but majority of the people, I see my own fellows telling me we don't want to go ahead with the pregnancy because when we have struggled so hard with the fellowship, बच्चे करेंगे, उनको देखभाल करेंगे, there is a halt in my career. So this motherhood, maternity leave, so is it a boon or a bane? There are both ways out. With my first child, I had taken 9 months off. I joined, she was born in March. I joined in November, Deepavali. How many months? I don't know, 6 or 8 months, something. So I took a complete off. It was not an ophthalmology, nothing. I just spent time with her. I had dedicated that whole 6 to 8 months for her. So that is one way of spending. Don't feel guilty. Those months will never come back to you. Once your kids grow, now my children don't need me. They leave me off. I can spend my own career time now. Or with the second one, I had joined back after 2 months. She was born in March and I joined back in June. But during those 2 months also, I spent my time, quality time, doing quite a bit of work. Like we had organized a pediatric ophthalmology conference then, which was a national level SPOCI conference. I had worked for that sitting at home. There are other ways. You can actually write some papers. You can actually prepare some publications. You can read, do lot of activities. So it's not like that. There is a way in which you can balance your maternity leave also. So first 2-3 months, kids only sleep. So you can publish your papers. You can write few papers. You can submit few papers for the conference. This time you will never get back. Or there may be few of you who thinks motherhood is like once in a lifetime. I want to spend it with the kids only. You can do that part also. So you can make it into a boon, or you can just crib through your motherhood thinking मैंने बच्चा कर लिया, हो गया, मेरा पूरा life खत्म हो गया. No, that is not so. Eventually all of us in this world have kids. That doesn't mean that successful women don't have kids. Everybody has kids. How you balance is what matters. So now coming to the maternity thing, do you need to take a leave? That is what I stressed, maternity leave. So or do you need to leave your work after your delivery? I need 2-3 months, I need 2-3 years till my child becomes 3 years of age. I need to leave work, I need to stop working. So is that so? No. The current, so how do you proceed with that? I have been very lucky. I have my own in-laws with me. So they have been taking care of my kid right from the starting days. इसीलिए in-laws को अच्छा रख लो, लड़ाई मत करो बैठ के उन लोग के साथ. That is one more lesson what you learn. Otherwise, there are part-time. Many of my PGs and fellows here are actually having part-time caretakers nowadays. They are available. So you can start your work once the child is about 6 to 8 months. Start it as a part-time initially till your child adjusts to your absence. Keep it maybe 6 hours a day, 4 hours a day. Slowly there will be a phase that your child knows that this much amount of time my mom is not at home. You can then slowly make it a full time. And it is not always necessary. Remember that people know you only because of your OPD works only, or only because of your OT works only. There are other ways to make yourself known to the whole society. You can, that's what I mentioned you can do lot of research work. You can publish your paper. When your paper comes in some public journals, people eventually end up reading that and they find there is a name in that. They will Google you back. They will know that you're existing. Or you can actually send some paper publication. When you send this year, the conference is obviously 6 months away. Your child would be 1 year old by now, by then. So you can do some paper publication, send it for your paper presentations, poster presentations, all those things. So again, when you are thinking 6 months down the lane, you go and stand on a podium and present, you're again making yourself known to the people. So it is not that सिर्फ OPD करके OT करके ही लोगों को अपना रहने का वो बताना है. That is not necessary. There are other ways also. So there are multiple, these are two of my papers, in fact, which have won the best paper award in the Squint AIUS. Sir has also always been in a support with that for all these things. So people knew who is Deepthi when such things happen. So this was not because of some patients. I mean, yes, obviously, when we work on the OPD, only then we get patients for publication. But then just seeing that is not important. You need to do something more than that. Go and present, stand on the podium, do some presentation. When you stand and go to the conferences, get to know new people, meet new people, tell them you are working in this place. Suddenly, when I have a patient, I remember that girl had introduced me that she's in that place. This patient is going back to that. I'll write a letter and send ki rest of the follow-up you can do. So in that way, you're actually getting back new patients. So conferences are very important. Write some articles for newspapers. Do in some wherever you are staying or wherever you are working, make yourself known to the general public that you're actually working. You may be working for 4 hours, but if the general public gets to know that there is a pediatric ophthalmologist who is working for 4 hours, in those 4 or throughout the day, those 4 hours will be quite a rush in your OPD. So you can eventually use up those 4 hours and go back happily to the home. So now, in this way, that's what I said. So it's not necessary that you slog for 10 hours, neglect your family, but it's important that you intelligently work when you're working. It applies to the gents also. When you start your own hospital, it's not that easy. You have a huge competition as of now with respect to ophthalmology. Use all these small techniques. Try to make yourself known to fellow ophthalmologists, fellow doctors of other departments, because they have to refer cases to you and to the general public somehow, and that actually makes those 4-5 hours worthwhile. So the next few questions which many people ask is there any workplace discrimination? No, absolutely no. I think right from my initial days, I did not know. When I had frankly joined, my surgical skills were poor, my clinical skills were really good. If KP sir and Srinivas, my husband, he wouldn't have been there. These two people have always constantly guided me through all the procedures. So whenever I have any, I think whatever I do today, my surgical skills I owe to sir. And whenever I have been in the middle of the night also, when I have got up to see some cases, my kids have been taken care by my husband. So there are two males who are behind me. So how, when there is no discrimination at home itself, how can there be this is all just a mental block what we people have, that there is a discrimination. Current 2021, I don't think so there is a discrimination. In fact, that's what I stressed you. We need males. We cannot tell that without them we won't work, or without us they will not work. It's a complete balanced one. Workplace discrimination absolutely doesn't exist. Patient discrimination, to some extent, yes, they do that. When there is a my own fellows, when they were males of slightly taller height and well built, patients used to feel that wo bade doctor hai. Yesterday Dr. Maina was also telling the same thing. So till date I am still felt, I mean, seen by many patients as a very junior doctor because of how I look. But then we cannot help it. I don't want to put on weight, or I don't want to put on gray hairs. This is the way I am. I'm very happy. My husband is happy with me, so I'm not going to change physically for that. That is not happening. But first 3 to 4 years is tough. You need to struggle. But after that, the patients whom you have done well, they will refer patients to you. Whether you are a female, you are a male, whether you are a junior, whether you are a senior, they will go back and tell that that doctor is good. And so if you are good in subject, no matter what sex you are, however you look, finally patients will come back to you. So after a period of 9-10 years, you have your own clientele. You will definitely have your own clientele. You need not crib about the patient discrimination after 3-4 years. So first initial 2-3 years may be tough, but then I think we can put on with it. It doesn't matter. Don't let your ego come in the middle in the first 2-3 years. We are still junior doctors. So after all the workup, if they say हमें उन डॉक्टर से मिलना है, भेज दो, चलेगा, गए, it's okay. कभी ना कभी वापस हमारे पास आ ही जाएंगे, उसमें कौन सी बड़ी बात है. So send कि ठीक है, ले लेना उनसे भी एक opinion. So don't bring any egos in the middle, either in the family or in the professional spaces. Let the works happen. After a few years, people, other doctors, everybody in the family will definitely recognize you. But first 2-3 years, there will be some amount of that. So this is something which I found. A woman becoming financially independent doesn't equate to I don't need a man. This is what I was telling you. This is all pseudo feminism. Don't read all those things in the Instagram and feel कि मैं great हूँ, मैं woman हूँ, मेरे साथ abuse हो रहा है, मेरे साथ discrimination. कुछ नहीं हो रहा है. Just remove all those dumb Instagram posts from your Instagram as well as Facebook. Just remember that yes, definitely we are made to multitask, but we need them. They need us. We need their help. If I have a nucleus drop in my during doing phaco, I need my husband. He's the one who is going to remove that nucleus out and put IOL and give. If I do some complication while doing trab or something, I need KP sir. He will be the one who will be rectifying it. So it is like that. We need people. We need them. They need us. It is similar to that. So finally, coming to I would like to conclude that one first conclusion is regularly reassess your priorities. So that's what I told you. With the first child, I slowed down. Then I again took my career somewhere up. After 5 years, I had my second child. Again, I have slowed down. Then maybe after 2 years, when now my daughter is 2 years, she doesn't need me till 6, 7 years, 6 o'clock, 7 o'clock. Again, I may pick up my career now. So there will be dips and downs. There won't be every day is not a Sunday. Every day is not a Monday. That doesn't mean you need to go into depression and pop up pills like Deepika Padukone. That is not needed. So just regularize your priorities. 2 years, my first daughter was important. Then she didn't need me. I concentrated on career. Now 2 years, my second daughter was important. I concentrated on her. Now she doesn't need me. I'm concentrating on my career. So that dips and downs. If somebody in your family is not well, 1 month, spend time with them. That is also equally important. So reassess your priorities. Don't feel the career is not the only thing in your life. There are lots of things beyond that. So regularly reassess your priorities. And there is a life beyond ophthalmology also. To everybody out here, don't slog and finally पूरी जिंदगी में क्या किया ऑफ्थाल छोड़ के कुछ नहीं किया. That shouldn't be the only thing. If you have hobbies, if you have something else, go pursue it also. Like my daughter learned, she's still learning dance. I'm learning dance from her. She has learned chess. I learned chess from her. So spend time with them. I have been interested with anti-sexual abuse education to school children, which I do regularly. I'm still involved with the Masum activity. Now the schools are closed. We are doing it online. But somewhere I go and educate students throughout the schools of Hubli about what is good touch, bad touch, so there should be something else other than ophthalmology also. Don't feel guilty that you're spending 1 hour or 2 hours in a week for some other activities other than the ophthalmology part. Spend time with your friends, party with your friends. Remember, finally, the final conclusion is the F word. What is the F? The family. So that is the most important thing. That is the most important thing which you need to concentrate on. When I was not there for 3 months during my maternity leave, patients did not go back from the hospital. They showed to some other doctor and they went back. So if you are not there, somebody else is there. But at home, if my daughter is not well, I am the only mother to her. You are the only father to her. Remember that. So family is the most important thing. They don't have a substitute, but patients do have a substitute. Remember that family is the most. Again and again, I'm stressing that. Just for the sake of your career, don't fight, don't argue in the family, don't spoil your family life, don't lose those small moments of the family, which at this age is the most important. When you're 60 years old, there may not be anything much left to enjoy, but at that time we have plenty of time to enjoy. But what is the fun in doing? We would be diabetic, we would be hypertensive, bahar jaake kuch kha nahi sakte hai, pee nahi sakte hai, kya karna hai leke. So that is when you have time, make time for everything, enjoy. Don't crib that I'm a female and I'm being pushed back. No, that is not happening. The world is open for you. Just prioritize your life. If you're getting married now, 2 months husband के साथ spend कर लो. उस टाइम पे ये मत सोचो कि फेलोशिप करना था and fellowship के टाइम पे अरे पति के साथ रहना था, पति के साथ. So don't, when the grass is always greener on the other side, just concentrate on that one thing what you're doing. We women are known at multitasking. We can definitely do it. So all the very best to all of you. Select whatever fellowship you want to do. Get married, have children. To my own fellows here, she's run away. So get married, have children, enjoy the family life. That is equally important as your career also. So all the best. And all the men here, we are doing a lot of other jobs other than ophthalmology. We manage the family, we manage your financial securities, we manage lot of things, right from your small cooking necessity to everything. So respect your wife, let her have her own career. So all the best to everybody over here.
I think that will take some time to get sink in actually. But few things, I would just to probably echo a few things is about, there are both extremes. I've seen a lot of, my postgraduates, mostly women because of the statistics. I've also been interested in how their actually career shaped up, and I've been able to help them with some advice sometime. Normally, I've seen some of the very brilliant postgraduates, women, of course, have actually, taken this, sometimes the easy route. Like they get probably a government job and they just go there. They get they are so much unchallenged in their life, even though they were so good. Probably they did not take the fellowship, when the time was actually ripe for that. So, but basically, as she said, it's very important that you need to take one thing at a time. Your biology, the societal pressures, the everlasting patriarchy will definitely demand you to kind of step back from your career and take the things, one at a time. So marriage, children, family, all these things obviously will happen. But at the same time, once that is over, please try to spring back. Don't get carried away in that, okay? Because some of the very brilliant, my postgraduates or my junior, colleagues in ophthalmology have not been able to really, get what their potential actually was. But one thing, there's an entire lifetime for ophthalmology. I know Dr. K.R. Murthy's father, who was practicing till the age of 86. He used to see 20 patients a day when he was 86 also. That means patients will come. The longer you sit in the OPD, people keep coming. More hair or no hair actually gets you more patients. So gray hair or no hair actually is better. So as you age, it's like wine, you become more precious, more important for people. So there is no end to, there's no retirement in ophthalmology or medical field. So don't have to really do everything now. So what is important at the right time, as she said, be at the moment, enjoy the moment. You are right now here, just worry about this part. Don't worry about tomorrow. So you're taking exam, you take exam. Be at it. You're marrying, so don't try to mix up your priorities and think of something else. You are always either having a remorse for the past or the fear for the future. You're never at the moment. I'll probably suggest you a book by Eckhart Tolle called The Power of Now. Okay, where it says you be here and now, and that will solve all the problems. Okay, so I think that is an advice for the majority of people here. I think with women increasing in ophthalmology, maybe after 10 years, I will be giving a talk about how to survive in ophthalmology for men. Maybe there'll be one or two in the crowd, or maybe none. Okay, so with this, we now shake up and get back to ophthalmology. So about neuro-ophthalmology, I think now I want you to be a little interactive after this lively talk, okay? And please write down few important things and discuss, or maybe ask me question. That would be better, because I will really do not know exactly what you want in this thing. So now it's a few things about neuro-ophthalmology, what is required for the exam, or what you should know as a postgraduate, okay? See, they will ask you about pupil. You should know everything about pupillary reactions, the different kinds of pupillary abnormalities, the pupillary pathway. Okay, what the pupillary pathway starts with? Let's say this may be simple. You make mistakes in simple things only. You may know all about AD stonic pupil, but you may not know exactly how do you start pupillary pathway. What it starts with? It starts with retina. Okay, photoreceptors. Okay, the photoreceptors. From there, optic nerve, then Chiasma, optic tract. Then the fibers deviate before reaching the lateral geniculate body. Fibers reach the pretectal nucleus, that is in the superior colliculus, where there are interneurons and they kind of synapse. They basically join the Edinger-Westphal nucleus. That is the subnucleus of the third nerve, which is important for the parasympathomimetic or a parasympathetic system. From there, third nerve, then it comes into the orbit. Then the nerve to inferior oblique, the branch enters the ciliary ganglion. There is a synapse. So preganglionic parasympathetic fibers start from the Edinger-Westphal. They synapse in the ciliary ganglion. So postganglionic fibers through various short and long ciliary nerves, they innervate the ciliary muscle as well as the sphincter pupil. Okay. So that is the pupillary. That means that is the afferent limb. This is the afferent limb. So you should be able to trace this. And also it happens that those fibers also innervate the opposite Edinger-Westphal nucleus. That means there is with the light falls on right eye, both the pupil constrict. The direct reaction is usually stronger. The consensual is slightly weaker compared to the direct. So that is the very reason why you have an RAPD. So RAPD is a situation where because of the decrease in the optic nerve conduction, because of an extensive retinal pathology or an optic nerve pathology, there is a paradoxical dilatation of pupil when the light is shifted. Okay. Even if it does not dilate also, it is a mild RAPD. For example, you put light in the right eye, which is a normal eye, let us say. The left eye constricts. The left eye has an early optic neuritis. When you shift the light, by convention, this pupil has to further constrict because it is constricted for for an indirect reaction, maybe 3 units of constriction. When you put light, another 2 units it has to constrict. It has to constrict further. If it does not, then also it is abnormal. Okay, that could be a very questionable. That could be an early RAPD or a mild RAPD. If it dilates, then definitely it's an RAPD. If it dilates too readily, then it's a very severe RAPD. So which indicates that the optic nerve is more seriously affected. So pupils are the most objective measure of your optic nerve conduction or a posterior segment. So no other test can equal this. So whenever you never miss an opportunity to check pupils when you have a opaque media, like you have a total cataract, okay, when you have a vitreous hemorrhage, so please check the pupil. That is invaluable, and no amount of tests, any other test can equal anywhere near pupillary reaction. That is the reason why we stress so much upon the pupil. Okay, so there are some pupillary abnormalities you should know. So one is about Horner's syndrome. See, Horner's is a short note, can be asked in the exam. Some examiners know about Horner's syndrome actually. So a few things. What happens in Horner's? It's a sympathetic denervation. So you should also know what is the innervation to the dilator pupillae. Okay, from the superior cervical ganglion all along the great vessels of the neck. Basically, the sympathetic fibers go along the blood vessels. They don't have a separate nerve as such. They go along the blood vessels till where they want to reach. And finally, do they synapse in the ciliary ganglion? No. Okay. They are already parasympathetic. From the superior cervical ganglion, they're already coming up there. And they pass to the ciliary ganglion, but do not synapse there. They go on basically innervate the dilator muscle. So whenever you have some kind of a sympathetic blockade, some kind of a sympathetic denervation, what happens to the pupil? Because there's no dilatation happening, pupil will become small. So in Horner's, there is a meiosis. There are other features of Horner's. What are the other features of Horner's? See, the Muller's muscle of the lid is also innervated by sympathetic system. So normally 1 to 2 millimeters of elevation of lid is taken care by Muller. So there is a drop, there is a ptosis, a very minimal ptosis, like 1 millimeter to 1.5 millimeters of ptosis can happen in Muller's, in Horner's syndrome. What else can happen? What are the other features? Anhydrosis of that part of the face, because it also supplies the sweat gland. What else? when you pinch the neck. So loss of ciliopspinal reflex. So this is the thing. There are some people also say about enophthalmos. Okay, but what is important is the meiosis. So if there is a Horner's, they will ask you two things. Okay, if there's a Horner's, what they will ask you is about the cocaine test. They will ask about a hydroxyamphetamine test. Cocaine test is for basically confirming whether it is okay Horner's or not. So normally there's an anisocoria. Don't worry about those anisocoria in dark light. I think forget all that. Okay, it's not required. Pupil is small. This pupil is normal. This is meiotic. When you put 1% cocaine, okay, what happens to the pupil? See, normally what does cocaine do? It basically stimulates it's an alpha receptor. It's a sympathomimetic drug. Okay, that's why when you go high, when you're on coke. So it stimulates the alpha receptors and causes pupillary dilatation. Okay, so when then it says that probably so far the sympathetic system has not been stimulated. By stimulating the sympathetic system using cocaine peripherally, by peripheral stimulation, you are causing a dilatation, means that it is Horner's. Okay, this is important. If it is small because of let us say senile meiosis, if it is small because of a posterior synechia, okay, it won't dilate. Only in Horner dilate. So put 1% cocaine. If it dilates, then it is Horner's. Then what we do is we want to know where is the problem. Is it well before the superior sympathetic ganglion? Is it preganglionic or postganglionic? If there's a postganglionic problem, there is a degeneration of the the nerve endings. Okay, then always when there is a postganglionic is cut, the nerve endings degenerate. Preganglionic cut, this nerve is still intact. So they still have the nerve endings intact. So what you do is if you put hydroxyamphetamine, okay, what it does is it basically releases the preformed epinephrine at the neuromuscular junction. So it causes dilatation again. So if you put hydroxyamphetamine, if the pupil dilates, it is preganglionic. That means the postganglionic part is intact. If it does not dilate, that means the nerves have degenerated because of it's a postganglionic lesion. So just this much is enough. You don't have to really crack your head about this because you don't get that very often in practice. In the exam, this could be the only thing. Next, about Ades pupil. Ades pupil is quite common. In fact, we just had a patient 4 days ago. So because you miss it, people don't come complaining about the problem. So Ades people are usually young individuals or middle-aged. And Ades pupil need not be a simple thing. Sometimes it can herald a serious intracranial problem. But most of them are idiopathic and normally they do recover on their own. What is Ades pupil? Ades pupil is just like this is a sympathetic denervation, this is a parasympathetic denervation. The pupil is dilated, fixed, tonic. Tonic means it doesn't change. It's stable like that. Normally a mid-dilated pupil, and many a times there is also a loss of accommodation. Most times there's a loss of accommodation. Okay. So it is a fixed mid-dilated pupil with loss of accommodation, usually because of a parasympathetic denervation of the pupil. Right. So what is the reason? The problem is usually in the brain, usually in the midbrain. Okay. So that is the reason why this happens. But there are certain features of Ades pupil. This Ades pupil, will it constrict for accommodation? Like if you suddenly ask the patient to read, will the pupil come down? Yes. Accommodation is intact in Ades. The pupillary constriction for accommodation is intact. Okay. Number two, so in some cases you can constrict for accommodation, not for light. Okay. What about the most important thing is the super sensitivity to cholinergic drugs. Because there is a denervation, the peripheral system has become so much sensitive to cholinergic drugs. Even an extremely dilute portions of cholinergic drugs will cause a pupillary constriction. So this test they're going to ask you. So how do you confirm that it is ADs? So you normally use pilocarpine. Pilocarpine is a cholinergic meiotic. Normally it comes in 2%. You have to dilute it 16 times. How do you dilute it 16 times? You just take 7.5 ml of water for injection in a syringe and draw 0.5 ml from your pilocar eye drops. So it becomes 8 ml, in which only 0.5 ml is pilocarpine. That means it becomes 16 times diluted. 7.5 ml plus 0.5 ml of pilocarpine in a syringe. Don't throw that syringe, keep it with you. I'll tell you why. Now put 1 drop of this in both eyes. Other eye acts as a control. Normally when you put this so dilute, it becomes 0.125%. If you know, like 2 divided by 2 is 1, divided by 0.5, divided by 0.25, divided by 2 is 0.125. If it is 16 times, okay? 0.125% of pilocarpine, which is 16 times diluted of the normally available 2% pilocarpine. If you put 1 drop, the normal eye doesn't react, it's so dilute. Here the pupil constricts. That means this super sensitivity to cholinergic drugs is a pathognomonic feature of AD's pupil. And you can use that remaining whatever you have reconstituted as a treatment. So put it in a bottle and give it to the patient, ask it put twice a day. Okay. This is AD's pupil. Normally AD's pupil, it may not be sometimes complete, maybe segmental also. When you actually take it on the slit lamp and apply bright light, certain portions of the sphincter work. So there is a segmental denervation and a segmental innervation. So this segmental denervation is classical of ADs. And what happens to ADs? Normally most of them are idiopathic. It is usually some very pinpoint lesion somewhere there. Normally demyelination, sometimes a vascular insult, sometimes we don't know what, because imaging doesn't say anything. And many of them recover over next 6 months to 1 year. But having said that, a AD's pupil always requires a neuroimaging. You may not be knowing what exactly is happening. There may be a problem in the midbrain. Always do an MRI of the midbrain for an AD's pupil. It is never assumed to be, idiopathic and doesn't require treatment. Only after neuroimaging, it can be watched and treated with these dilute pilocarpine drops. So this is for you. And somebody was asking about, what was they asking? Nystagmus. You said, no? Okay. So nystagmus is a very complicated chapter. Whenever you read it, you will not normally understand, because there is so much. Normally, all neuro-ophthalmology books complicate so much. They assume that we are neurologists or neuroanatomists. There is so much. I will probably tell you only few things. Maybe next 2 minutes, whatever I tell, that is the nystagmus you should know. That's all. Whether it's a short note, or if they ask you in the exam, or if there is a finding in the case that you are going to discuss. So what is nystagmus? Involuntary, you can write down, involuntary to and fro rhythmic movements of the eyeballs. So it has to be involuntary. It has to be rhythmic because it happens repeatedly in the same way. And it is to and fro. This can be horizontal. It can be vertical. It can be torsional. It can be mixed. You may have a multiple combinations. You can have a horizontal with torsional, multiple combinations. So all these are possible. So next important thing you should know in nystagmus is, there are 2 types of nystagmus. Normally, what is nystagmus? There is, whenever the eye sees the target, there's a drift from the target. There's a drift off the target. The eye drifts away and there is a sudden compensation or a correction for it. The drift that happens is usually slow. The correction that happens is usually fast. Okay. So most of the nystagmus, okay, can be divided based on this. Majority of nystagmus belong to a type called jerk nystagmus. People use it as jerky nystagmus. Don't use that word. There's no jerky nystagmus. It's called jerk nystagmus. So the majority are jerk nystagmus where there is a slow component and a fast component. The slow component is the actual problem. Okay, there's a drift. And the fast component is the correction from the brain. And a minority of them, both are slow. It's called pendular. Okay, so majority of them are jerk nystagmus, minority of them are pendular. By convention, we always say the direction of fast component is the direction of nystagmus. See, when you watch nystagmus, no, you don't make out anything. If you watch it, you will understand. The nystagmus is like this. You only see the fast component. There's actually a slow component happening. The fast component is very obvious. So whichever side it is beating, that is the direction of nystagmus. Imagine my right eye is like this. So what is this? This is a right beating nystagmus. That means right beating means the direction is towards the right because the fast component is towards the right. If it is like this, it's a left beating or left sided. So the direction of fast component is the direction of nystagmus. This is important. So you can say it's a right beating nystagmus, left beating nystagmus, indicating the direction. Next is one more thing is what is called as Alexander's law. What is Alexander's law? The nystagmus always increases when you look towards the direction of nystagmus. That means in a right beating nystagmus, if the eyes move towards the right, the nystagmus increases. Got it? It's already a right beating. With the patient towards right side, it starts more. You should now, with this, you should go and watch a nystagmus patient. Okay? Let's say it's already right beating. You move it like this, it starts becoming like this. Now here it's slowly. Okay, here it is slow. Okay, it's here now though. Now it starts like this because it's Alexander's law which says that nystagmus increases when you look towards the direction of the nystagmus. So most of the nystagmus follow Alexander's rule. Okay, so now comes, there are various types. Ocular nystagmus, central nystagmus, cerebellar nystagmus, vestibular nystagmus. So I think these are the four common causes. Ocular, okay, cerebellar, vestibular, and central. Okay, ocular is for usually because of eye conditions. Cerebellar, of course, you know it's a part of the cerebellar thing. Vestibular, you know already caloric test. And central, there are some CNS conditions which cause nystagmus. So these are the most common causes of nystagmus. I'm just trying to oversimplify everything. There are too many nystagmus, but I just want to say very basic about that. So then comes about what are the features, like how do you describe a nystagmus? You say whether it's jerky or pendular. So first look at the type of nystagmus. Then you tell what is the direction of nystagmus, right beating, left beating. Then you comment about the amplitude. Amplitude is the range of the drift or the saccade. Like it's, what is the excursion of the eye? That is the amplitude per to and fro motion. Sometimes they have a very small amplitude, sometimes a large amplitude. So whether the eye is moving like this, if it is moving like this, a small amplitude. The eye is moving like this, it's a large amplitude. Next, about frequency. So you just have to say large or small. You don't have to measure anything. You say it's a large amplitude nystagmus, small amplitude nystagmus. Then frequency. Is it happening very fast or happening slow? Per second, how many excursions? You don't have to measure it. You say it's a low frequency, moderate frequency, high frequency nystagmus. So always comment about amplitude, frequency. Then you can also say, how does it increase or decrease? Does it increase on looking to right or left? Follow the Alexander's rule or not? Does it increase on fixation? When your patient looks at something intently, the nystagmus increases. it gets decreased on convergence. You converge the patient. When the patient converges, the nystagmus dampens. That also leads to a squint entity called nystagmus blockage syndrome, and one of the common esotropias that you get in the acquired esotropias. Okay, so these are the things. So with this, we will come to the most common causes that you see in practice. The most common thing that you see is congenital nystagmus, also called infantile nystagmus. Both are same. So most cases that you see are congenital nystagmus. As opposed to, that means there must be an acquired nystagmus also. Okay, and the main difference between these two is, if a patient has an acquired nystagmus, everything moves for him. There's an oscillopsia. The whole world is shaking. So please write down, with underline, there is no oscillopsia in congenital nystagmus. The patient feels oscillopsia in acquired nystagmus. So congenital nystagmus is usually from birth, but usually noticed by 3 years. And it usually decreases by 8 years. Okay, that's why we don't do any surgical procedure for nystagmus before 6 to 8 years. And classical, this is jerk nystagmus. Most of the congenital nystagmus are jerk nystagmus. Then it increases on fixation, decreases on convergence, decreases in dark. You take the patient to dark, the nystagmus decreases. And normally it is very less under the closed eyelids or in sleep. And usually CNS is normal. Whatever you check, CNS is usually normal. But there are certain associations of this congenital nystagmus with some conditions. These are very important conditions. You have to rule this out before you say that everything is okay. What are the conditions? Number one, there are eye conditions. Optic nerve hypoplasia. Optic nerve hypoplasia is associated with congenital nystagmus. Achromatopsia, aniridia, Leber's congenital amaurosis. If a patient comes with nystagmus, don't say it's congenital. The patient may not be seeing at all. It may be an LCA, Leber's congenital amaurosis. It may be a hypoxic ischemic encephalopathy, maybe because of birth trauma. So these are the eye conditions and delayed visual maturation. Many children come with that. They actually recover very quickly. Delayed visual maturation. So these are some of the causes, of association with congenital. So once you rule them out only, then you think everything is okay. So neuroimaging may be required in some cases. Okay. Now comes pendular. There are 2 pendular nystagmus you remember. That's enough. One is in children, one in adult life. In children, the most common cause of pendular nystagmus, which is also a variant of congenital nystagmus, is spasmus mutans. You have heard of this? You know the spelling? Spasmus. Spasm, US. Nutans. Nutan. S. Nutans. What is spasmus mutans? It's very simple. If the patient is unmistakable in the OPD, there's a triad of spasmus mutans. Number 1, pendular nystagmus. Number 2, head bobbing or head nodding. Have you seen patients, sometimes nystagmus patients start nodding the head without any reason. It's just an involuntary nodding. And third is head posture. Okay, so this is a variant of congenital nystagmus. And I come to a very important aspect of nystagmus, which is important for us for therapy. That is what is called null point. So what is null zone or null point? It is the direction of gaze at which the nystagmus is least or absent. Usually it is there in congenital nystagmus. The direction of gaze in which the nystagmus is least or absent. So the patient assumes abnormal head posture in order to see better. Let us say if there's a nystagmus, the patient's actually the nystagmus is least in levoversion. When the patient looks to left, he sees better. So what he does is he turns the face to the right. There's a face turn to right, and he uses the levoversion in the primary case. So abnormal head posture indicate there's a null zone and the patient sees better. So this is an opportunity for you to do something surgically. Okay, what do? Let us say this same patient, when he looks to left, the nystagmus is least. What I can do is, I can bring this null point to the center. I cannot reduce the nystagmus. What I do is, I do a procedure called Kestenbaum-Anderson's procedure. Kestenbaum-Anderson's nystagmus procedure is, you shift the null point to the primary case. So how do you do that? So it's very simple. What does the brain do? Whenever the eyes move to left, brain thinks it has to reduce the nystagmus. The starting point is center. From here, we move to the left. If you change the starting point, if the eyes are towards the right, then if they move to left, they come to midline. But the brain thinks I have moved to left, it will reduce the nystagmus. So what you do is, you surgically, shift the eyes to the opposite side of the null zone. The null zone is towards the left. You move the eyes to the right. What you do is, left eye, you recess lateral rectus, resect medial rectus. This eye has turned to left, right. This eye, you recess MR, resect LR. So the eyes have been, moved to the right by your extraocular muscle surgery. So when the eyes take the midline, the brain thinks that we have moved to left, nystagmus will come down. So by simple shifting the eyes to the opposite side of the null zone, you can reduce the nystagmus in the primary case and take care of the head posture. So this is a procedure for congenital nystagmus with a null zone. Okay. What about pendular nystagmus? Pendular nystagmus, there is no null zone. Eyes moving to and fro in the same speed. What can you do? Pendular nystagmus, what you can do is you can actually weaken the muscles so much so that it won't move the eyes, because it's basically done by the muscles. What you do is you shift lateral rectus and medial rectus both towards the equator. You do a recession of LR and MR in the same eye, both sides. That means you weaken MR, you weaken LR. The contractility is so low that it can't shift the eye to this side. Your version movements are affected, but eye is more stable. The pendular nystagmus does not happen. So by shifting the muscles and stitching them at the equator, you weaken them so much that the nystagmus dampens in case of pendular nystagmus. So this is the surgery for pendular nystagmus. So I told you, in pendular, the most common congenital variety is spasmus nutans. But if an adult gets pendular nystagmus, be careful. You may be dealing with a case of multiple sclerosis, demyelination. That's a very common thing. So some special nystagmus. You should know this, some special nystagmus. Okay. Have you heard of convergence retraction nystagmus? What happened? What is this convergence retraction nystagmus? In which condition you get convergence retraction nystagmus? Huh? Perinod syndrome. Yes, dorsal midbrain syndrome. So in dorsal midbrain syndrome, what are the points in dorsal midbrain syndrome? There is a vertical gaze palsy. There is a vertical gaze palsy. Eye cannot move up. Number two, in an attempt to move the eye up, the eye converges as well as there is a retraction of the globe. Why it happens? Because simple. Vertical gaze nahi ho raha hai. So both MR and LR contracts together. When you are trying to elevate the eye in a dorsal midbrain syndrome, the vertical gaze is not happening because there's a vertical gaze palsy. Both MR and LR contracts together. Between the two, what is stronger? MR is stronger. So the eye goes into convergence. And also, when both are being pulled, eye is retracted back into orbit. So it's a nystagmus where the eye moves in and goes back. You just see it. If you see a case, you will not forget it. Okay, once you see it. In an attempted up gaze, the eye is doing like this. It is retracting and also converging. So it is a convergence retraction nystagmus in dorsal midbrain. There are other signs in dorsal midbrain is Collier's sign, that is lid retraction. There is a light near dissociation. What is light near dissociation? Huh? You heard of Argyll-Robertson pupil? That is, the light reflex is not there, but the accommodation reflex is there. The pupil responds to accommodation, but not to light. Why does that happen? Huh?
Ventrally located for accommodation in the midbrain.
No, it's all same trunk, no? See, basically, it has a reason. And it's not happen so commonly. Once somebody sees and puts it in the book, it becomes a gospel. It doesn't happen so commonly. It happens for one reason. Have you ever thought of it? Why only accommodation reflex is preserved, light reflex is not there? It's only because if you see the number of axons, the parasympathetic fibers reaching the eye, okay, the fibers reaching the pupillary sphincter is 1/10 of the fibers reaching the ciliary muscle. You understand? That means the pupillomotor fibers, or let's say 10, the fibers going to the ciliary body are 100. That means when there is a damage to these structures, it is likely that the accommodation fibers are preserved more than the pupillomotor fibers. Just that. So you will have few still fibers going to ciliary muscle preserved. So accommodation is still possible. That is the reason why in neurosyphilis also, you have Argyll-Robertson pupil. We don't see it anymore now. So that could be the reason. It's only because of the discrepancy in the number of fibers which are innervating the ciliary body versus the pupillary sphincter. Otherwise, there's no selectivity. The fibers are not separate that you can cut this only. No. Okay. So that is dorsal midbrain syndrome. That is special. The other nystagmus that you have seen is the abduction nystagmus in INO. So you have internuclear ophthalmoplegia where there is a adduction restriction. There is a loss of adduction and abduction on the contralateral side. In an attempted abduction, there is a nystagmus. So this is INO. Okay, and this is a very commonly again asked. I don't know, it's a favorite of examiners, both for theory and practicals. So for that, you should know a little bit about the supranuclear control. I told you that day the frontal area, Brodmann's number area number 8, controls the horizontal movements, horizontal gaze movements. The right side controls the movement to the left. Okay, so if there's a frontal area damage, the eyes will move to this side. There's a conjugate fixation towards that. That means they see towards the site of lesion. So this is what happens. So they come down and the center, there are center at the cortex, there is one center at the brainstem, and then the brainstem center connects to the cranial nerve nuclei. It's a 3-tier system. Okay. So you should probably, when you go give a theory question, you write that brain, this, they will come to know what you are doing. So brain, cortical control, there's a brainstem centers are there. Brainstem centers will either further innervate the cranial nerve nuclei, because that is the final common pathway for everything, voluntary and involuntary movements. Right. So horizontal from area number 8, it comes down. The brainstem center is in pons. It's called parapontine reticular formation, PPRF. So that is the brainstem center for horizontal movements. Right. So from there, so what happens is when you want to move the eye to right or left, the lateral rectus of this eye has to be connected to the medial rectus of the other eye and vice versa. So there is a connection between the medial rectus subnucleus of one side to the lateral rectus nucleus of the contralateral side. So this connection is called as medial longitudinal fasciculus. So there are two, right and left. And by convention, the medial longitudinal fasciculus is named as per the medial rectus subnucleus. That means, let us say this is connecting the medial rectus subnucleus of the right side to the left lateral rectus nucleus. Then we call it as a right MLF. Okay. And this is left MLF. So if there's a damage to MLF, then what happens? The ipsilateral medial rectus will not work. There is a adduction deficiency. And the other eye, when it is abducting, will go for a nystagmus. So this we call as the INO of the same side. That means if I say right INO, you should think that right eye is not adducting. And left eye is showing nystagmus in abduction. So that is a convention. Right INO, left INO is left eye medial rectus is not working. So please understand, in a patient, he comes with an isolated MR weakness. Don't think of third now. Think of INO. There is nothing like a situation of third now where only MR is weak. It cannot happen. It has to be INO. And INO is also very common. Because it comes and goes, recovers, most of the people will not even know. But the patient complains of diplopia. There is a diplopia. When you have an INO, patient will have diplopia. Okay. So this is the situation. Right INO, left INO. Now if there's an INO on both sides, the medial longitudinal fasciculus is damaged on both sides. And what will happen? Both medial rectus cannot. The eyes tend to take a position, one on this side, the other on this side, looking at the walls on the either side. It's called as wall-eyed bilateral INO called Webino. Okay, not a very common thing. Now, the PPRF is also in the brainstem. MLF is also going through that. So the lesions can involve both. If PPRF, what it does, see right side PPRF, okay, moves the eyes to the same side. Okay. So what happens is, if there's a right side lesion causing damage to right medial longitudinal fasciculus as well as right PPRF, the eyes cannot move to right. At the same time, because of MLF involvement, it also can't abduct. So can't adduct. So the only movement that is possible is the contralateral abduction. That means in case of combined lesions, this eye, both abduction and adduction is not possible. This eye, adduction is not possible. The only movement is the other eye abduction. This is called 1.5 syndrome. Okay. So 1.5 syndrome is the involvement of MLF and PPRF on the same side. So what is 8.5 syndrome? Because it's in brainstem, if the seventh nerve is also involved, we call it as 8.5. See, these are all basically jargon. You need to know because it may be asked in the exam. Okay, so this is the most common things that are asked. So INO is quite common. When you have a patient who is coming with INO, what will you do? So you will basically check, it's only MR, he has got diplopia, okay, other eye has got nystagmus. Then what we do is, we basically screen for the brainstem lesion. Many a times, 90% of INO is only because of a vascular insult or a demyelination. Okay, and rarely a tumor. But usually it is because of a demyelination and vascular insult, and most of them will recover. Most of them INOs will recover spontaneously after some time. Okay, so but at the same time, once you have an INO, better do a screening. Neerin bottle tandu. And now something about the short cases that will be kept. That is the lid malpositions. Okay, you have heard of lid malpositions, lower lid and upper lid malposition, which is nothing but ectropions and entropions. So these are common cases in the OPD. So you can actually get them as a short case. If no case is available, they will keep it. And it's a usually, if it is available, that is a standard thing because there is so much of discussion that can happen. Okay. So let us think what will be the most common case in the OPD that you can probably encounter in the exam. So that is usually a lower lid ectropion and lower lid entropion. These are two common things, usually because of senility. Okay. So once you have a lower lid entropion or a lower lid ectropion in an old man, the discussion will be on what is the pathogenesis. Okay. What will be the pathogenesis? What will be the test that you do on this particular patient? And how do you manage that? Okay. So first let us take lower lid entropion. See, if both for entropion and ectropion in senility, there are some common pathogenesis mechanism. What are the common pathogenesis mechanism? Number one is horizontal lid laxity. That is because of the age, there is a slackening of the both medial and lateral canthal ligaments. There is an expansion of the tarsal plate. There is a laxity of the skin and orbicularis. So there is a horizontal increase in the laxity. So there is a horizontal lid laxity. So that makes the lid to go in or out. Number two is vertical lid laxity. If you understand something analogous to the levator aponeurosis of the upper lid, you have what is called lower lid retractors. From the fascia covering the inferior rectus, a sheet comes forward. It is called capsulopalpebral head, which comes and attaches to the lower border of the inferior tarsus. So whenever the pull of inferior rectus, it is transferred to the lower tarsus. So the inferior tarsus always is erect, is held vertically erect because of this lower retractors. That means that is called, if this is lost, the vertical laxity happens. The lid can go up, can become vertically lax. So this is called vertical lid laxity because of improper action of lower lid retractors. The third thing is, so horizontal lid laxity, third vertical lid laxity. The third thing is what is called overriding of preseptal over pretarsal orbicularis. So normally you have two muscle, orbicularis is circular. So there's an overriding. Whenever the patient is squeezing the eye, the muscle orbicularis strip, which is in front of the orbital septum, which is lower down actually. So then it kind of overrides on the orbicularis, which is in front of the tarsal plate. So preseptal overrides on pretarsal, pushing the lid inwards. So there's an interning of the lid margin. Okay. So this is the cause. So if you have horizontal and vertical lid laxity, the stage is set for either entropion or ectropion. If there is a overriding, then the lid goes in. If there is no overriding, the lid falls off. It becomes an ectropion. So these two are common to both situations. Okay. I think I'll give you a 2 minutes break. Everybody can eat. Nanago antan kodama. Okay, we got some energy to talk as well as to listen now. So understand horizontal lid laxity, vertical laxity is a common factor for both entropion and ectropion. If there's an overriding of the preceptal over pretarsal, it goes inside. Otherwise, it falls off. So that means when you are seeing these patients, you have to demonstrate all three of these. So how do you demonstrate horizontal lid laxity? You call it as a pinch test. Pinching is you try to pinch. So just to get what is the excess amount of horizontal lid skin that is available? Like you just pinch the full thickness lid. So pinching is basically showing what is the excess lid available. Distraction test is you hold it, pull it away from the eye and leave it. The speed with which it recoils back, that shows the elasticity of the tarsal skeleton. You do it in a young patient, it immediately goes back. You'll not be able to pinch also, that's a different issue. But if you distract and leave it, it immediately snaps back. It's also called snapback test. So pinch test, snapback test or distraction test, these are basically done to demonstrate. So what about vertical lid laxity? How do you demonstrate that the lower lid retractors have actually snapped? What is the, can anybody tell me how you can probably demonstrate it? Logical. So this is horizontal. Vertical? Huh? Okay, so I told you there is a capsulopalpebral head coming from the inferior rectus joining the lower border of the tarsus. So whenever the eye moves down, it pulls the lower lid downwards. This is normal. Because why it happens? Because if it doesn't happen, the lower lid will block the pupillary axis. Okay, it's a physiological thing. Whenever there's a snapping of the inferior retractors, when the patient looks down, the lower lid does not move down, okay, maintaining the same. Normally, the lower lid is at the lower limbus always. In primary gaze, always, also in down gaze. If you see that there is a overriding of the lower lid beyond the limbus in extreme down gaze, indicating that it is actually not being pulled by the lower lid retractors. If you look at if you pull the lower lid and look at the conjunctival surface near the fornices, you can actually see one bright white cord-like structure, which is the detached portion of the lower lid retractors in some patients. Okay. So you can actually see that on slit lamp or torch light, one white line thing, which is probably a detached thing from the lower lid tarsus. Okay, so this will demonstrate the snapping of the lower lid retractors. Okay, so now how do you manage a lower lid entropion? Lower lid entropion is dangerous because the interning causes corneal rubbing, corneal SPK, symptoms, watering, sometimes it can even lead to corneal infections. Okay, so cornea patient is not only very symptomatic, it can also lead to corneal problems. Sometimes it is so severe that we have to actually do a taping till we do the surgery, right? And taping is one of the temporizing measures that we do even today. So why does this taping is required? Because there is what is called as a spastic component. Whenever the orbicularis contract, there's an overriding. So the lower lid goes and touches the cornea. So that causes again irritation, the patient squeezes further. So again the orbicularis contracts. So there's a vicious cycle setup. Till you kind of take it off the cornea, so this is keep on happening. So that's why there's also called as a spastic entropion. Many of the patients. So how do you demonstrate the third part? Once we told about horizontal lid laxity by snapback test, pinch test and things like that. The second one is by the lower lid in down gaze is actually overriding the limbus. What about the overriding? How do you demonstrate? You actually see a bulge. When the patient squeezes the eye, you see a bulge in front of the so-called the orbital septum. So just first 3 to 4 millimeters of the lid is tarsus, and below that there's actually a bulge. That is because of the overriding. In those patients, you will be able to see that bulge. So whenever the next patient that you see, look for all this. And when you get in the examination, you have to mention this. Otherwise, there's nothing in the case. There is, don't do anything else, and always comment about the cornea. Try to stay in the cornea. Look for any SPK or any corneal damage, any aberrations. Okay. So now management of this. For some time, in a spastic case, you can probably put a tape and pull it away from the thing, but you need to do a surgical procedure. So now you are all nearing your exams. You must have probably gone through this. So I want you to answer this. I will not tell the answer. I want you to tell the answer. How do you manage a senile lower lid entropion? I want answers from you. Averting sutures? No. I mean, that's not the first answer. No, this is so common. You will get a next patient in practice. Late ಆಯ್ತು. ರಾತ್ರಿ ಕರ್ಕೊಂಡು ಹೋಗಿ ಬಿಟ್ಬಿಡಿ. Come on, tell me. No, you're all taking exams. I've been answering all through, but now you should tell me. No, because I'm not really, it's not rocket science. The next patient that you see will be a low-grade entropion, and if you don't treat him well, he will not come to you for cataract. If you do it well, he will get the entire mohalla for cataract surgery. Yesterday I was telling you, know, cataract is so important. It is not important to learn a cataract surgery alone. The patient directly will not dance into the OT table. First, he will come to your OPD. You have to impress him in the OPD. That patient, the way you talk, the way you explain, where you make him comfortable, where you create a confidence in him, then only he will come to the OT. Correct? So if you have managed an entropion of his friend, and he will be confident, ye bahut achhe doctor hai. He will not understand that you are a cataract surgeon, not an oculoplasty surgeon. He thinks everything is same. If you don't even give a good glasses, for that matter, why refraction is important is, refraction is so difficult. In a complex refraction, it's so difficult to make the patient happy. So when you give glasses, it is not working. He has spent 10,000. He'll say, "Isko chashma dena bhi nahi aata hai." So surgery kya karega? He doesn't know that you are an expert phacosurgeon, but zero refraction. Patient ideas are different. Patient thinks, if you are good in everything. So you will have to manage this entropion, and it is so simple. See, please understand, oculoplasty, okay, hope nobody is listening, is not a specialty. It's a comprehensive ophthalmology. It is common sense. It is brave heart. It is some minimum common sense with some minimum skills and lots of imagination. If you know your anatomy well, if you are, have some basic skills, you can actually do a fair good of, because most of the oculoplasty surgeons are very forgiving. An expert does it or a novice does it, the difference is not very different. Unlike cataract or a refractive surgery, it can, like you do a cataract surgery, you drop the nucleus, then you can never be the same. It can never be the same. But an oculoplasty, here and there, 19-20 chalega. It has got a very large margin for error and more forgiving. So in that case, you should know, and if you can see one correctly, you can do one correctly, you can teach one also. So please do not demean oculoplasty surgery. The way by which you are not knowing how to do a surgery is actually a disrespecting that particular specialty. Either you think it is too less for you people, you're all great people who does not do lid surgeries, or you think it is too big for you to reach. What is correct? Either you are too big or oculoplasty is too big. Tell me why not even one of you is having a clear about how to solve this problem of a gentleman. He's writhing in discomfort. Every time he squeezes, he's having pins and needles in the eye. And you don't want to take care of this man for compassionate reasons. So tell me, what will you do? Huh? Transfers? Arey, man, you are all Neanderthal science. This is from my Stone Age. Arey, I told you, simple, man. Come on, you're all surgeons. You should be aggressive. You should be imaginative. What? Epilation. Enucleation. Both are same. This is not a trichiasis or dystrichiasis. This is a lid is turning in and touching the cornea. If you epilate also, the lid will turn, no. And the eyelashes will come back again. Huh? Huh? Botulinum toxin is a temporizing thing. We give it for kids. Sometimes we give it for kids with this spastic entropion, just because they cannot, they keep on doing this. So we give it this and we manage that. No. Okay, let's get started. What were the problems? You solved the problem, right? What was the foundation on which this melody was created? Horizontal lid laxity, vertical lid laxity, overriding. Arey yaar, can you manage to get that whiteboard? वो नीचे है ना, with thing, इसको लगा देंगे इधर. Come on, Abhishek. Abhishek. So, horizontal lid laxity. I just need to chop off some lid and reconnect it. I need to reduce the horizontal extent of the lid. I can right away do it in the center, or I can do it in the extreme periphery or the lateral canthus. If I do it in the center, it is called as a pentagon excision. Why it is a pentagon? Why not a square or a rectangle? This is elementary, okay? You need to answer this. This is elementary. How much margin I can give? Why it is a pentagon excision? Why not a square or a rectangle? Huh? Pardon? Arey. Okay, let the board come. Okay. So you reduce the lid size. Number two, you will have to reconnect, okay, the torn lower lid retractors. You need to open up and go explore the lower lid retractors, get them back, reattach to the tarsus. Okay, reattachment of the lower lid retractors to the lower tarsus will make the lower lid erect. Number three is the overriding. What you do is you just make an incision 4 millimeters below the lid margin, lower lid margin, which is the junction of pretarsal and preseptal. Just this scar itself is enough to prevent this thing. Or else, if you really want to do that, what you can create a strip of orbicularis, cut them in the center, approximate them and suture them, what we call as Wheeler's procedure, to support the lower border of the lower tarsus. Okay, so what we do in this case is the lower lid retractors are dealt by what is called Jones procedure. It is the simplest procedure, Jones procedure, and the lid laxity horizontally taken either by a vertical, by a pentagon excision, or by the most important evergreen procedure every ophthalmologist should know how to do is lateral tarsal strip. It is as elementary as cataract surgery for you. If you do not know how to do an LTS, then you are not an ophthalmologist. It is such a versatile procedure, so simple and so elegant, and solves many problems in one stroke. So you should know how to do a lateral tarsal strip, because It is the same surgery for many things. Okay. So horizontal lid laxity, I told you, if you do a pentagon excision, so I'll keep it at that. I think once it board comes, I will explain. Similarly, we just go back to ectropion. Ectropion is again horizontal lid laxity is there, vertical lid laxity. The whole lower lid is flabby and it falls off from the globe, taking the punctum also away. So the punctal disconnection, okay, puncta not opposed to the globe, can be a generalized part of the lid going away, or it may be exclusive the medial part. Sometimes there'll be the medial part is much more everted than the rest. What we call as a punctal ectropion or a medial ectropion. So ectropion of the lower lid in a way is less symptomatic. The patient has only watering because the puncta is off the globe. The lid is off, so all the ocular surface is unnecessarily exposed for desiccation. So the lower part of the conjunctiva below the limbus, as well as the lower fornix, is exposed. So there's an evaporation. There is an abnormal tear resurfacing. So it's more of a surface problem. There is no corneal damage as such. Patient has a lot of watering and irritation. In extreme cases, there will be some keratinization of the conjunctiva also. So this patient can also be because of a post-facial palsy. Okay, the post-facial palsy, because the orbicular is not working, the lid is off. So it can be a paralytic ectropion of the lower lid, or it can be just a senile ectropion because of all these senility changes, or it can be that the anterior lamina has got a contracture. There is a scar on the skin. Either there's a burn or there is some infection or some kind of an injury or some bad suturing, which has shortened the anterior lamina, so the lid has gone off the globe. So to understand all lid surgeries, there are some basic anatomy you need to understand. The lid, let's say lower lid, has two functional units. Okay. Many of the lid surgeries basically work on these two functional units. One is, it's like two slices of bread put together. There's a potential space always between them. One is the skin orbicularis. The other is the tarsoconjunctival lamina. So skin orbicularis lamina, tarsoconjunctival lamina. You can split them between the two. And the boundary line at the lid margin is called the gray line. So that is the sarhad, that is the boundary. So at the gray line, these two join. And if you split the lid, they become two functional units. So if you want to reconstruct the lid, okay, you can construct them in these two components. You don't have to bring the entire thing. You can reconstruct the anterior lamina separately, posterior lamina separately. One can be a free flap, one can be a pedicle graft. So remember this. This is important for most of the lid reconstructions. Okay? So this is for vaccine. Anybody wants vaccine? Okay. So we come back to, let us say this is the lower lid. This is the eye, okay. If you know, this is the medial canthal ligament, lateral canthal ligament, and this is the tarsus. Right. So this is the lower lid retractors have got disconnected from the lower border. So I need to reduce the horizontal lid laxity. So what I have to do is I can cut the lid and rejoin them. And just like cataract, you should know always how to do a anastomosis of the lid margin, how to suture the lid margin end to end. Okay. Once you cut the lid, the two margins, how do you reconstruct the lid? You should know that. So if let us say, see, this is a hard portion. What if I take a cut like this and join? You want to shorten, right? So I will cut this and join. Why it should be a pentagon, why not a triangle? You should understand that this tarsus is like a cardboard. If you cut the cardboard in a horizontal, try to join them, there will be a buckling effect. No, it will buckle. Okay, it is not just like skin. It cannot be tampered like that. Once you cut, it's a hard structure. So when you want to suture it, it will create a deformity like this. So when you cut the lid, the thing has to be always vertical cut till the entire length of the tarsus. Then only you can bring them together and suture these two ends. You can't take a vertical lid cut like this and join them. It has to be straight. Then you can bring them together. Then there's no buckling. Right? So once you do that, you have to join them like this only. There's no other way. So always all lid full thickness excisions are, whether it is for a tumor, whether it is for a horizontal lid resection, it is always a pentagon. Okay. So how to take care of horizontal lid resection? Just cut a pentagon, join them. Lid margin. So if you see that, if this is the two lid margins, we are looking at these two. This is the gray line. This is the lash line. These are the meibomian openings. Okay, this has to be extremely sharp. Because if there's a notch, here, after you do it, when the lid closes, this notch will create a small area where the tear resurfacing does not happen. All the time, this area of the cornea will not be wet. You will have a Dellen formation. You will have a thinning of the cornea. You will have a perforation. So just leaving a notch in the lid margin can result in a corneal perforation. So no notching. Okay, that's why they should be sharp. So you always take, the simple thing is to take 3 sutures. One at the first gray line, one at the meibomian gland opening, one at the lash line. Okay. Or else you can take what is called as a vertical or a horizontal mattress. You enter here, come out here, enter here, come out here, join them. Or else if the lid is like this, you enter near, go out, come back, then suture. So these are the ways by which you basically do a pentagon excision. But what is the problem of pentagon excision? If you do a pentagon excision, the punctum here will be pulled laterally. So punctal will get distracted. The patient's watering will further increase. So by doing this, your puncta is distracted out. So I want to do a procedure where puncta is there only and puncta should be pushed backwards. Puncta should not be distracted. So that is where the beauty of LTS comes. Lateral tarsal strip. Okay. In lateral tarsal strip, what we do, this is a tarsus. This is the extra lid, let's say. We're not doing a pentagon. I make a cut here. Okay. I do a canthotomy first. Then I cut the lower crest called cantholysis. Then this tarsal plate is there, no? I will remove this orbicularis. I'll remove the skin from the lid margin. I'll remove the skin from the front. This will go, this will go, this will go. So what is left? Just a strand of the terminal portion of the lower lid tarsus, which is like a strip. So this is the tarsal strip. Then what I do is I open up the things here. There is a orbital, periorbita here, the lateral orbital margin. I take non-absorbable sutures, suture this to the periorbita. I take it higher up and attach it here. Then what happened? The shortening is happening at the lateral canthus. So there are no suture lines in the middle. Cosmetically fine. Then I am suturing it at much more at the backward plane. So the whole lid is being pushed backwards with a nice opposition. The puncta is not getting distracted. In fact, puncta is getting reopposed properly into the thing. So cosmetically fine, And also it is giving a wrapping effect. So this itself will take care of the horizontal. So here basically we are doing it to take care of the horizontal lid laxity. But for a vertical lid laxity, I take an incision at 4 millimeters from here. Okay, the orbicularis here is pre-tarsal, this is pre-septal. And expose this, then I find the lower lid retractors. I'll not go into the surgical details, it's very simple. So I see them and either I plicate them and attach it here or directly attach it here. If I plicate, it's already very thin, I plicate it, okay, and reattach it to the tarsus. How do you know that this is lower lid retractors? You can hold them. Anyway, given only lower lid anesthesia, ask the patient to look down. You will feel the tug. When the patient looks down, it retracts. So you can attach it here. Once you attach it here, and this suture you put, this scar itself is enough to prevent the overriding of the preseptal over pretarsal. So for lower lid senile entropion, what you do is lateral tarsal strip plus Jones procedure. So if somebody asks you, how do you do? So I'll do a lateral tarsal strip for horizontal lid laxity and a Jones procedure for vertical lid laxity and to prevent the overriding of preseptal over pretarsal. Okay. This is all that you need to do for entropion. Now comes the next thing, ectropion. I told you the ectropion is of 3 types. Senile, same underlying factors. Cicatricial, if there's an anterior lamina, I told you anterior and posterior lamina, if there's an anterior lamina shortening, then the lid will go out. So you need to do a skin grafting. This area of the face, you can get a free graft. It is always in the lid, partial thickness or split thickness skin graft, never full thickness. From the back, from on the mastoid, you can take behind the retroauricular area or at the medial side of the upper arm. You can take the split thickness skin graft. And it takes really well. It happens well. So now, what about lower lid ectropion inside? And what about the paralytic one or the senile one? We operate the same time. So let's say this is the lower lid. And this is a tarsus which has fallen off. And the puncta is also off the globe. So the procedure that you do is exactly same. Lateral tarsal strip. The lateral tarsal strip shortens the horizontal lid laxity. It also brings the lid back to position. The lid has gone off. So when you attach it more posteriorly to the periorbita, the strip, it actually puts the lid back in the place without distracting the punctum. Okay. So this is one procedure. So lateral tarsal strip. If there is also a vertical lid laxity, you can also add a Jones to this. So LTS plus Jones also works for ectropion of lower lid. This is number 1. Number 2 is if there is a excessive medial ectropion, punctal ectropion, you can do another procedure. The other procedure is called as lazy T procedure. So what is lazy T? What we do is this punctum, okay, is gone off the globe. I need to re-invert the punctum back onto the ocular surface. It has come off. So what I do is I go in onto the inside of the punctum. Let us say if I have pulled the lower lid out to expose the palpebral side. Let us say this is the palpebral side. This is the punctum. So I create a diamond. So around 6 to 8 millimeters behind, I create a diamond, cut this tarsus and suture this. So what happens? This shortening of the diamond will cause an inversion of the punctum towards the internal side. So that the punctum again is back to the inverted position. Otherwise the puncta is off. So you just turn the punctum in. So at the same time, you also do a pentagon excision just next to it on the medial side of the lid. You wanted to reduce the horizontal aperture, no? Size. So once you do that, once you suture this, what will happen? This diamond will be sutured like this. And once you do this retraction, it will be sutured like this. So what it is? It's a sleeping T, lazy T. Okay, so that is the name. So lazy T is nothing but this diamond excision, what we call as conjunctivoplasty. Okay, doing that is called conjunctivoplasty. And this is a horizontal lid resection with a pentagon excision. With this, we result in a scar that's in the form of a reclining T. So it's called a lazy T procedure. So lazy T procedure is another one for lower lid ectropion. But this classic surgery is still waiting. First one I told you is LTS. The second one is lazy T. So the third one, I don't want to write here because I don't know the spelling. Always write the short form. What is this? Huh? If you would say, you have to tell the spelling. So Kuhn-Zawinowski. Kuhn-Zawinowski procedure is really elegant procedure. Okay. So how do you do a Kuhn-Zawinowski procedure? I think you need to see it once. All this. So this is lower lid. Okay. This is medial side. This is lateral side. So what we do is, you say modified Kuhn-Zawinowski. The real Kuhn-Zawinowski is different. This is the lower lid lashes. Let's say just below the lashes, I take an incision and go temporally like this. And separate the two lamina of the lid, tarsoconjunctival and skin orbicularis. I separate it at the, I don't start at the, I can take it at the gray line and do it also. The original Kuhn-Zawinowski took it at the gray line. But the modified Kuhn-Zawinowski, we take just below the lower lid lashes and separate the two layers and dissect all these here. Let us say I have dissected up to here and I have inverted this. Just imagine along this axis, I have inverted the skin orbicularis. So what I'm seeing here is the tarsoconjunctival. So I do a pentagon here. After removing the anterior lamina on a hinge, I do a pentagon here, shorten the lid. Because full thickness, there's a scar. Okay. So if I take the anterior lamina, cut the only tarsal plate, when I put back the skin, there is no scar. So I have shortened the one lamina, but the other lamina still lacks, no? So what I do is I put it back. I had dissected up to here. I make a cut like this and pull this anterior lamina. Now I have put this back. I put the skin back. I pull it towards this direction. Like a wrapping the lower lid. So that it will go till here because it is lax. And I cut this portion, suture it back here. So what I have done, I have shortened the lid. But the two segments are separately shortened. The posterior lamina was shortened separately. The anterior lamina was dissected up to the temporal side and pulled so that there's a wrapping effect and the excess skin was removed here and it was sutured back. So what happens is, because you have wrapped it, it pushes the lid backwards. And the posterior lamina is already short. So both are shortened with a backward direction. If you just do a horizontal lid dissection, it won't happen. Only this can produce a backward vector to put the lid back onto the globe. So this is an elegant procedure of modified Kuhn-Zawinowski. So if you have entropion, just tell people about Jones plus LTS. If you have ectropion, you can say modified Kuhn-Zawinowski. You can do Jones plus LTS. You can also do lazy T. Okay. See, these are all names. Okay. But any procedure, okay, that is okay, you can do it. And all of them are really easy. You have to believe me. It's so easy. If you just do one, you will understand how to do it. I told you it definitely it's going to be the situation is much better than what the patient started with. Okay, there cannot be any kind of variations in the result because it is so mathematical, so simple to understand. So you need to understand the lid anatomy, and you don't need any special equipment, no cost involved, no machines involved, no some great sutures, simple sutures with just one strip of vicryl suture, you can finish off this surgery. Okay, so remember this for a lifetime. Whatever specialty that you practice in future, you should be knowing all this. You should know how to do a tarsorrhaphy. It may be saving light, maybe sight saving. Like if the patient comes with extreme degree of thyroid exophthalmos, okay, patient comes with a very bad lagophthalmos with already corneal exposure, you should be able to do a tarsorrhaphy, if not permanent, even a temporary tarsorrhaphy. How do you do a tarsorrhaphy, permanent tarsorrhaphy? So you always remove a strip from the lid margin without damaging the posterior sharp border. Okay, you remove the strip, both exactly on the same, okay, the upper and lower lid complementary you should remove. Then you should pass sutures with the raw area coming in contact over a bolster. Okay, pass a bolster that won't cut through the skin. We use 80 watt buttons as bolsters. So hold it for 3 weeks. They will join. The skin grows from one to another. So there is a skin tag connecting the lid margins. Then you can remove the suture. Why we can't put a suture? Because the suture will be always, if you put a non-absorbable suture, whenever the patient try to open the eye, there is a pain. Here there is a biological skin, adhesion. Like you have created a symblepharon, okay, for a desirable cause. So you have created a symblepharon. So you create a skin tag will go between one to another, and that will cause a permanent tarsorrhaphy, so that you can leave it like that. You can do temporary, just without making a raw edges, you can just pass a suture for some time. You can even put a glue and join them. Okay, these are the temporary tarsorrhaphies, but you should know how to do a permanent tarsorrhaphy. Okay, it's already time. So maybe in next 5 minutes, now you tell me what you want to know. Anything, whatever in ophthalmology that you have any doubt, because tomorrow we only have a half a day. We already some plans for it. So I think the last 5 minutes, anything you want to ask? Anything in oculoplasty? Anything in ptosis? Anything in orbit? Anything in glaucoma? Oh, I see. You're all brimming with knowledge. No questions. No questions can only in 2 occasions.
If we get a note on eccentric fixation, what should we write?
What is eccentric fixation? A very eccentric question actually, because what is eccentric fixation is the non-foveal point acts like fovea even under monocular conditions. You are going to make sense out of this? The non-foveal point acts like fovea under binocular condition, it could be an ARC. Okay, but when you close the other eye, still the non-foveal point continues to be the fovea. Okay, this is eccentric fixation. That means it is because of a neurological rewiring. For some reason, let us say a patient had a squint, a small exotropia or esotropia. So this image was basically forming on that. So what happened was there was that area, that portion started working like fovea. So even on closing this eye, that area is the supreme. See, fovea is supreme and everything works around it. The rewiring is around the fovea. So here the non-foveal point is acting like fovea even under monocular conditions is eccentric fixation. There's a very big difference between one more entity called eccentric viewing. What is eccentric viewing? Eccentric fixation is basically because of a squint from a very early childhood, not treated. Okay, eccentric viewing can happen in any time of your life. And typically you find them with children coming with Stargardts, adults coming with a bad disciform scar in the macula because of an AMD, wet AMD. See, whenever the fovea gets damaged, the patient wants to see with a point with the highest visual acuity. You know, fovea is 6.6. Next to the fovea is 6.12. Next to that little away is 6.18. Next to that is 6.60. So the vision drops quickly when you move away from fovea. How do you know that? Very simple. You put two Snellen's charts. Close your eye. You try to see with one eye 6.6. At the same time, without moving the eye, try to figure out what is in the other chart. You can't even read 660. That means your extrafoveal point is looking at the chart. It can't even read 660. So you go close, and when you read 660, or when you probably bring the chart closer to this chart, you will be able to read 660. That means the vision drops drastically when you move away from fovea. So a person who has got an acquired macular problem, foveal problem, would like to use a point as close to fovea as he can so that he has the highest visual acuity. So what he does, he intentionally moves the eye out or in to reach that point as in the line of sight. It is not a squint. It is not because of rewiring of the neuronal system. It is an intentional effort by the patient to see better with whatever available retina he has. So these children with Stargardt's come, they have a macular already a scar or a lesion. They look at you, but you think that they're looking somewhere here. Because the eyes are slightly deviated out or in, okay? There is no eye-to-eye contact. They're looking at you, but you think that they're looking elsewhere. That is eccentric viewing, but they are trying to look at you because they're that the available closest to non-foveal point is looking at you. The fovea is somewhere else because it's not working. So eccentric viewing and eccentric fixation are two different things. Okay. So see, there is a lot more in strabismology, but I want this is not the forum to discuss complexities. I can talk about Horopter, I can talk about Panham's area, I can talk about Donner's law, Listing's law. Not important. Now, calm kichis. What you require for exam, let us discuss. Okay. Anything else? Don't be hesitant to ask a question.
Sir, I have one doubt regarding LASIK, sir. Like yesterday, ma'am told for myopia, we need to ablate 15 microns of the cornea. For 15 microns reduces one diopters in myopia, sir. And 18 microns reduces one diopters in astigmatism. Why there is so difference? Like anyways, we are removing the cornea only, no, sir. Why we have to? Anyways, we are ablating the cornea only, sir. Why there is difference for like for myopia, we have to remove 15 microns, and for correction of astigmatism, we have to remove 18 microns for each diopter. Anyways, yes, sir.
No, I think, let me clarify that. See, I think refractive surgery is a very enticing subject. You know, I think you should all, I always appeal to you that please get interested in refractive surgery. It's a real, very interesting subject and the need of the hour. The less you know, more an disadvantage. So I told you, like, how do you say whether a patient is eligible for LASIK or not? I told you the calculations, mathematics. So if the patient has got a 500 microns, okay, pachymetry, we take if you're doing a LASIK, 130 micron flap, so 370 is remaining. We have to at least keep 300 microns. In some extreme cases, maybe 275, not lesser than that. So that means if we keep 300, only we have around 70 microns for ablation. Right? I'm talking about the worst case scenario. Now, every mission ablates a particular amount of corneal stroma per diopter of correction for a given optic zone. Normally, we keep 6.3 millimeters as the optic zone. So for a 6.3 millimeter optic zone, some machines, good machines, ablate around 12 microns. Okay machines ablate around 15 to 16 microns. Some bad machines, old machines will ablate 20 microns. So it is not same for all machines. But let us keep for convenience sake 15 microns per diopter. So if you have 70 microns at your disposal, max you can probably remove these 4.5 diopters. If a patient has 10 diopters of myopia, you cannot do a LASIK with that 130 micron flap. There'll be a huge undercorrection. Okay. So why that much is required? Because you are sculpting the cornea, making it flatter. For a cylinder, you are creating a toricity, reverse toricity. See, all hypermetropes, how do you correct hypermetropia? Okay, there's a thing here, I will show. Nothing like a blackboard class. The cornea is like this. If I want to correct myopia, what I'll do is, I'll chop off this. This is myopia. Okay. So if I want to do hyperopia, what I'll do is, this is like this. I will try to remove this part. Now this became more curved than the rest of the cornea. This is the curvature. Compared earlier, this was the curvature. So this will be more convex. Okay, so this is what you do. So now let us say, to kind of accentuate the effect, we will create like this for myopia. Not a flat thing, just to kind of get you an idea. Now see, if this is the optic zone, now if I take this as the optic zone, it will be parallel like this. This is the optic zone, this will be parallel like this. That means if you reduce the optic zone, you can, with lesser ablation, see, all are causing the same amount of correction, because you see the curvature is all parallel. If take this is the optic zone, this is the curvature. If I take this is the optic zone, this is the curvature. That means all are correcting the same amount of myopia. But a larger optic zone is removing so much of stroma. A smaller optic zone is removing this much of stroma. That means if you reduce the optic zone, with very minimal ablation, you can correct more myopia. You got the point? Hope I made it clear. Because the curvature, we are creating parallel curvature. Larger optic zone, you have to remove more stroma for the same curvature. If it's a small, you create a small lenticule, small convexity, the same myopia gets corrected. But it will be a smaller optic zone or treatment zone. Right? So, if you reduce the optic zone, even with 10 micron ablation, you can correct one diopter. If you reduce this further, maybe with 8 microns, you can correct it. But you cannot keep on reducing the optic zone beyond a point. It should never be smaller than your mesopic pupil. If the pupil dilates in dark, if the optic zone is smaller than that, then at the edge of the treatment zone, you will have a photic phenomena. You will have starburst. You will have all kinds of, unwanted photic phenomena. So you have to know your pupil. So you have to see, at least it should be slightly more than the mesopic pupil. So for patients who have a larger scotopic pupil, you can't do LASIK in most cases, because you have to keep the optic zone more and you have to ablate more. For luckily, if your patient has got smaller pupillary mesopic pupil, you can, with a very minimal expenditure of stroma, you can correct more. Come to astigmatism. See, in astigmatism, we are actually creating a differential curvature. See, in myopia, we're just scooping it off. In astigmatism, this will be same, but we are only scooping on either side. So you require more stroma. For one diopter of myopia, if you require 15 microns, for one diopter cylinder, you will require 18 microns. That is an understanding. See, it is not sacrosanct. No numbers are sacrosanct. It all depends on the machine. It depends on the, the beam size. That's not a time, because the present machines, we have very fine beam size. Earlier we had 2 millimeter beam size. It get reduced. It became 0.8. That means you are sculpting the cornea with a finer chisel. Right? Earlier we have a big chisel. If you have a big chisel, you can't make an intricate sculpture. If you have a very fine chisel, you can. So that means with lesser and beam spot size, we are able to save more stroma. Okay. So I think you don't worry about it. Basically, what you should be knowing is what are the different, maybe we can, tomorrow is the time we can, the cornea roundup we can do. For you, I don't want to discuss anything in detail. Please have clear idea about what is LASIK, what is LASIK, what is epiLASIK, what is PRK, what is trans PRK, what is SMILE, what is C3R, what is augmented C3R, only definitions. And about latest things like endothelial keratoplasty, you should know what is DSEC, what is DMEC, what is PDEC. Just know what it means. Nothing extra. So all these newer developments, unless you have a clear idea what it is, you will not be able to write. Like there's a question on PDEC. What will you write? Can you write one page about PDEC? Okay, no. So just know what is PDEC. If you know what is PDEC, you can write all around that. वही बोलते हैं ना एग्जाम में पहले what is PDEC? I'll write. You just tell what is PDEC. So if the next person says what is PDEC, that's enough. You write half page. So that we are doing it. It's like asking the neighbor, "Oh, क्या होता है? What is smile?" बाद में लिखूंगा सब. So we are going to tell you only that much. I cannot tell the whole answer. Okay. So tomorrow we will just tell. That's why you come with your questions, whatever it is. Don't. Nothing is silly here. Everybody is in the same boat. All are equally what? Let me reserve that word. You know, you're all equally. Okay. So you can ask. Right? Equally inhibited, tongue-tied. I mean, you are hesitant to ask questions. I think this is the curse of the generation. We as children are inherently inquisitive. A child asks too many questions. Then everybody stumps it. Hey, don't ask questions. Okay, then you go to the school, you don't ask questions. Because somebody who gets up and asks a question, people say hey, he's just too smart. Huh? It's not cool to ask questions right from that age. Then it gets grounded into it. In MBBS, when we were MBBS, after the class, we would go behind the lecture asking doubts. That was supposed to be sign of meritorious people. So that was cool. Okay, even a nonsense class, we would go behind, ask question to impress the teacher or no, even find out. But now it's okay. If I don't know, it's okay. So have you any time got up in your class and asked a question? No, it's not cool. So that has got into your DNA now. Even when it's a life and death situation, even exams 1 month away, you don't want to ask a question. Look at this. When I'm saying, prodding you, say, all right, come on, yeah, tell anything, yeah, whatever I know, I'll share with you. And you don't want to ask a question. As if you know it all. I don't think. Nobody can know everything. And this stage, you don't see. I'm not saying you may know more ophthalmology than me. Okay, at any point of time. At this time, you know more ophthalmology. But I know more practical ophthalmology. And I know what is wrong in the ophthalmology, whatever you have read. Whatever ophthalmology you know, I know most of it is fake. Most of it doesn't happen. Most of it is Neanderthal, as she's telling, averting suture. It doesn't happen. There is no neuroprotection from brimonidine. Okay, it doesn't happen. There is no von Willebrand's knee in the optic asthma. See, it's fine. You live with those fake news and lies for some time. But please ask if you don't know something. Let us say I ask you something. You don't know it. Okay, you know nothing about it. Okay, you know what is Dresden protocol? So you don't know, you ask, you find out, because that will be a short note. At least know what does it mean. So like that, what is Dresden? It's a place, okay, not a person. So know something about every possible thing for next 2 months. So if you have some basic doubt, tomorrow half day we have. So we'll start with diffraction tomorrow. Then we'll have some cornea facts, and we will probably leave it open like an open house. We will discuss all these small things. We'll not go deep into anything. We'll kind of do a wrap up, and especially case presentation. I have so many facts I've seen your presentations in 2 days. There are so many tips I want to give you or observations we have made. So our postgraduates will present them. So in the process, we will try to give you some kind of a format or an idea about, how to, get rid of this case presentation smoothly. Right? I think with that, we close this day. So tomorrow, 8:30. Good night.